conduct only physical or hybrid. It is not online alone. That is why this date was fixed with keeping all other options in mind. Anyway, we have all the clinical case sessions. The case scenarios have been sent to your mail ID. I think you have gone through the cases. Volunteers for case presentations, welcome. You should volunteer yourself so that you make mistakes here, not in exams. So it will be very useful for you. Instead of us calling you, come here, better you come and sit and answer the questions asked by the senior most faculty. We have faculty from outside the university, and all senior faculties from our university will be discussing the cases. If you don't have much time to discuss, suppose within 1 hour we have to complete long cases, 45 minutes for CVS and RS. You have any doubts, anyway WhatsApp group is there. Yesterday workshop you had some queries. Definitely it will be answered from the group. Or tomorrow morning you can come around 8:30 early before the conference starts. Any doubts, that's what we used to do. Usually if there is an open house, this time because of time constraint we didn't keep an open house. So you can come around 8:30 so that you can mail the questions or WhatsApp the questions. We will be able to answer your questions, any tough question, any concepts you want to learn or reinforce any concept. We are always here to help you. It is for your exam, not alone exam and clinical experience. Definitely it will be a different experience for you. Thank you. We will start the session. Over to the comparing team.
So, a very good morning and a very warm welcome to all of you. So, today's session we will start it with a prayer song without any further delay. Please stand up for the prayer song.
विद्या विराजित करा वारिजाता अपार कारुण्य सुधांबुराही श्री शारदांब प्रणतोऽस्मि नित्यं श्री शारदांब प्रणतोऽस्मि नित्यम्
செந்தமிழைப் போல என்றென்றும் வாழும் ஸ்ரீராமச்சந்திரா என் தாயன எண்ணி உன்னை வணங்கி பாடுகின்றோம் நாங்கள் கற்ற கல்வி பெற்ற பெருமை எங்களுடையார் தந்தது ஒட்டு தொடரும் சொந்தம் இதுதான் ராமச்சந்திரா சொன்னது பெற்ற அன்னை தந்தை போலே எண்ணம் எல்லாம் நின்றது உற்ற நண்பன் சுற்றமெல்லாம் இங்குதானே கண்டது வாழ்த்தி நின்றோம் வணங்குகின்றோம் வாழ வைத்த மையமே கூடி நின்றோம் பாடுகின்றோம் வானமெங்கள் எல்லையே உலகம் போற்றும் திறமையாலே இன்று இங்கு முதலிடம் உயிரை காக்கும் உணர்வுதானே ஒன்று சேர்த்த ரகசியம் ஆய்வு செய்தோம் சேவை செய்தோம் எதிலும் கண்டோம் மனிதமே ஆய்வு செய்வோம் சேவை செய்வோம் தொடரும் எங்கள் பயணமே ஸ்ரீராமச்சந்திரா வாழ்வதே
We welcome Dr. Sai Gayatri, final year PG of General Medicine, Dr. SRMC, to present the first case.
We'll start our first session, that is a case of pleural effusion. So by the postgraduate is Dr. Gayatri. We welcome onto the dais the moderators Dr. Rajashekaran and Dr. Rajkumar. Dr. Rajashekaran is an eminent physician in Chennai and he's an alumni of Madras Medical College where he has done his undergrad and diploma in chest medicine. He has done his post-graduation in general medicine from Kilpauk Medical College. With over 35 years of experience presenting, authoring and publishing several papers, Sir has got the award for the best correspondence in JAPI, has got the prestigious award for best teaching in 2015, and also he's been the current member of the Chennai Bioethics Unit, chaired by the UNESCO. Sir, we welcome you. Next, we have our very own Dr. Rajkumar sir, Professor and HOD of General Medicine, Sri Ramachandra Medical College. He has done his MBBS from Madras Medical College, Chennai, and MD in Internal Medicine from Sri Ramachandra Medical College. Sir has also done a diploma in diabetes care from the University of Newcastle, Australia. He has an MBA in Health Services Management from Anna University. With over 15 publications and a work experience 23 years, he has also edited a monograph titled Treatment Protocols of Common Medical Outpatient Conditions. A very warm welcome to both of you, sir. We'll start our first session.
Good morning, everyone. Thank you very much, Dr. Emmanuel and the team for inviting me. I'm coming here after 2 years. I'm seeing the students after 2 years. It's a big gap. I don't know how I'm going to catch up. Right, anyway, right? You all had this experience of facing at least the students. We never had at all. So thank you very much. Now I'll be interfering then and there. Okay? You don't mind, no?
Good morning to you. Good morning to you all. Am I audible? Good morning to you all. I would request some volunteers to come forward so that you can take up the questions. Why? You've got to face your exams, isn't it? From all the colleges, right from Ramachandra, MMC Stanley, CMC, Chettinad. Where is Priya's sister? Priya's sister saw me yesterday. Where is she? From, she's not come still.
Volunteers, please come forward.
Start, Gayatri.
As I told you, you should volunteer yourself. Now come and make all mistakes. You will know 90% of the questions. When you come and answer, you definitely have a very good experience. This type of opportunity you will not get. Don't be afraid. Nobody is going to do anything. Even if you don't know the answer, also no problem. You will never forget that answer in future. Come. I will help you, come. I'll tell the answers, come. I'll tell you the answers. I'll help you with the answers, come.
If possible, give us one table.
Come. Sit. You'll answer well.
Okay, Gayatri, you can start now.
Good morning, one and all. I'm going to start with my first presentation of SRMC MEDICLINICS 2022. A 70-year-old female patient who is a homemaker by occupation from Chennai. She came with the chief complaints of right-sided chest pain since 3 months, cough for 3 months, and shortness of breath for 2 weeks. History of presenting illness. Patient was apparently normal 3 months back, after which she developed complaints of right-sided chest pain, gradual in onset, pricking type of pain, intermittent, increased with deep breathing. There is no radiation of pain, there is no postural variation of pain. Complaints of cough since 3 months, gradual onset, associated with minimal expectoration, white in color, mucoid, non-foul smelling, not associated with hemoptysis. Cough increases in the night time. There is no postural variation and there is no aggravating and relieving factors. Complaints of
One minute.
Sir.
Now you told me chest pain right side.
Yes, sir. Yes.
Now what was the site of the pain? Don't you think the site of the pain is very important?
Yes, sir. Right side infra-axillary area, right side lateral chest pain is there, sir.
So what are the characteristics of a pleural pain? Does it look like a right side pleural pain?
Yes, sir. Right side pleuritic type of chest pain.
So what sort of a pain you get in pleurisy?
Stabbing or pricking type of pain, sir.
So pricking, is it?
Yes, sir.
So pricking, we usually say it occurs from the skin or superficial structures like muscles.
Okay, sir.
Right? So we say classically it is stabbing.
Stabbing type of thing.
If you say pricking, I will take that is only superficial. Then the second question is, so it is in the lower chest?
Yes, sir. Right side lower chest.
Right lower chest. Why is it the pleural pain is always at the lower chest? Why is not in the upper chest? You don't know anyone know the reason for that?
Dependent position, pleural fluid collection is.
If the pleural fluid corrects, there will be no pain at all.
Yes, sir.
The two layers of the pleura are separated. Anyone? Volunteers?
Which is a pleura which, pleural layer is pain sensitive?
Parietal pleura.
Why they don't have it initially? Is there some fluid which is there which prevents the pain?
Minimal pleural fluid usually.
So that is a lubricant which is going to be there, which will prevent the pain. So when will they have pain? Can you just hand over the mic so that it be audible for everybody?
When the parietal pleura is inflamed, there is a friction which occurs between the parietal and visceral pleura, leading to this pain. Yes, sir.
So the two layers of the pleura are separated at the apex compared to the lower. The lower chest, they are very closer. That's why you don't usually get. No, you may get. It's not 100%, but usually you don't get it. Because the two layers are more distantly separated in the upper lobes than in the lower lobes.
Okay.
Yes.
Sir. Complaints of shortness of breath since 2 weeks. Gradual in onset, initially grade 2 MMRC, progressed to grade 4 in the last 1 week, sir. There is no history of orthopnea or PND. There are no aggravating or relieving factors. There is no history of fever, evening rise of temperature or night sweats. There is no history of loss of weight or loss of appetite. No history of wheeze. There is no history of bilateral lower limb swelling. No history of abdominal distension or right hypochondriac pain. There is no history of palpitations or syncope. There is no history of decreased urine output. No history of hoarseness of voice or dysphagia.
Gayatri, wait. Maybe we can have some questions here.
Yes, sir.
No, why is there hoarseness of voice and dysphagia? Why did you ask for that history?
Sir, any lung malignancy can infiltrate the laryngeal nerve and cause hoarseness of the voice and dysphagia.
Okay, why bilateral lower limb swelling did you ask for?
Sir, to rule out cor pulmonale, sir, right heart failure, so that is why I've asked bilateral lower limb swelling, abdominal distension and right hypochondriac pain, sir.
Okay.
So, any cause for anasarca, not necessarily cardiac failure.
Yes, yes.
So here in respiratory, it is more of a right-sided failure which is going to cause this thing, and in case if there is a lot of cough, expectoration, all these things, there is a lot of protein loss which can also be there, which can cause a lower limb edema, which can be there, which can happen.
Yes, sir.
Go ahead.
Sir, trypopnea?
Sir?
Trypopnea.
Trypopnea.
What is trypopnea?
Late,
Now, in a patient who is going to have a pleural effusion, which side, if he lies, he will be more comfortable? The affected side or unaffected side?
Unaffected.
Lies down on the unaffected side, he'll get more breathless.
Yes.
Yes.
Okay, because of the restriction of the whatever respiratory reserve what he's having.
So there is a collapse which is happening on that side, and is also pushing the mediastinum to the opposite side. And the patient lying down to the opposite side, when it is there, it will restrict the lung to expand. So they will feel the breathlessness which is going to be there.
Yes.
Continue.
Patient initially went outside hospital where she was evaluated and she was told that she has a fluid collection in the lungs and tapping has been done, and patient has been started on TB treatment based on the fluid analysis, and patient was discharged home. After 2 to 3 days of discharge, patient had worsening of shortness of breath and patient presented to the SRMC.
So what could be the cause for aggravation of the symptoms after a pleural tap?
So could be recollection of the fluid.
Thorax after the pleural effusion tap.
She said pneumothorax. Don't you expect the pneumothorax to be immediate? It occurred after a few days. It is not occurred immediately after
post-procedure expansion pulmonary edema.
Possible, yes, expansion. But it should be acute,
Yes.
She says 2
3
days.
days.
Okay, is there any other causes where immediately after you remove a large quantity of fluid, patient becomes breathless? Apart from pneumothorax, is there any other cause which can be there? Agreed. That is a mechanism. What is there? There is a pulmonary edema, flash pulmonary edema, which could also happen, which can cause sudden breathlessness when a large amount of fluid is removed. Here it is after 2 to 3 days, isn't it?
Yes, sir.
Okay.
So what does it suggest to you?
Sir, a reaccumulation of the fluid, sir.
So rapid recurrence is there.
Yes, sir.
What is it suggestive of if a patient is going to have a rapid recurrence of a fluid after tapping?
What are the causes? Sir is asking what are the causes which could be there.
Could be malignancy, sir. Could,
Then?
heart failure, but not in this case, sir. The general causes like could be malignancy, heart failure causes recurrent pleural accumulation, sir. And
Any other thing which can be there?
infections.
So infections can be there. Then, though not that fast, connective tissue disorders also, there can be a recurrent effusion which can happen.
Rheumatoid arthritis and SLE, connective tissue disorders are also associated
Can also
with recurrent,
happen. Okay.
recurrent effusions.
How much of fluid should be there in a pleural cavity to cause a breathlessness?
More than 1 liter of fluid, sir, can cause rapid expansion of the underlying lung and cause lung injury.
Yes. Anyone else?
Should involve at least 2 lobes of the lung on one side to cause breathlessness.
See, that is one way. Yes. Anything else?
Can you quantify and tell us?
To cause breathlessness, sir,
Yes.
so 500 ml.
No, it doesn't depend upon the quantity. Depends upon the rapidity at which it occurs. That's more important. Doesn't depend. See, if it's going to slowly occur for 1,500, 2,000 also, it won't produce breathlessness. The rapidity at which it is going to occur is going to one which is going to produce breathlessness.
Just like the pericardial tamponade which is going to happen, it is very fast. Whereas in a case of pericardial effusion secondary to hypothyroidism, you can have a huge heart, still they may not be that breathless as rapid as in pericardial tamponade. But when will you say mild, moderate, severe, anything to do with the effusion, with the quantum?
That's will be with the clinical examination.
Okay, sir. We'll take it later.
Past history, there are no previous comorbidities, no history of tuberculosis or contact with TB positive patient. Husband is a smoker, sir. Personal history, sleep is disturbed because of breathlessness, normal appetite, regular bowel and bladder habits. Family history, patient's sister died from lung malignancy, sir. Treatment history, patient was on TB treatment from April 1st to April 11th, so 10 days of ATT in the outside hospital. Surgical history, bilateral knee replacement surgery was done 8 years back for bilateral osteoarthritis. Post-menopausal, sir. History summary, 70-year-old.
Gayatri, did you ask for an occupational history, which was there? She's a homemaker.
She's a homemaker, sir.
Okay, how important it is for us, especially when we are thinking of a malignancy, how this becomes important to us? Something to do with occupation?
Sir, occupational asbestos exposure can cause mesothelioma and lung malignancy, sir. And
okay, fine. Go ahead.
History summary, 70-year-old female patient with no previous comorbidities presented with complaints of right-sided chest pain and cough for the past 3 months and progressive shortness of breath for the past 2 weeks with history of lung malignancy in the family. I'm thinking of pleural pathology, sir, unilateral pleural pathology, thinking of pleural effusions. General examination, patient is conscious oriented, well built and well nourished. There is no pallor, icterus, cyanosis, clubbing or lymphadenopathy or pedal edema. Ecmotic patch present over the right supraclavicular region. Vitals, pulse of 130 per minute, regular, normal volume, no specific character, no radio-radial delay, no radio-femoral delay. All peripheral pulses are felt. BP is 120/70. Right upper limb in the supine position. Temperature is 98.6 degrees Fahrenheit. Respiratory rate 28 per minute, no specific rhythm. Abdominal, thoracic. Axillary muscles of respiration are in use. SpO2 is 99% with 2 liters of oxygen. JVP is not elevated, sir. Vitiligo patch are present over the
Yes, proceed.
bilateral lower limbs since 20 years. She's attributing it to the drug reactions 20 years back, sir. She's not sure with the clear history. There is no external markers of tuberculosis or no features of cor pulmonale.
What are the JVP abnormalities you can in a respiratory system?
Sir, in acute severe asthma, there is a fall in during inspiration.
Fall in jugular veins. Severe asthma. What are the JVP abnormalities you can have in respiratory disorders?
Cor pulmonale can have a wave elevation, sir. JVP elevation will be there. Cor pulmonale causing the right heart failure.
Okay.
Pulmonary artery hypertension also, JVP elevations will be there.
Good. Yes? So always when you say JVP, right? First you say about the pressure.
Okay.
Now the pressure is elevated, but there are no waves. What are those conditions?
So
The JVP is elevated, but you don't see the waves. What are the
superior
conditions?
vena cava obstruction, sir. Malignancy
Yes.
causing. In
Anything else? Right, chronic obstructive airway disease. Yes. Then what happens to the A wave? As you said, A waves are prominent whenever there is going to be pulmonary hypertension. You said what are the conditions in which A wave will be prominent? One, as you said, cor pulmonale.
Cor
Yes.
pulmonale and
Can A wave be absent in respiratory disorders? Yes, chronic hypoxia can produce atrial fibrillation. You can have irregular heart. So atrial fibrillation can occur. A wave may be absent. What about the V waves? Yes, any cardiac failure or cor pulmonale with cardiac failure, you have a V waves prominent.
not.
So what is Kussmaul sign?
And rapid shallow breaths and we are observing.
No, that is Kussmaul's respiration. I am talking about Kussmaul's sign.
Normally during inspiration, there will be negative intrathoracic pressure, and then JVP will be right, sir. But in Kussmaul sign, we can see in case of any tension pneumothorax.
No, JVP will be elevated during inspiration or decreases.
In inspiration, there will be negative intrathoracic pressure.
Yes, so?
And then blood filling will be there, so it will fall.
Right.
But in Kussmaul sign, it will be elevated, sir.
What are the conditions and respiratory conditions which can produce that?
Tension pneumothorax, acute severe asthma.
Yes. COPDs, right?
COPD.
Acute severe asthma and tension pneumothorax. Yes. Good. Yes.
Systemic examination, sir. Respiratory system examination, inspection, upper respiratory tract, nose examination, normal, no nasal polyps or DNS, deviated nasal septum. Oral examination, dental caries are present. Trachea appears to be in midline. Apex beat is not visible.
How does trachea help in your diagnosis? Position of the trachea, how does it help in your diagnosis?
In case of mass occupying lesions like pleural effusion or lung malignancy, there will be a shift in the pleura to the opposite side, sir. In case of fibrosis and lung volume loss, there will be a shift in the trachea to the same side, sir.
Okay, but whenever you say about pleural effusion, you should always say a massive pleural effusion shifts the trachea. There can be some minimal pleural effusion or say 250 to 500 ml. If it is going to be there, the trachea may not be shifted. It is only probably the apical impulse will be shifted if it is going to be there. If it is going to be, so massive pleural effusion. Name some conditions where there is an effusion, but still the trachea is on the same side. Can one of the volunteers take this question?
Malignant effusion, sir.
Yeah.
Because the trachea is fixed.
Endobronchial tuberculosis also will have the same, like without shift it will be there, no sir, with the effusion as well as
Minimal thing which is going to be there, minimal effusions, okay. So underlying, if there is going to be a collapse or a fibrosis which is already there, then like mesothelioma causing, then it can be on the same side which can be there.
Chest wall is bilaterally symmetrical, sir. Shape is normal. Chest movement is decreased.
How is chest wall abnormalities? What does it do with respiratory system? What problems can be there?
Sir, in case of lung volume loss like fibrosis, there will be a atrophy of the one side of the lung. So there will be asymmetry of the lung. And in case of effusion, there will be intercostal fullness of one side if it is a unilateral effusion, sir. And in case of any spine abnormalities or sternal abnormalities like pectus excavatum, kyphosis or scoliosis can lead to restrictive lung diseases, sir.
Okay. Straight back syndrome, all these things lead to restrictive lung diseases which can be there. So it is a skeletal abnormality leading on to a lung problem pathology, or it could be either way from a lung problem leading on to the abnormalities in the chest where there is crowding of ribs and all these things can happen with fibrosis or, okay, go ahead.
Chest movement is decreased on the right side. There is no shoulder drooping, no supraclavicular or infraclavicular hollowing. There is no rib crowding, sir. Spine, no kyphosis or scoliosis. Thoracocentesis puncture mark is present in the right sixth intercostal space in the interscapular area. There are no sinuses or no engorged veins. Palpation, position of trachea is in midline. Apex beat felt in the left fifth intercostal space on the midclavicular line. Chest measurements, AP diameter is 26, transverse is 32 centimeters. Chest circumference is expiration 108 centimeters, inspiration 111. Chest expansion is 3 centimeters. Right hemithorax of 1 centimeter, left hemithorax 2 centimeters. Chest movement is diminished in the right infrascapular and mammary areas.
So what do you infer from this?
Sir, based on decreased chest movement and decreased chest expansion on the right side, I think of unilateral lung pathology, sir.
So what are the pathologies which can be unilateral, which can lead to decreased chest movements, which could happen?
Pneumonia can, pneumonic consolidation, pleural effusion, unilateral fibrocavity.
Yeah, unilateral fibrosis when it is going to be there, pleural effusion, pneumothorax, all these things can be there. But okay, pneumonia, I'm not very sure whether it can
decrease movement on the.
Okay.
Now, you say the trachea is midline.
Yes, sir.
No, trachea is midline, and there is a diminished. The diminution, right, infrascapular and mammary areas.
Yes, sir.
Right? So
yes.
Patient has got breathlessness also.
Yes, sir.
Right? How is that in spite of all this, the patient has got a trachea which is not shifted? So if you are thinking in terms of a pleural effusion,
yes,
that was your diagnosis with your history.
Yes, sir.
Now how is that you say the chest movements are diminished only in right infrascapular and mammary areas? Right? That's what you say.
Yes, sir.
So, and you say the tracheal position is also in the midline.
Yes, sir.
Now, right, does it go with your pleural effusion or something else?
Sir, in case of, usually in case of pleural effusion, patient is breathless and decreased chest movements. We expect a trachea and mediastinal shift, sir. But with pleural effusion, without midline shift, could be a underlying collapse, like any bronchogenic carcinoma that is causing collapse, lung collapse associated with pleural effusion won't cause the tracheal shift, sir.
Yes. And how about this? That can be a pleural effusion which is starting organizing, right? Organizing pleural effusion can also, right, prevent the trachea being deviated. Now, presentation, she presented that there were right supraclavicular glands.
No, sir. Only.
I mean, sorry. Yes.
No lymph nodes, sir. Only ecmotic patch was there in the right supraclavicular area.
Go back.
Go back. No, but here it is not there. The thing in which she sent, it was there.
I couldn't feel the lymph nodes, sir, I thought.
I could feel some few lymph nodes there. Yes, it was there. So
I was a little doubtful about the lymph nodes, so that is why I've changed it.
Now, if you are going to say there are lymph nodes, then it explains you why the trachea is in the midline in spite of a pleural effusion. Right? What do you think? Why is that the right lymph nodes, or right side lymph nodes are there?
Right side lung drains into the right supraclavicular lymph nodes. So, malignancy spread can cause right supraclavicular lymphadenopathy, and tuberculosis infection can cause right supraclavicular lymphadenopathy.
So, now
in this
you are
case,
not you are not sure of the lymph node, right? That's what you said,
yes.
right? If it's going to be rubbery, what will you think?
If it is hard and fixed, I think of malignancy, sir. If it is rubbery and matted.
Rubbery is different, matted is different.
Matted, I'll think of tuberculosis, sir. Hard and fixed. Rubbery, I'll think of malignancy, sir.
What malignancy?
What lymphoma?
Give the answer.
NH.
Should be a lymphoma, right? When there is a lymphoma, automatically, right, your bronchus gets obstructed because of the external pressure. It can produce a collapse, and the patient may have tracheal deviation to the same side in spite of a pleural effusion.
Yes, sir.
Yes.
What is the mechanism of this pleural effusion, this malignancy? You are suspecting a malignancy here, and if there are lymph nodes, what is the mechanism of pleural effusion?
In other words, he is asking what are the mechanism by means of which you can have a pleural effusion in malignancy. Is it transudate, exudate, or both?
Exudative, sir.
Right.
Malignancy, exudative.
Now,
effusion.
if it is going to be exudative, what is the mechanism? If it is going to be transudative, what is the mechanism?
In case of transudate, whenever there is a decreased oncotic pressure in the plasma, in the blood.
Why should there be a oncotic pressure go down in plasma?
Sir, in case of hypoproteinemia, hypoalbuminemia,
Okay.
nephrotic syndromes,
Okay.
and cirrhosis of the liver, hepatic hydrothorax.
We are thinking of a malignancy producing transudate and exudate. We are not asking about the causes. Okay? Now you said hypoproteinemia can produce. Yes. What are the other ways by means of which you can have a pleural effusion in malignancy?
Regularly means there is hydrostatic pressure, oncotic pressure, all these things we say, but especially in malignancy, what happens?
So pleural metastasis can cause.
Yeah, that is there.
How it is causing? That's what he is asking. Yes.
Obstruction to lymphatics.
Obstruction to lymphatics.
Yes, that's the most important, right? Yes, anything else?
So reactive collection for the malignancy, sir.
Yes, malignancy itself can produce excessive fluid, right?
Direct involvement of the pleura.
Yes?
Direct involvement of the pleura,
yes,
sir.
that can produce exudate, yes. Then, anything else? Yes, anything else? So, when there is a collapse, naturally the space which is left over will be filled up only with the fluid. Right? So, it could be lymphangitis, right? We call it as a lymphangitis carcinomatosa, right? Or it could be because of the lymph glands, right? Or it could be direct, or it could be hypoproteinemia. See, these are some mechanisms by means of which you can have pleural effusion in malignancy.
Okay, sir.
Go ahead.
ocal fremitus is decreased in the mammary area, infraaxillary area and infrascapular area, sir. Other areas it is normal, sir. No tactile or frictional fremitus. Percussion.
No, I would like to know whether it is or absent. There is a difference between decreased and absent.
Sir, decreased, sir.
No, what is the difference between decreased and absent? If it's going to be absent, what will you think? If it's going to be decreased, what will you think?
Sir, ocal fremitus, if it is decreased, we think of pleural effusion, sir. And
I'm not agreeing. That's why I'm asking you this question.
because of the increased.
What will happen to the breath sounds?
Breath sounds will be decreased or
In case of
absent.
pleural effusion, what will happen to the breath sounds?
Diminished or absent breath sounds, sir.
So this is decreased or absent. Now vocal fremitus. See, because the lung is separated off from the chest wall, right?
Yes, sir.
The vibrations produced by the vocal cord is not transmitted. So you must have an absent. Unless you are going to say, I'm going to palpate just above the pleural effusion, where there can be some amount of relaxed lung which can produce decreased. Okay, I expect it to be absent. Unless, as you said, if it is going to be up just above the effusion, you can have a decreased. When you are committing as a pleural effusion, it should be absent.
Okay, in case you have mentioned it as absent, decreased, absent in the level of pleural effusion. Just above the level of pleural effusion, sometimes there can be an increased vocal fremitus and increased vocal resonance.
Yes.
What is the mechanism?
Sir, because of the underlying collapsed lung with the patent bronchus, so that can cause an increase in vocal fremitus and vocal resonance.
Yeah, that can increase the vocal fremitus, vocal resonance, and that can be a bronchial, breath
Breath
sounds,
sounds
egophony, all these things. One mechanism is that. Another mechanism is that there is a compensatory emphysema also, which is happening in the lower zone, whichever is there. So both these things, maybe you will have to tell. What you said was the first reason. That is the most important thing. Second, additionally, you can also say this.
Yes.
Percussion, there is stony dullness in the mammary, infraaxillary and infrascapular areas, sir. Other areas it is resonance.
What did you say about the clavicle? How do you percuss? Direct percussion.
Direct
Okay.
clavicular percussions.
Chronic systems. Yes?
Sir, tidal percussion, dullness still persists after deep inspiration, sir. Drop space is resonant, shifting dullness is negative, straight line dullness is negative.
Now, this curve.
Ellis curve.
Yes, what is Ellis curve?
In axillary area, it's a radiological.
No, it's clinical. I do agree. Radiologically, it's okay.
In the axilla, the fluid will be high up when compared to the anterior and posterior regions of the chest walls.
Okay.
So
Why?
it is because of the capillary suction action between the two layers of the pleura.
Yes, that's exactly. Now, why is that it is important?
So in case of hydropneumothorax, the Ellis curve won't be there, so it will be a straight line dullness.
If you have seen an Ellis curve, one need not look for a straight line dullness and shifting dullness. That's important. So you are not mentioned about the Ellis curve, but you are mentioning about the shifting dullness and straight line dullness. That's why.
Vocal resonance is decreased in the mammary, infraaxillary and infrascapular areas, sir. Other areas it is normal, sir. Air entry is diminished in the mammary, infraaxillary and infrascapular areas, sir.
It's only diminished, it's not absent. Huh? No, I thought it was absent. Right, okay. Yes? Now, what are the other things you will find out, right? Because you have found out that the patient has got a pleural effusion.
Yes, sir.
And you are thinking that the patient has got a no tracheal deviation.
Yes.
In fact, when be on the right side line.
Yes.
There on the right side, where they have tried a biopsy.
Yes,
right?
biopsy, yes.
Right? Needle biopsy probably
Yes,
they've
sir,
tried.
yes.
Okay. So what are the other things you look for? You were there 11 a.m. examining.
Yes, sir, I was.
All right. What is that I was looking for?
Bronchophony, egophony, sir, and egophony,
Right? Go funny.
sir.
Yes. But I don't know whether it is changed. Today it is little higher up. It's not only mammary and infraaxillary, it is going up to the second space. Right, okay. But probably it is increasing more now.
Repeated collection, sir. Repeated tapping
Right,
has
okay.
been done, sir.
Now, anything else I was looking for? There is a gland. I'm giving you a clue. Yes, anyone think of a malignancy, especially a lymphoma, right? Any other maneuver I'll try to do to confirm whether there is a mediastinal mass. Yes, I'm given an extra clue. Huh?
And causes tumors.
Yes,
Whispering
for
to
that you should have looked for a harness, right?
Egophony.
Scalene lymph node.
Huh?
Scalene nodes.
No, the lymph nodes are there. Why should I look for a scalene? It is obvious.
Thymus.
No, thymus I cannot palpate. Huh? What is D spin sign?
Sir, below the level, posteriorly below the level of D3 spine, there will be a bronchial type of breathing, bronchial.
Yes, this patient has a D spin sign. Right from the third space up to seventh, right, vertebra, the patient got a D spin sign. So that's very, very important. Not that you are going to be penalized if you don't find that. If you are going to get that, right, it will fetch you more marks.
Definitely.
Especially when you said they tried a biopsy. They won't do a biopsy and just like that. All right? Probably there were glands. Okay. Proceed.
Because we're running short of time, slightly be fast.
So other system examination is normal. CVS S1 has 2 Hz, sir. Per abdomen soft. CNS no focal neurological deficit, no flaps, sir. Final diagnosis, sir. Unilateral pleural pathology, right side pleural effusion with signs of respiratory distress with no signs of cor pulmonale. Differential diagnosis, right sided pleural effusion, probably malignancies.
Okay.
With metastasis to the lymph nodes.
Okay, how will you investigate this person?
Sir, first I'll go with all the routine investigations, sir. All the routine blood investigations, blood picture, renal function and liver function, and ECG and X-ray, sir, chest X-ray, to look for the effusion, and pleural fluid tapping and analysis, sir. Pleural fluid total count, differentials, sugar protein, and ADA, LDH levels, and cytology to look for malignant cells, sir. CT thorax.
Okay, in case if it is a drug-induced pleural effusion, how will it help? Cytology help?
So increased eosinophils will be there in the pleural fluids.
So name some drugs which can cause pleural effusion.
Nitrofurantoin, dantrolene, sir, bromocriptine, and amiodarone, sir.
What are the other causes for eosinophilic effusion?
So parasitic infections, tropical eosinophilia, tropical pulmonary eosinophilia, and
Most common.
malignancy can also be there, sir.
Any condition where the blood or air is going to be there in the pleural cavity.
So hemothorax or hemothorax or.
Okay, Light's criteria.
So pleural fluid, it is used to differentiate whether it is a transudate or exudate, sir. Pleural fluid by serum protein of more than 0.5 or serum pleural LDH by serum LDH of more than 0.6 or pleural fluid LDH more than 2/3 of the upper limit of normal LDH in the serum, sir. So that goes in favor of exudate, sir.
Okay. And then
Yes, proceed. This is only extra.
Okay. In case of malignancy, mesothelioma, any other investigations can you think of?
So pleural biopsy can be taken. So pleural biopsy can be taken and sent for histopathology and cytochemistry.
Now all of you know the Light's criteria,
Yes.
right? What is Light's index? So this is your homework. You go and see that. Thank you.
Thank you, sir.
Thank you, Dr. Gayatri. We thank Dr. Rajkumar sir for chairing the session. Next, we'll have the second session. The session will also be chaired by Dr. Rajashekaran sir. We also welcome Dr. S.R. Ramakrishnan sir, Professor of Medicine, Srihar, to come to the dais for the second session. We welcome Dr. Shravanti and Dr. Ravi Kumar, final year postgraduates, Sri Ramachandra Medical College, to come to the stage to present the second case. Dr. Rajashekaran sir is an eminent physician from Chennai. He has done his UG and PG from Madras Medical College. He did his general medicine from Keelpark Medical College, Chennai. He has over 35 years of teaching experience in premier institutes like Madras Medical College and Stanley Medical College. He has published multiple papers and in multiple international and national conferences, and multiple textbooks have his publications. He has been awarded the Best Teacher Award by Stanley Medical College. He is the chairperson of Chennai Bioethics Unit of UNESCO Chair in Bioethics. We welcome Dr. Ramakrishnan sir, Professor of Medicine at Srihar. He is an alumnus of Stanley Medical College, both at UG and graduate level. He is the current president of IMA Porur branch. He is a lifetime member of API and IMA. He has 20 publications in various reputed journals and was part of 4 clinical. So we will begin the second session.
So, good morning.
Good morning, one and all. I am honored to be with my teacher, Dr. Rajashekaran sir. He was my mentor in Stanley Medical College.
It's a great pleasure to sit with a student and chair a session.
We'll start, sir. Good morning, everyone. This is Shravanti, final year postgraduate from SRMC.
Students, anyone else want to?
A 40-year-old male who is an electrician by occupation resides at Porur. He had an alleged history of fall from a height of 35 feet after sustaining an electrical injury to his right hand 13 years back. After which he sustained a neck to his neck, followed by a brief history of loss of consciousness for a few minutes. Later, when the patient regained the consciousness, he noticed neck pain and band-like sensation in the upper part of chest, below which patient had complete absence of sensations and movements of both upper and lower limb.
Now I have a question.
Yes, sir.
You are listening to what I was asking the patient. Now, do you think the electric shock has these problems, or the trauma which he sustained is giving the problem?
Sir, since post-electrocution, sir, since he is in contact with the high voltage current, he can be falled away few meters away from the site. So chances for him to get a fatal injuries are very high, sir. So it could be post-electrocution rather than a direct fall.
No, but you say this is because of the way in which you are presenting. Appears to me that you are giving importance to the injury rather than electrocution, right? Now, what is your choice now? Is it an electrocution or it is an injury?
Electrocution more than an injury.
Electrocution more than injury, right?
Yes, sir.
So you are going to discuss in that way. Well, let me see. Okay, we'll see.
We have injury, fall from height 35 feet. Which part of the structure is more vulnerable to this injury?
Cervical spine, sir.
Why is it? What is the reason?
So it's a highly mobile part of your spine.
So one is highly mobile, has no support with the ribs. Then
And it is not, it doesn't have any support from the rib cage, sir.
That is one reason. Then,
And there are cervical bulges also, sir.
so it is supporting the skull, number 2. Then,
Spondylosis.
the spinal cord is uniform throughout its course.
No, sir. In cervical and lumbar area, there will be bulges, so they are more prone for the
So these are the
injuries.
three mechanisms why neck is more often injured. Because it is solitary, doesn't have support of the rib cage, it is supporting the skull, and there is a cervical enlargement which starts from C3 to T2. Yes, proceed.
Now, you say but patient has a band-like sensation in the upper part of the chest. How do you explain this?
Band-like sensation, sir.
He had an injury to the neck.
Yes, sir.
But the band-like sensation is over the chest.
Upper part of chest. So band-like sensation is because of the involvement of posterior column, sir.
Yes.
And it is far away from the site of the lesion which is expected, because in a stage of spinal shock we can't exactly determine the, we can't exactly localize the illness, sir. It can be even far away from the site of injury.
No, spinal shock is different. No, band-like sensation means the patient has definitely he is having a sensation which he is able to appreciate. Yes? Any other? Yes? Any other?
Please,
Yeah?
could you clarify the question, please? I'm not
The
able to.
patient had a neck injury, but he has a band-like sensation in the chest. How do you explain that? If he has a neck problem, as she said, if she's going to have posterior cord involved there, right? The patient should have band-like sensation in the neck, not in the chest. Now, how do you explain that? That's my question.
Sorry, injury over multiple levels of the cord.
No, now with the history, we'll come to that later. Now with the history, with the neck pain, with the neck injury, but the patient got a band-like sensation. So what is watershed? Heard of watershed?
Yes, sir.
Watershed area. That is why the neck, which has produced a vascular problem, possibly, it is producing a band-like sensation in the chest. This is how you can explain.
What is Lermite sign and reverse Lermite sign?
So Lermite sign is seen in multiple sclerosis, sir, demyelinating disorders, where forward flexion will cause electric shock-like pain, and reverse Lermite sign is seen in cervical spondylosis or other cervical pathology, where because of posterior column involvement, he will be having an electric shock-like pain in extension of neck.
So Lermite sign is seen in demyelinating disorder, whereas reverse Lermite, that is reverse extension, is seen in compressive lesions. Both are different. Yeah, proceed.
Post-fall, patient had loss of consciousness and there were no history of any seizures. He was taken to the local hospital where he was intubated in view of low GCS. Patient was catheterized and about 1.5 liters of urine was drained. And he was on mechanical ventilator support for 48 hours and was operated 74 hours after hospitalization.
So why did he have a loss of consciousness? What do you attribute it for?
So there could be an associated head injury also, sir, so because of the fall, that can explain loss of consciousness.
But he recovered on his own, illa?
Yes, sir.
Yes? So vertebrobasilar involvement, because the neck, that is one. The second one is the shock itself, electrocution. So that is why I am trying to bring in a shock more than your cervical spine injury. Okay.
What is Lazarus sign?
No idea, sir.
So it is seen in brain. When you have injury, patient has a overflexion. When you notice signs soon after the fall, that means it is indication of brainstem death. Proceed.
Post-operative period, patient regained consciousness one day after the procedure. Speech was normal and there was no associated breathlessness. Patient was able to lift the head off the bed and able to shrug the shoulders, but unable to move both his upper and lower limbs and unable to roll over the bed. Patient had complete loss of sensations below the shoulder and had history of fecal incontinence.
Yes, proceed.
Present status, there is no improvement in the power over the next few months, following which with the regular physiotherapy, there was gradual improvement in the power in the upper limbs, proximal more than digital. So now he is able to shrug the shoulders, able to lift the head off the bed, and is able to lift his arm above the shoulder, but unable to hold the objects in both the hands, unable to move both his lower limbs, and unable to roll over the bed.
Has the proximal muscles have improved?
Yes, sir.
And the distal muscles have not improved.
Not improved.
So what are the tracks which involved in proximal muscles and what are the tracks which involved in distal muscles?
Sir, in corticospinal pyramidal kind of weakness, usually digital muscle weakness will be more predominant.
The tracks, ma'am. So proximal muscle, what track is concerned primarily? Which controls the proximal muscles predominantly? Which track? Which track controls the distal muscles predominantly? All are motor tracks only.
Yes, sir.
Some will control postural muscles, some will control the peripheral muscles.
Sir,
so corticospinal, as you said, it controls more the distal, you'll have more distal weakness
digital
or proximal?
weakness. Digital weakness, sir.
What is the other track which is concerned with the distal weakness?
Sir, other track with the
Rubrospinal. So these two tracks are concerned with the distal
weakness.
Proximal muscles, which tracks are involved?
Vestibulospinal and reticulospinal
These
tract.
two muscles are concerned with the proximal muscles.
weakness.
So according to your history, he has more distal weakness. That's the impression you are giving.
Weakness. Yes, sir.
Yeah, proceed.
Sensory history, patient had band-like sensation in the upper part of chest which has gradually decreased since the injury. Patient is now able to feel the clothes, able to appreciate the pain and able to discriminate between hot and cold water over the upper part of the body till umbilicus, but not to the extent as he appreciates over the face. Autonomic history, patient complains of decreased sweating below the shoulder. Post-trauma, patient had
Sir,
loss.
1 minute. Now in the history, why is that you are talking only about the power? What about the tone? How does he feel the limb as? Is it a flaccid limb or stiff limb? I was asking him.
Yes,
he
sir.
said it's flaccid in the upper limb. He is not able to say about the lower limb. And second thing is, what about the muscles? Right? Does he has developed a deformity or he has got a thinning of the muscles? Is there a fasciculations? All these things are very important in localizing the signs. Right? So you were listening. What was he telling?
He is saying that in upper limbs he is having flaccidity.
Yes.
Like tone is low. In lower limbs he is having numbness. He is unable to feel his lower
Tell
limbs.
that, yes.
Yes, sir.
Anything else? He was talking something. Fasciculations. He was complaining of fasciculations, especially in the
Upper part of chest.
upper limb, right? Especially the arm. Yeah? So,
So at the level of lesion we have an LMN localization, sir. So at the level of lesion we have atrophy and fasciculations. Below that we have UMN features.
right. Okay. Now it should be in the card or it could be outside the card also. It could be brachial plexus or it could be a plexopathy, radiculopathy or it could be a neuropathy. Right? Now that's very important. Right? Now, if you are going to talk about the deformities and the patient is going to complain of a fasciculation, then I will not think of a card. I will think of radicals, roots. Then I will think of peripheral nerves. Yeah? So, history is very, very important. Once you take a good history, you need not examine at all. All that you got to do is only confirm whatever you are feeling like. Yes.
Can you have a cord injury without long tracks involvement?
Only Greyhorn involvement.
It's possible or not possible?
Yes, sir, it's possible.
So what is it called?
Central cord syndrome.
So what is any particular syndromes?
Schneidner syndrome is the one which...
Schneidner syndrome. So particularly whiplash injury, when flexion of the neck, you will have only element findings and particular level. You don't have long track signs. That is known as Schneider syndrome.
No, in whiplash, is it the spinal cord is involved or something else is involved?
is the tenting of the ligamentum.
No. That is for pyramidal tract involvement. Right? So I don't know how far everyone will agree on that. But they say, what they say, it is not involvement of the spinal cord, it is actually involvement of the roots. Right? When flash, the entire spinal cord moves upwards. So at that time what happens is multiple radicals are involved. So that recovery in a whiplash. Yes.
Autonomic history, patient complains of decreased sweating below the shoulder. Post-trauma, patient had loss of bladder sensations with continuous dribbling of urine for about an year and was unable to initiate the maturation, following which patient now is on continuous catheterization in view of recurrent bed sores and UTI. But patient could appreciate the fullness of bladder, but he is unable to initiate the maturation or maintain the flow.
Right. No, but in this history it is not there. The history which you are giving is, there was a continuous dribbling.
Yes, sir.
Right? The patient was able to feel the sensation of breath. That's how you are given it.
Later,
now
sir.
It's changed. Right? In the original history, what you are given is, the patient is able to feel the sensation, but he is not able to initiate or is going to continue, maintain his bladder. At the same time, there was a continuous dribbling. So what do you think? Is it a spinal bladder? It is an automatic bladder or autonomous bladder? Deafferented bladder, deafferented bladder.
Yes, sir. So initially he had a element type of bladder, sir. Later he is having an automatic bladder with the presence of sensations.
So initially what type of bladder you said the patient was having?
Element type of bladder. Autonomous.
What is the difference between an element type of bladder and automatic bladder? It's the same.
Element type of bladder is autonomous bladder, sir. It is due to involvement of sacral roots S2, S3, S4, and patient will have painless distension of urine, and he won't be having sense to initiate or to maintain the maturation.
So autonomous or automatic?
LMN is autonomous, sir.
LMN is?
Autonomous.
Is it?
LMN
is automatic. Right? UMN is autonomous. It is not under the control of anything. Right? Not even the sacral center. Right? Automatic bladder is, once it fills, automatically it gets released. Autonomous bladder is, it doesn't have anything at all. Now how does it continuously dribbling? There is no, right? There's a bladder sensation is not there. The bladder center is not there. So how is that the bladder has become autonomous? It is neither in the control of spine or in the control of cerebrum. Yes?
So once the pressure in the bladder is very high, it overcomes the pressure of the internal urethral sphincter. So there will be relaxation of internal urethral sphincter and causing constant
dribbling. It is because
dribbling.
of the inherent capacity of the
bladder.
smooth muscles of the bladder. Right. So that becomes autonomous bladder. Automatic bladder is element bladder. Both are same. Right. Now you think it is a deafferented. The patient is able to feel the bladder sensation.
Yes, sir.
Right? So it is deafferented or deafferented?
Deafferented, sir. Motor paralytic bladder.
Yes.
So what is
Okay.
afferent and efferent? Which one is afferent nerve and which is efferent?
Efferent now.
Afferent sensations are carried by the A delta and through the spinothalamic tract, sir. Efferent is by sympathetic and parasympathetic tracts.
So what is the action of the parasympathetic, sympathetic on bladder?
So sympathetic, it acts on the beta-3 receptors of your bladder and it helps in fullness of bladder and acts on the internal urethral sphincter causing constriction. So bladder filling will happen in sympathetic tract stimulation. Parasympathetic, it acts on M3 receptors of bladder causing contraction of bladder and relaxation of internal urethral sphincter. So emptying of bladder happens in parasympathetic stimulation.
Sympathetic causes bladder detrusor muscle relaxation and constriction of the internal sphincter. There is a parasympathetic, the opposite one, where the external urethral sphincter is only controlled by the prudental nerve, S to the S3, S4, which is under voluntary control.
Yes.
Patient complains of giddiness with blurring of vision lasting for about a minute after mobilization and post history
Next. Slide. பார்த்துட்டேன்.
A patient complains of giddiness with blurring of vision lasting for about a minute after mobilization. Post-trauma is having a history of poor cough and sneezing, no history of any orthopnea. History of sudden onset palpitations and excessive sweating over the upper part of chest is present on and off, and it is not associated with chest pain and relieved spontaneously. No history suggestive of cranial nerve involvement.
So what is the cause for giddiness there?
So probably orthostatic hypotension.
So if a patient is going to have the parasympathetic and sympathetic involvement, right? Where does the spinal cord localization occur?
T6, sir.
Above T6 or T6?
Above T6.
Above T6, okay.
Surgical history, history of recurrent barriclariculae and was operated twice through cystoscopy. Past history, no comorbids before. Personal history, he consumes a mixed diet and has a normal appetite and sleep was adequate. So history diagnosis, tracts involved are bilateral corticospinal tract, bilateral posterior columns, bilateral lateral spinothalamic tract with the involvement of autonomic nervous system. So provisional diagnosis, a case of quadriplegia secondary to compressive myelopathy, probable level being above C5 and etiology is trauma.
So what will be your approach in a spinal cord lesion? First you have got to decide, right, whether it is a horizontal lesion or a vertical lesion. You think it is a horizontal lesion or a vertical lesion?
Horizontal lesion, sir.
So why do you say it is horizontal?
So since he is giving a definitive sensory level, it's mostly a horizontal lesion. He's giving a definitive sensory level in history, sir, with like band-like sensation.
But by history he gives different levels. He says right from the neck and band is there, right? Then it means there are two levels. Can you place it in one area? Right? Okay. Now, is it then if you say it is horizontal, so you got to decide whether it is a compressive lesion or a non-compressive lesion. Now you think it is a compressive lesion or a non-compressive lesion?
Compressive myelopathy, sir.
Now what is that to call it as a compressive?
So probably a vertebral fracture which is causing compression of vertebral.
Because of the history of fracture, it need not be always compressive. Now you tell me, what are the things which is suggestive of compressive?
Presence of radicular pain.
Is there a radicular pain?
No, sir, in this patient.
Yes.
Presence of any vertebral pain.
Yes. Yes, local pain is not there. Radicular pain is not there. Is there a deformity?
Local pain he had for first few days, sir. Post surgery, there is a resolution of pain.
But now is there a deformity in the bone?
No deformity, sir.
Then why do you want to call it a compression? So you think it is a transverse lesion? Right, you said transverse lesion because
yes,
you said
sir.
horizontal. Right, now you have got to give me levels there. And third level he says he doesn't feel anything at the lower part.
Yes, sir.
So there are three levels are there. Then why do you say it is horizontal? There are three horizontal levels.
What is the triad of spinal cord? When do you say cord is involved? What are the three things should be there?
All motor tract, sensory tract and autonomic system should be involved.
In your history, where do you think is the motor tract? Which part?
So he's only able to abduct the shoulders up. So C5.
Then he had something in the involuntary movements near told.
Flexor spasms.
No, other thing, one more important. Pitchings, fasciculations in the upper arm. So that localizes the motor level as what?
Upper part of arm, C5.
So that's what you have put C5.
C5.
You have put three levels. You have put only the motor level. So what about the sensory level and autonomic level?
Okay. Sensory level, since it's having a band-like sensation in the upper part of chest, and from there it's a decreased sensation. So probably T3 will be the sensory level, sir. Autonomic level above T6.
So if you have a single lesion, the motor, sensory, autonomic should go within a particular, as I said, the watershed territory. When it goes beyond the territory only, you think of multiple lesions. Like LETM. What is LETM?
Longitudinally extensing transverse
When you
myelitis.
say longitudinally extends, how many segments?
More than 3 contiguous segments.
More than 3 contiguous segments. So you have to mention the motor level, sensory level and autonomic level.
Good.
General examination. Patient is conscious, oriented to time, place and person, and there is wasting of both upper limbs and lower limbs present. Vitals, pulse rate 74 per minute, regular normal volume. BP was 100 by 60 millimeters of mercury in supine position and 76 by 54 millimeters of mercury with the patient in the supine position with the head and elevation. Respiratory rate was 16 per minute, abdominal thoracic. There was no pallor, icterus cyanosis, clubbing lymphadenopathy or pedal edema, and dryness of skin with cirrhosis was observed was present below the umbilicus, and multiple healing bed sores present over the bilateral gluteal region. Hyperpigmentation of the lower limbs noted, and there are no neurocutaneous markers present. Single breath count is 10. Higher mental functions are intact. Patient is conscious, alert, oriented, time, place, and person. Memory, both all the immediate, recent, and remote memory are intact, and speech is normal. MMSC scoring is 30 by 30.
Any important nerves affected?
No, sir.
All 12 are
normal.
So what are the cranial cells could be involved along with the spinal cord?
Cranial nerve, sir.
Oh, yes.
Probably in the case of a trauma, olfactory.
No, don't. I'm just asking you in general. So, for example, second nerve and the spinal cord, third, fourth, and sixth and spinal cord, fifth and spinal cord, seventh and spinal cord, like that. At least 1 or 2.
Weber's syndrome, ipsilateral third nerve palsy, and contralateral pyramidal tract, sir.
No, I'm talking about the spinal cord.
Sorry.
Quadriplegia.
Okay, sir. About the level of C2, spinal nucleus of the trigeminal nerve can be involved, sir. With causing
No,
loss
you
of
go with in an order. Second nerve and spinal cord. Condition? At least one condition.
Okay, sir. Friedreich's ataxia, sir.
Friedreich's ataxia.
Optic atrophy with
yes. Then anything else?
Demyelinating disorders.
NMO. Neuromyelitis optica. Multiple sclerosis.
GBS 7th nerve can be involved, sir.
Go in, sir. That's what I'm asking.
Okay, sir.
Right? If you go in an order, you will never forget anything. If you are going to jump here and there, you tend to forget common things.
Okay.
Right? So always keep it in your mind. Always go in an order. So third, fourth, sixth. Right? Condition third, fourth, sixth, and this thing, spinal cord.
No, sir. Dab.
Miller-Fisher variant of GBS can produce 3-4-6 cranial nerve palsy.
So third, fourth, sixth Miller is little uncommon. Right? Anything else? INO with right spinal cord, multiple sclerosis, internuclear ophthalmoplegia. Then fifth and spinal cord?
Higher cervical lesions can
high
produce.
cervical lesion. So what sort of a problem it will produce? Fifth now? Is it motor, sensory?
Sensory,
or what
sir.
sort of
Spinal nucleus of the sensory nerve is, trigeminal nerve is at that level.
So, yes.
So it involves the ipsilateral.
So one side, yes, ipsilateral loss of pain and sensation. Temperature on the face. Okay, then seventh now, everyone knows, right? GBS.
GBS.
Right. Then 9th, 10th, and 11th? 12th? It is one condition, man.
Syringobulbia can produce
syringobulbia
lower
of any
cranial
reason.
nerve palsy.
So it could be basilar imagination, atlantoaxial, right? So craniovertebral anomalies. Yes. Okay.
What is field stride?
Sir?
Field stride.
No, I can't understand.
Field striate.
Field striate.
So field striate has 3 components, sir. Short neck with low posterior hairline and restricted cervical movements.
Good. Which condition?
Kippelfield syndrome, sir.
Yes. So no cranial nerves in this.
Yes. Motor system examination, attitude, upper limb, shoulder is in adduction, elbow in extension, wrist in neutral position with ulnar claw hand, ape thumb deformity, and lower limb, leg extended and adducted at a hip joint, extended at knee, and joint, extended knee joint, plantar flexed at ankle.
Now, what does this attitude?
Sir, due to the pyramidal tract involvement, generally the pyramidal tract supplies the predominantly the extensors in the upper limb and flexors in the lower limb. So when it is When it is involved, it can cause flexor hypertonia in the upper limb and extensor hypertonia in the lower limb.
So, but here you said shoulder is an adducted, elbow in extension, wrist in neutral position. So, what should be the position if your patient is going to have a pyramidal tract?
There will be flexion at the elbow, sir.
Yes, it should be like this.
Yes, sir. Yes. Yes, sir.
Here it is.
It
So,
is in the
does it go with corticospinal?
No, sir.
It doesn't go with corticospinal. The position itself doesn't go with the corticospinal. Whereas the lower limb, I agree. The leg is completely extended knee, plantar flexed. Yes.
Bulk in the upper limb, 10 centimeters of the olecranon, right side was 19 centimeters, and left side also it was 19. And 10 centimeters below the olecranon, both sides it was 18 centimeters. And in the lower limb, 18 centimeters above the tibial tuberosity, 30 centimeters on the right side and 31 centimeters on the left side. And in, 10 centimeters below the tibial tuberosity, 21 centimeters on the right and 19 on the left.
Yes.
Tone, in the upper limb, flexor hypertonia is there with clasp knife spasticity. In the lower limb, extensor hypertonia is there with clasp knife spasticity.
No, show them. Is it a flexor hypertonia in the upper limb?
Yes.
Huh? Show me. Flash it over this. No. A hypertonic limb, it should be like this, right? It cannot be like this.
The flexors are dominant, the limb should be...
It should be like this. You just lift the hand. You just, you see that? You flex it. Just like that it falls. No, but it is flaccid.
You are able to understand what sir is saying?
Yes, sir, yes, sir.
The flexor hypertonia means we expect the limb to be
Flexed
at the elbow. It's not flexed, no? As of
what on
So which will be difficult? Extension will be difficult or flexion will be difficult in a clasp knife in the upper limb?
extension will be difficult, sir.
Flexion will be difficult.
Extension, sir.
Extension will be. Now you see that extension there? You think is there any resistance there? You just flash it. Whereas do the lower limb. Now you see that? You are finding it so difficult.
so you are able to flex the knee fully. See the extension.
Now while he is flexing itself, there is a clonus coming. Yes.
See the position of the ankle, how is it? The foot completely dorsiflexed. Sorry, the plantar flexed.
So both the upper limbs, I don't think it is hypertonic. It is only hypotonic. So that is why it is used as yes. Now if he has a flexor hypertonia, then the flexion should be very easy for him. La?
Yes, sir. Power of the muscles. At the joint, shoulder joint, adduction.
Now, mention about the fasciculations, wasting.
Sir, on inspection, there is wasting present in both the upper limbs and lower limbs, sir. And fasciculations, we could not appreciate it, but patient is giving history of fasciculations, sir.
No, we were seeing there.
Flexor spasms were there.
Just show them fasciculations.
Fasciculations is there in the deltoid region.
There were fasciculations in the deltoid, biceps.
You saw the position of the hand, how is it? All the intrinsic muscles, did you examine?
Now what about the... Yes, sir. There is wasting of all the intrinsic muscles of the hands.
So there is hyperextension of the MCP joints. The lumbricus are totally
it is like this, and as you said, but he is coming later. He is coming later. Okay. He has written about that. Slides.
Power, sir. At the shoulder joint, adduction 2/5, both right side and left side. Abduction 2/5. flexion 2 by 5 and extension 1 by 5. Elbow flexion 4 by 5, extension 2 by 5. Wrist power is 0, sir, both flexion extension. And hand grip 0%, sir.
The elbow, you said a flexion is 4 by 5.
4 by 5.
I don't think
Let
so.
me see. 4 by 5 irundhathu.
See, 4 by 5 is against resistance, no? So that is, he does flexion against resistance. So again, 4 you divide into 4, 0, 4 minus 4 plus, no?
Yes, sir. No. 4, 0, sir. 4. ఇంకొంచెం 4 minus.
Right. Why I am saying is, if it is going to be less than 4, then you don't put in a corticospinal. La? It is less than 4. I'll put it as only 2. But as you said, once it is going to be mid-flexion, then it becomes stronger. Because the gravity is eliminated. Here he has to go against the gravity. Here, partially gravity is eliminated.
In the lower limb, power is 0 by 5, sir, in all the joints. Deep tendon reflexes, biceps, both sides 1 plus, sir. Triceps also 1 plus with supinator.
Slides are not moving, yeah. Lower limbs.
Slide.
Slides.
What's the rating for?
And the slides are not moving. Slides.
Slide change. Slide is not changing, is it?
Yeah, proceed. So power is 0 by 5 in the lower extremities. Yeah, go to reflexes.
Reflexes, biceps 1 plus, sir, both sides. Triceps 1 plus on the both sides, and supinator 3 plus. With knee, clonus is there, sir, both knee and ankle. And plantar extensor on the right side, and left side on the day we examined, because of plantar flexion we could not appreciate, sir, but so now it is extensor.
You are doing the biceps. Do you expect the flexion or something else is there in this patient?
Inverted biceps reflex is
that
there.
You have to specifically. Why is it important?
Because it identifies the level of the lesion, sir.
So there you have to mention inversion. You are not getting the routine flexion of the elbow. Can you demonstrate?
Demonstrate the inversion of reflex, both supinator as well as biceps.
Does inversion of reflexes carry any value?
It identifies the level of lesion of the spinal cord.
Very important. Localization. You can hit and see the
camera cutting.
Camera cutting.
Camera cutting.
Extension is there, sir, in the.
Now you see what happens to the lower reflexes. That is the C7, C81.
No, do
No.
You
do the biceps and see
the
for
biceps,
the.
let them see the movement.
What do you see?
That
Extension of the forearm is there, sir.
So that is C7 is working.
C7.
Look at the fingers. What happens to the fingers? Do the same reflex.
Okay. Same at the. or do the supinator. Now what is happening? When he's eliciting biceps, his finger goes for a flexion. So what is the mechanism of inversion of reflexes?
Inverted reflex, there is a spread of the reflexor. The more even the surrounding muscles, even though not stimulated directly, they become they get stimulated. Sir.
Actually, usually your deep tendon reflexes are confined to segments. Now the reflexogenic areas are extended above and below. So that is why there is inversion of reflex. Now bilaterally he has got that finding.
Yes,
right? Show them the finger flexion. Just tap over the finger and show.
Come here. Finger flexion flex exaggerated. Sir.
Yes, finger flexion is exaggerated.
What is the root value of finger flexion?
C8 to T1. Sir.
Huh? Is it ulnara? Median or ulnara?
Median now, sir.
Median now in a root value.
Median from C5 to T1. Sir.
It includes both, no? Median and proceed. So clonus is there in this patient. Beautifully demonstrated. The ankle clonus is there. Superficial reflexes.
Superficial reflexes. There are no primitive reflexes.
Ravi, you demonstrate the clonus and the Babinski's. You can demonstrate.
Just demonstrate the both clonus. Patellar, and there is some amount of in the wrist also.
Yes. More easily on the left side, you can, both sides there, left, you do demonstrate both.
Wait, at the camera there. Give more stretch on the lateral aspect.
So do on the left side.
Do it on the left side. Going for a flexor spasm. You're going.
You see here, when you're lifting, there is. You go to that side and see the. So it's not. You go to the right side of the patient and do.
No, he's going for a flexor spasm, sir. No, you will not get it. Why? Patient is in the flexor spasm.
Yes.
Now you see that everything goes to flexion.
Demonstrate the Babinski, no?
Custom. Flexor spasm. No, it won't go. It's coming? Now it is the spasm. It won't come. Yes.
Extensor, sir, both sides.
Okay.
Proceed. What is the importance of the genital reflexes?
We can identify the type of bladder.
One is that one. Then they are the earliest reflexes to come after cord injury.
Bulbocavernous is the first to recover.
Yes, proceed.
Abdominal reflexes are absent bilaterally, sir. Cremastic reflex present bilaterally. Bulbocavernous present and anal reflex present.
So how is that the cremastic is present?
Sir, I didn't.
Was it there? I could not elicit, but anyway, was it there?
Yes, sir.
So now what they used to say, actually cremasteric reflex is nothing but an extension of abdominal reflex. Because the abdominal, right, extended abdominal muscle fibers, right, comes as a spiral and goes back, right? So even if you don't get abdominal reflex, you must get a cremasteric reflex. The cremasteric reflex is there, you can take it that abdominal reflex is present. So possibly it is not there because of some other reasons. Okay, now you say the cremasteric is present, abdominal is absent. Now how do you explain that? So it cannot be explained. If you are bringing in a pyramidal tract with clonus, everything, and absence of an abdominal reflex, right? Now the bulbar cavernous and anal reflex are present. That means you are saying the sacral sparing is there.
Yes, sir.
Now how is that the sacral sparing is there? Because it has involved the posterior column, it has involved the lateral spinothalamic tract, it has involved the pyramidal tract. Now how is that it's only the sacrum which is not affected?
Sir, for the reflex to be present, just the spinal segment, if it is intact, we can get the reflex.
But the afferentism should be there, illa? But your sensation is 0/5. The afferent should be intact, agreed. Reflexes of one need not have anything, but the afferent should be there.
Sir, is it possible that for the sensation or the patient to feel the sensation, he requires the information to be sent to the thalamus, sir?
No, for that also I am telling you. Now both, see, sometimes what will happen is, if corticospinal tract is not there, the lateral spinothalamic tract is not there, the posterior column will take over. Now according to you, the posterior column is also affected, because you say the vibration is not there, 0/5. There is no afferent at all. How is that? So I could not explain that. If it is going to be present, I may not be able to explain that.
Normally the impulse goes via the posterior route. The lamination of fibers, sacral is the most medial one. So here you are saying the anal reflex is present. That is, efferent is present. You said, but the tension, sensation is absent. Afferent.
Sir, I thought for the patient to feel the sensations, for example, at the L1, L2 area, the efferent impulses must first travel from the sensory nerve to the spinal cord and from there to the thalamus. But for the reflex arc to be present, the sensory nerve, spinal segment, and the efferent, if these three are intact, even if the upper segments are lost.
No, the sensory is not there. That's what I am telling. The sensory is not there. See, what is superficial reflex? Right? It is a noxious stimuli. Right? Pain is the one which is going to produce the reflex. So I used to say 4 P's. Right? The response is plurisegmental response. It won't confine to one place. For example, you just tap one place, the entire abdomen may contract. Right? Plurisegmental. And it's a polysynaptic reflex. Right? Modified by the pyramidal tract. Yeah. So for a noxious stimuli to occur, the patient should have pain or at least the pressure. Both the things are not there according to you. The vibration is 0, position is also 0. The afferent is gone. Now I will not be able to explain if you are going to say bulbar cavernous and anal. Unless you are going to say it is a sort of a visceral reflex, it doesn't depend upon anything. So they used to call it as in olden days visceral reflex. This abdominal bulbar cavernous reflex, they used to call it. Unless you are going to call in that way, I am not be able to explain that if you are going to say pyramidal tract with afferent gone.
Able to understand, both efferent and efferent arc should be intact to produce a reflex. If one is absent also, then you are not going to get the reflex.
Yes.
Sensory system examination, sir. Pain from the C2 level, it was 100% till C4, and from C5 level, patient mentioned that he could only feel 25% of what he felt at the level above. C6 also 25%, and C7, C8 10%, and T1, T2 25%, T3, T12 25%, and from L1 there is no perception of pain, sir. Temperature also from C2 to C4 it is 100% intact, sir, and from C5 it is 25%.
Go back one slide, go back. No, cremasteric. present. Then you said L1 you go? L1 you are saying 0.
Zero.
So it's not matching. Yeah, what is the root value of cremasteric?
L1, L2. Sir.
And then how can you say L1 is absent and you say reflex is present? So these are small things you have to be very careful. Sensory arm is not there, but you're saying motor arc is there. Proceed.
And temperature also from C2 to C4 it is 100%, sir. From C5, 25%. C7, C8, 10%. And from T1 to T12,
Do you have a sensory root for C1? Which is a dermatome for C1?
No, sir, sensory dermatome for C1.
Then why you mention C1 then?
Not C1, sir.
T1.
No, before L1, sorry. Okay, proceed. Proceed.
Touch and vibration also from C2 to C4 it is 100%, sir. From C5 to C6, 25%, and C6, C7, C8, 10%. T1, T2 again 25% till T12, and from L1, 0, sir.
Okay.
Cerebellar system speech is normal, there was no nystagmus, sir, and because of poor muscle power, coordination could not be assessed. Other system examination, RS bilateral larynx present equally, no added sounds, and abdomen soft, non-tender, no organomegaly, CVS assessment present, no murmurs. Final diagnosis: traumatic spastic quadriplegia secondary to compressive cervical myelopathy, extradural, extramedullary in recovery phase, with sensory level above C5 and motor and reflex also above C5 levels.
C5. So motor level is C5. Right?
Yes.
But there were inversion of reflexes were there. So the motor level is a little lower down also. Right? It is 1/5. So the motor level goes down also. So is it a central lesion? You say transverse lesion. Right? So transverse lesion. Right? Now how do you explain this? There's ulnar deformity, apthumb deformity, all those things, and small muscle wasting. Usually if you are going to say pyramidal tract, it won't get involved. They are involved only either plexor, so beyond anterior root. It should be plexus plexopathy, or it could be radiculopathy, or it could be neuropathy. Right? If you are going to say small. No, or else if you say putting it as a spinal tract, entire thing should be flexion. Cannot go for ulnar. So ulnar hand cannot occur with pyramidal tract. Claw hand cannot occur. So it should be myelo, radiculo, neuropathy. That's what I feel.
Yes. See what will happen, spastic, you will have a limb like
and
this.
And the fasciculations are there.
The limb is not like this. So we have to be.
So there is a myeloradiculopathy at multiple levels. I cannot say give a single level. So because there were some skip lesion. If you are going to say bulbocavernous is going to be there, L1 is going to be there, then you say there were some skip lesion. So this sort of a skip lesion we used to give in olden days. Now we have CT scan, MRI and all is going to fix up the diagnosis. We used to call it as arachnoiditis. Multiple roots and dura is involved. Myeloradiculopathy. Right? Okay. Now, I cannot say it is horizontal. I will call it as only non-compressive lesion, possibly the electricity. What is the effect? So possibly, see, the nerves are the good conductors. Nerves, that's why they go for ulcers. What will happen is it produces a local heat and the entire nerves, right, arteries, everything, arterioles, everything gets damaged. So it can produce such an extensive lesion. The case, I cannot say a definite level. So I can say, all that I can say is multiple lesions are there. All that I say is, the case is good for demonstration and multiple clinical findings. You cannot do anything of it. Even the surgeon, that's what I feel.
Patient was operated soon after the fall, is it?
72 hours after the fall.
Any MRI was taken pre-operative, post-operative?
Taken, sir. There is a fracture dislocation at C4 level, sir.
Is there any compression?
Was there compression?
Yes, sir, compressive myelopathy is there at the C4 level.
No, that they said at that time, right? It is an acute phase, where the patient will have an edema, right, which can be there up to 4 to 6 hours, sometimes 12 hours, 24 hours also, right? So in which case, all that they can say is there is only a pressure, right? Now, have they repeated the MRI now?
No, recent MRI we don't have, sir.
No, they were not done. Possibly, I expect the patient to have hematomylia, myelomalacia. These are two things I expect.
Suppose if the neurological findings are worsening, what do you suspect?
Yeah, they can have post-traumatic syningomyelia, sir.
Very good. So neurologic, you have to have a track of the neurologic. If the findings are worsening, is developing a strings, which is expanding, growing upwards or downwards.
So, thank you very much.
Thank you.
This
Thank
case
you.
is very good. It is only for physical findings. It's not going to help anyone. Thank you.
Thanks.
Thank you.
So one doubt, sir. So in stage of recovery, they say reflexes will be the first to get recovered, then motor in the order reverse of the involvement. Later will be the sensory to get recovered. If he is in a stage of recovery, the presence of reflexes can be explained, no, sir?
No, you are saying recovery after 13 years. I don't think. It isn't the same. Right? I don't think he has got any recovery. If it's going to be recovery, then he must not have all these deformities. He must not have wasting. He must not go for fasciculations. There is no recovery at all.
See,
It remains the same.
In case of injury, you don't get any recovery within maximum 1 or 2 years. There is no very, very less chances the patient will recover. So by physiotherapy connects some, but neurology recovery is maximum 1 year post-traumatic. Yeah, neurology recovery will not be there beyond 13 years and all. Whatever he gets the power within 1 year after the trauma, that will be that is going to last long.
Okay, sir. Thank you, sir.
Thank you.
Thank you, Ravi Kumar and Shravanti. Thank you, Ramakrishnan sir. Thank you, Rajshekaran sir. It was a very elaborative, informative session, and thank you for simplifying the cord lesions. So, now I request Rajkumar sir, Professor and HOD of Department of Medicine, to please hand over the memento to Dr. Rajshekaran as a token of gratitude. Thank you, sir. Thank you very much. May I request Dr. Venkat Krishnan sir to please hand over the memento to the other moderators of the session, Dr. Rajkumar sir and Dr. Ramakrishnan sir. Thank you, Rajkumar sir. Dr. Ramakrishnan sir. Thank you, sir. Gentle reminder, we have uploaded the feedback forms in your WhatsApp group. Kindly fill it. And the second thing is the certificates are available at the registration desk regarding yesterday's workshop. Now we have a small tea break and we'll meet after 15 minutes. Thank you. 2018, Dr. M.G. Garg All-Time Achievement Award by the IMA in 2014, and the President Appreciation Award in 2018 by the IMA. We welcome you, sir. Our next moderator is Dr. Emmanuel Bhaskar, sir. He is the Professor of Medicine and Unit Chief in our college. He is a Member Secretary of the Institutional Ethics Committee. He has been involved in various and multiple national studies. We welcome you, sir. Now we'll start the next session.
Good morning, sir. Good morning, everyone. Today, myself and Dr. Hari will be discussing a case on cardiovascular system. So, history, 39-year-old male, resident of Chennai, unemployed, stays at home, not educated, came with chief complaints of bluish discoloration of fingers, toes and lips since 4 months of age, as noticed by mother, and exertional breathlessness. Coming to history of presenting illness, the child was apparently normal till 3 months of age, following which the mother noted bluish discoloration of body. First, she noted at the lips, then at the toes, and this episode happened during the breastfeeding. So, followed by which, mother noted there was forehead sweating, and baby became drowsy and lost consciousness. Following which, the baby was taken to outside hospital. Treatment-wise, as far as the history she says, like he was started on oxygen and given some IV injections, followed with baby recovered with the treatment. Similar episodes which recurred, and especially during feeding, with further episodes, mother mentioned that baby had involuntary movements of all 4 limbs. Next hospital visit, baby, when they went to next hospital, they told like he had a heart disease, and they advised to go to a higher center, where they mentioned baby might require cardiac surgery. He had recurrent such episodes of bluish discoloration, followed by multiple hospital visits, and on and off episodes of involuntary movements of all 4 limbs. Child initially attempted some physical activity, however, developed breathlessness and hence refrained from such activities and prefers staying at home. The history of cyanotic spells were relieved by sitting with legs crossed or lying down maneuver. Reduced frequency of cyanotic spells seen in due course of time. And history of recurrent admissions during the past few years with similar complaints. Also, he had associated symptoms of headache, dizziness, blurring of vision. There was also history given of repeated procedures of drawing out blood, no history of chest pain, palpitation, no history of seizures, no history of seizures without cyanotic spells, and no history of any focal seizure.
Okay, 1 minute. So this person has got cyanosis from very young age.
Yes, sir.
Isn't it?
Yes, sir.
So what are the causes of cyanosis at birth?
Sir, cyanosis at birth at first week, generally we'll observe TGA can be there, pulmonary atrasias can cause, obstructed TAPVC can cause, then hyperplastic left heart syndrome can cause, then Epstein's anomaly can cause. This is generally at first week. So now since it's presenting at 3rd decade, the conditions which can cause are TGA, corrected TGA, TOF can cause, and also during the first week, severe TOF with critical pulmonary stenosis can also present with such.
So you need not go through this extensive list. So remember 5 T's at cyanosis at birth.
Yes, sir.
It is transposition, truncus, and TAPVC.
Yes.
Then tricuspid atresia and tetralogy. So these are the 5 T's at cyanosis at birth. So here, according to our history, so basically the approach to congenital heart disease is, the first approach is cyanotic or acyanotic. So here you are dealing with the cyanotic heart disease.
Yes.
The second approach should be whether the patient has got history of increased pulmonary blood flow or a decreased pulmonary blood flow.
Yes.
From history itself, you must be able to say whether you are dealing with a history of increased pulmonary blood flow or decreased pulmonary blood flow. According to our history, so far. You know this is cyanotic heart disease from very young age, although it is not birth. They noticed at 3 months, maybe at birth. So probably the cyanosis at birth. So it has to come in the basic conditions. You have said some rarer conditions, but most common conditions are these 5.
Yes.
In this, what are the 3 conditions which have got increased pulmonary blood flow? What are the 2 conditions which have got decreased pulmonary blood flow? I told you 5 T's.
Yes, sir. TGA, TAPVC can cause increased blood flow, and truncus arteriosus also. And decreased blood flow will have top physiology, will have the decreased blood flow.
Yes, exactly. So now, in these 5 conditions, 3 conditions will have increased pulmonary blood flow, 2 conditions will have decreased pulmonary blood flow. Tricuspid atresia and TAF is decreased pulmonary blood flow. Truncus, TGV and TAPVC are increased pulmonary blood flow. So these are the 5 conditions you may be dealing with.
Yes.
Some sort of variations of these 5 diseases. From your history, do you think the patient has got an increased pulmonary blood flow history or decreased pulmonary blood flow history?
Sir, I think it's decreased pulmonary blood flow since they didn't give a history of recurrent respiratory tract infections. So I would like to put as decreased pulmonary blood flow based on that.
What are the other symptoms
And cyanotic,
of increased pulmonary blood flow?
Increase, then there will be like left heart failure symptoms.
Not necessarily left heart.
Then there will be possibility of hemoptysis. There can be
yeah, so just I tell you, cyanotic heart disease or acyanotic heart disease, the increased pulmonary blood flow history, whereas decreased pulmonary blood flow history is same. It is only the difference of cyanosis absent or present. So increased pulmonary blood flow, patient comes with repeated respiratory infection. Heart failure is common. They will have a huge heart because it's a volume overload most often. They will have tendency for heart failure. The cyanosis may be less. In a cyanotic heart disease, patient with the increased pulmonary blood flow will have less cyanosis. And also, they have a huge megaly. They have a shunt murmur and not an obstructive murmur. And also, when you take an X-ray, there is most often a plethora rather than an oligemia. So, any patient who has got a tendency for heart failure comes under this group. Whereas a patient with a decreased pulmonary blood flow will have a small concentric hypertrophy, pressure overload. They may not have a big heart, but the murmur will be very rough because most often they are obstructive murmur. The tendency to go for heart failure is very, very late, not early. So the heart size is small or normal or little bit larger, but they have no evidence of heart failure in the young. Cyanosis, so they will have cyanotic complications.
Yes.
What are the cyanotic complications?
Cyanotic complications, we can start with polycythemia related complications. There will be CNS infections, there will be respiratory tract infections, there will be gout, hyperuricemia.
Respiratory tract infection? What respiratory tract infection? In a decreased pulmonary blood flow?
Mostly abscesses through embolic phenomena.
That is in brain.
Then
primarily polycythemia and related thrombotic complications. Majority of cyanotic complication. Hypoxia, as you said, cyanotic spells. Cyanotic spells are primarily due to what?
Cyanotic spells is the mechanism behind is basically when child during any exertional activity like breastfeeding and all, there will be decreased systemic vascular resistance. So as a result, there will be a shunt from the right to left which will increase. So as a result, patient will have hypoxia, which will further trigger, the respiratory center, which is very immature at that time. It will cause hyperventilation. So with this hyperventilation, what will happen? Again, there will be like in TOF physiology, there will be infundibular stenosis because of the hypoxia. It will go into generally we'll advise mother, like if a baby, so advise them for knee to chest position. And during the due course of time, we tell the child, like during the episode of squatting.
Any drug you want to give?
Sir, drugs you can give morphine, anxiolytic. Second thing is alpha agonist we can give. Specifically for cyanotic spells, we have to give propranolol.
Okay, any other drug? Any other drug? When there is severe hypoxia, what will happen?
You people can also try.
Oxygen.
My microphone is there.
So, if for severe hypoxia, what type of metabolic dearrangement will happen in the
Sodium
body?
bicarbonate
Exactly,
we can give.
exactly. So basically, the sodium bicarbonate to reverse the acidosis which is happening to the lactic acidosis. So from your history so far, we understand
Yes, sir.
the patient has got cyanotic heart disease. The cyanosis is existing from almost from birth.
Yes, sir.
So this rules out what conditions? Cyanotic heart disease,
so
it rules out what type of conditions? What is tardive cyanosis?
Tardive cyanosis Eisenmenger phenomenon, sir.
Exactly. So what will be the history there?
So generally it will be all left to right shunts, and the cyanosis will come at a later stage.
Exactly. So what we have ruled out in this cyanotic heart disease is we are not dealing with Eisenmenger type of problems.
Yes, sir.
Except a very rare situation where a big VST may happen at a very early age of reversal. But most often we have ruled out that group. That is, cyanotic heart disease with severe pulmonary hypertension is almost ruled out. The tardive cyanosis is ruled out.
Yes, sir.
From your history, you think it is a decreased pulmonary blood flow history or increased pulmonary blood flow history?
Sir, I think it's decreased pulmonary blood flow.
Okay. Then what are the conditions you'll think of?
So mostly decreased pulmonary blood flow. So I'll first condition, and since his age is 39, so I'll be thinking of TOF, the TOF physiology. So under that TOF physiology is possibility of.
Is there a possibility of tricuspid atresia in this patient?
So, but the age is 39, so I don't think the survival is still
Okay.
that.
Between these two, the people may not live up to that tricuspid atresia unless they are corrected. They may not live up to this. So please remember the commonest cyanotic heart disease in adult is still tetralogy of Fallot.
Yes, sir.
What is trialogy of Fallot?
Triology is ASD with RVH and pulmonary stenosis.
What is pentalogy of Fallot?
Pentology is tetralogy of Fallot plus ASD.
Okay, right. Now with this background, you can go ahead.
So
past history, the patient gave a long past history to sir also. Anything should be more elaborate. See, this patient has a very long past history, so actually it should be combined with what the mother tells, what the patient tells.
Yes, sir.
You have not brought out that part in the past history. That's quite relevant because that gives you a clue that next step you are telling that he underwent a temporary pacemaker.
Yes,
but
sir.
you should have to justify in the past medical history
Yes, sir.
what was the possible reason he required a temporary pacemaker. You understand? That
Yes, sir.
should be captured in the past medical history.
Yes, sir.
Though it's not too long, 39 years, we know certain diagnoses are ruled out. That's
Yes,
correct.
sir. Yes,
But still, for reasoning purpose,
Yes,
you need to elaborate the past history more before you tell that a temporary pacemaker.
Sir, what I asked from the son and the mother, their history to me didn't seem reliable. So we called up father. He said the reason for putting pacemaker was he was admitted. During that time, he had similar episode. And that time he had...
Telling that part alone. Okay. The number of episodes, she told multiple episodes of respiratory infection. That is one thing. Even now when sir asked, she told that.
Yes, sir.
And multiple episodes of loss of consciousness.
Yes, sir.
2 things she told.
Yes.
And numerous hospitalization.
Yes, sir.
These 3 things should be captured in the past medical history. That's what I am trying to tell.
Okay, sir.
Go ahead.
That's what in the history, there were both, history was there. That's what the important thing. Okay. It is not a pure decreased pulmonary blood flow history.
Yes.
I asked her, she said recurrent respiratory infection for which the 2 things the patient got admitted. 1, respiratory infection. 2, recurrent syncopal attacks with a seizure.
Okay.
So these are the multiple episodes. One of such episode, some complication happened and he had some intervention.
Okay.
Okay. So there was some history suggestive of repeated respiratory infection. We'll come to that a little later.
Okay, sir. So personal history, his appetite was low, no consumption of alcohol or smoking, and drug history, he was taking levetiracetam and ecosprin AV.
Right, okay. Now, this patient had a probably, why the pacemaker was put probably, the patient may had a bradyarrhythmia, a severe bradyarrhythmia. Most often we have to think of as complete heart block with a Stokes-Adam attack, isn't it?
Yes, sir.
At that time the pacemaker was put. So what are the congenital heart diseases in which AV block is common? So that will give a clue regarding the etiology of, the diagnosis of this case. So what are the congenital heart diseases in which AV block is common?
ASDs can
ASD, which ASD?
ostium primum and secundum because of the right.
Well, sorry to interrupt. See, when a question is asked, take few seconds. See, you are telling ASD, then sir is asking another question. Don't give that opportunity to the examiner. When a question is asked, take 3 or 4 seconds, organize your answer, then give a good flow.
Yes.
Flow is important.
Yes, yes. So, which ASD will cause AV block? Okay, ostium secundum can cause a first degree atrioventricular block.
Yes, sir.
Ostium primum can cause anything else which is more common to cause AV block? Congenital heart disease with AV block.
Total anomalous pulmonary venous connection can cause.
No.
Epstein's anomaly.
Epstein's anomaly can cause.
WPW syndrome can happen in Epstein.
Exactly. No, I'm asking not the accessory pathway. I'm asking for a bradyarrhythmia, which is AV block. WPW syndrome is a syndrome which can produce tachyarrhythmia and not a bradyarrhythmia. Whenever there is a whenever there is a heart block, congenital heart disease, what is the commonest cause? Corrected transposition of great vessels. You know, the corrected transposition of great vessels, your AV node is reversed. So the most common abnormality which will happen with the AV block is corrected transposition. And also, as you said, an AV block. Because as you know, the endocardial cushion development of the primum ASD is a part of endocardial cushion.
Yes.
So at that time, there only the AV nodes conduction system develop. So they also have. But most important condition you must think of when there is an AV block is corrected transposition of great vessels. So more commonly they will develop complete heart block, AV block, and so on because the ventricular inversion is happening there.
Okay.
Right.
So this is the family history as brought out through a pedigree chart. So he was born out of a consanguineous marriage with death in family. The sister who died, she died after birth, soon after birth. Cause was not known. And from the mother's side, her sister, she after pregnancy, like few years later, she died. They mentioned this because of some cardiovascular disease, but other details are not known.
Okay, so when you put the family history in such detail, it will tempt the examiner to ask you, what are the congenital heart diseases which run in family? So this is inviting the trouble. So please remember, the examination is a psychological warfare between you and the examiner. So examiner is trying to trap you, try to trap the examiner.
Yes.
So for example, if you are not very sure in one particular aspect of your presentation, you must quickly set and go on.
Okay.
Right? Whereas when you are very particular, when you are strong in, for example, let us say JVP, you are very strong in JVP. You must keep on saying JVP, A and V waves are seen. Then the examiner will ask you, what is JVP, in which condition A wave is present, and so on. Otherwise, you say, no features of infiltrate endocarditis. Routinely will say. But examiner will start asking, what are the features of infiltrate endocarditis, and you will trapped. So what you must do is, it is a sort of presentation in which areas you are very strong. You try to delay that area of presentation so that the examiner will have a temptation to ask you in which you are strong. So then you consume the time of the examiner in those situations where you are strong. Whereas routine statements like this, family history such in detail, will unite and it immediately will tend the examiner to ask, now you tell me, which are the congenital heart diseases which will run in families? Anybody? Which are heart diseases more often inherited? So that's what the trouble is. So if you are not very sure about the family history, so just mention there is no family, no history of such heart diseases in the family, and just go quickly on that. So when you put it in a detail like this is inviting the trouble. ASTs run in families. Most of the ASTs will run in families. So ASTs is very, very common congenital heart diseases. So there is a list of heart diseases which will more often inherited from the mother. So if the mother has AST, we have to expect AST in the fetus and so on. So that's what I'm saying, trying to say. It's okay, but not in such
because
detail.
see, basically we expect it only in neurological disorders.
Exactly.
In cardiovascular, we don't expect it. And the genetics in cardiovascular disorder is advancing on almost on a daily basis.
Very complex also.
You need to be updated on that. It's highly variable between countries to countries.
Okay.
So what sir is trying to tell is that you could have skipped this pedigree chart. That's what he's telling indirectly.
Yeah. Okay, go on.
Antenatal and postnatal. So, history of fever was present during pregnancy in second trimester, which was there for 5 days, but mother was not admitted in a hospital during that period. Other history, no history of diabetes, no history of drug intake. Birth history, normal vaginal delivery, full term. Birth weight, she said it was normal, but the details are not known.
What drug intake you asked?
One thing is regarding the diabetic medications I asked.
What diabetic
Second thing, so OHS, metformin, and
so it naturally it comes to what drugs in the pregnancy will cause congenital heart disease. So once again a trouble.
Main anti-epileptics, antipsychotics can cause.
You tell me only the most important drug which is very useful in practice. You tell me only one drug, one group of drugs which should not be given in family, which is during pregnancy, which is
anticonvulsants,
angiotensin inhibitors, AC inhibitors, ARBs, statins, aldosterone inhibitors are contraindicated in pregnancy. All these drugs, if at all the patient had some hypertension before and she was taking these drugs, they can cause some abnormalities, not necessarily heart disease, some abnormalities. Okay. Go on.
So, based on history summary, he's 39-year-old male.
No, that previous, at birth, what happened? Delivery? Normal vaginal delivery?
Yes, sir.
Full term, but the most important history mother gave, that you did not mention here at birth. Mother said the child did not cry at birth, and they took a lot of time to make the child cry. So that means at birth the child was severely, probably hypoxic or severely cyanosed at birth itself. Okay. So that's a very, very important history. But but the child did not cry birth at all. So that's a very important history. Okay. So the child was born with some sort of hypoxia, some sort of cyanosis. So this is probably, that's the reason why I said this is a cyanosis probably from birth. So that is a very important history.
Okay.
Right.
And it took 7 years for him to walk. That was another thing she told.
Yeah. Delayed milestones.
Yes, sir.
So see, 7 years the person took for. So these are the histories which is very, very important to tell you. That the brain is not getting the good blood supply, and at birth also and subsequently also.
Yes.
It is not getting enough oxygen. So the body is not getting enough oxygen. Not only the brain, but also the body is not getting enough oxygen to have the normal milestone. Milestones are delayed. The child did not cry at birth. So this once again emphasizes the fact the cyanosis is from birth. Okay.
So again in this patient, one more thing. If you look at the history, she told till walked.
Yes.
And then after that, there is a dramatic difference. After he got the pacemaker, his quality of dramatically changed. That is something you need to capture. So it tells you the impact of the arrhythmia on the patient's quality of life. That is something which is very striking in this patient.
Okay.
Okay. Now summarize the history.
So he's a 13-year-old male with history of cyanotic spells which started since 3 months of age, with dyspnea on exertion, with symptoms of headache, dizziness, and history of multiple venous sections. So probable
not dizziness, headache, and the dizziness is, what is dizziness?
Dizziness is a subjective sensation of spinning of.
But this patient had a recurrent syncope, isn't it? There is a lot of difference between dizziness and syncope. What is the definition of syncope?
Syncope is a transient loss of consciousness due to loss of cerebral blood flow, but with no neurological deficit.
No. What is the classical correct definition of syncope?
One of you can try.
I'm not asking you anything Very big. What is the definition of syncope?
This definition, older examiners.
Definition means
very
certain
strict.
words have to be there. Explanation is different, definition is different. He is telling that explanation of syncope and not definition of syncope. Definition of syncope is transient loss of consciousness with loss of postural tone, from which the recovery is immediate. So that is the definition of syncope. Loss of postural tone. Transient loss of consciousness with loss of postural tone, from which the recovery is immediate.
Okay, sir.
Right, that is the definition of syncope. So, instead of dizziness, the patient had recurrent syncope and seizures. So, that you have mentioned as cyanotic spells, but not the, you can also mention about the syncope, because cyanotic spells is different. The syncope can occur even in the absence of cyanotic spells. Not necessarily the syncope is always accompanied by a cyanotic spell. Right.
Three things are there here. I think again you are missing out there. He had episodes of loss of consciousness.
Yes.
Syncope history was there. There was history of involuntary movements,
Yes.
twitching of the extremities, frothing. And he had episodes of headache and dizziness. That could be polycythemia related. So there were three CNS symptoms which had perhaps interrelated or different reasons.
Okay. So, probable, based on history summary, suggestive of cyanotic heart disease, tetralogy of Fallot's physiology.
So, okay, what are the points against Fallot's physiology? I will not call it as a Fallot's physiology. It is not physiology. Physiology gone wrong is pathology. So, it should be correctly called as Fallot's pathology and not physiology. Isn't it? Physiology is normal thing. So, it should be, although we continue to call Fallot's physiology, the correct terminology will be Fallot's pathology. Right. What are the points in your history which are against Fallot's pathology?
So against can be, one is respiratory tract infections.
Exactly.
Recurrent, so that is high pulmonary blood flow.
Okay, right. Then? Okay, usually a patient with a cyanotic spell. So Sir said a very important point in the history. This patient after 7 years had some sort of remission of symptoms, isn't it, sir? Remission of symptoms. So, does it happen in Fallot's?
No, sir.
So, in which case, so actually in cyanotic heart disease, usually what will happen is the patient may be first 3 to 4 months, maybe little all right, but suddenly there will be deterioration. Especially in those conditions where is decreased pulmonary blood flow, there will be sudden deterioration in a patient who is cyanosis and be normal at 3 to 4 years, or first 2 to 3 weeks, I will say, then sudden deterioration. Why? That history is very common, isn't it?
Yes, sir.
Why that happens? A recovery, sudden deterioration of a cyanotic child.
Because initially the right ventricular compliance will be low. So as soon the weeks progress, the pulmonary arteries.
No. That you are telling about the left to right shunts. See, please remember the deterioration in left to right shunt will come around 3 months. Because you will always underestimate left to right shunt in the first 3 months.
Yes.
Because your right sided pressure is little high, pulmonary involution happens around 2 to 3 months, and you will always underestimate. So any left to right shunt in a cyanotic heart disease, you expect heart failure at 3 months only, and you assess the shunt only at 3 months. Because of the higher right atrial pressure, higher right ventricular pressure at birth, there you will always underestimate left to right shunt. So the real left to right shunt will happen only around 3 months.
Okay.
In cyanotic heart disease, the closure of PDA.
Yes.
That's the most important finding. See, for example, in patients who have got a decreased pulmonary blood flow, the PDA is the one which will be keeping the pulmonary blood flow intact. So once the PDA closes, there is a dramatic decrease in pulmonary blood flow, which will cyanotic child will worsen. So that's the most important cause of worsening of cyanotic heart disease. But here we have an opposite history. That a cyanotic heart disease patient after 7 years had become better. Can you explain that? What is the possibility? You can explain that?
natural course of different
one
congenital heart disease.
development of
So,
collaterals.
for example, pathology of pathology, why the patient is cyanotic? Because there is a decreased pulmonary blood flow. If at all the patient has to become better, there has to be increased pulmonary blood flow, isn't it? There is some mechanism by which the increased bipolar blood flow has to happen. Then only the patient become little better, less cyanotic, because the cyanosis is becoming less because the increased pulmonary blood flow is happening. Is there a mechanism by which increased pulmonary blood flow can happen?
Aortopulmonary collaterals.
Exactly. So that's the one important thing you must remember, no? So the patient will develop collaterals, or the collaterals from the systemic circulation to the pulmonary circulation, so that although the right ventricle is not able to pump the blood across the obstruction into the pulmonary circulation, the systemic circulation is trying to help the pulmonary circulation by developing its own collaterals. So if at all this fellow has developed some sort of remission of symptoms or decrease in cyanosis, because he would have probably developed some amount of acquired collaterals from the systemic to the, what is the major collaterals is called? Some abbreviation is there. Some mnemonic is there.
MAP.
Yes?
MAPCAS.
MAPCAS. So it is called MAPCAS, major aortopulmonary collaterals. So whenever a cyanotic child becomes better, think of collaterals. Whenever a cyanotic child becomes deteriorating, think of closure of PDA. So this is how we look at a cyanotic child. Right. On. So there are certain points. So summarizing the history, cyanosis at birth, and there are certain history suggestive of fellow, and it is not a pure history suggestive of a fellow. There are certain findings in the history which is against fellow also. So we are not very sure, because there is some history, recurrent respiratory infection, where there is increased pulmonary blood flow history is there. Then there is a fellow's history of cyanotic spells is there. Cyanotic spells tells you there is a decreased pulmonary blood flow. Recurrent respiratory infection tells you there is increased pulmonary blood flow. So both things are there in the history. So there are findings for fellow, there are findings for the other things also. So with this, we go on to the physical findings. Go on. What time in this case?
Thank you, Prashant. Good morning, sir.
Yes.
So moving on to the general examination, patient is conscious.
Those of you who are sitting there, anything which is not matching there, any error you want to pick it up, ensure you don't make fundamental mistakes when you write case sheets. Terminology is used. How do you tell built? What is a traditional adjective? Built is moderately built, well built, something like that. Don't use the word thin built and all. Your skeletal thing with the built generally represents skeletal development. That's how we go. And nourishment looks at muscular and soft tissue development. So don't mix those phrases there, right?
Sir, patient is conscious, oriented and cooperative. He is comfortable at rest. He is undernourished and having a height of 165 centimeters and a weight of 41.6 kilograms with a BMI of 15.3 kg per meter square.
What is the lower range of BMI? Below which it's a concern?
18, sir.
18.
The upper segment to lower segment ratio is 0.9, sir. General examination continued. There is pan-distal clubbing in all the 10 digits, grade 3. There is presence of cyanosis in lips, upper limb and lower limb digits. There is bilateral conjunctival suffusion present. There is no presence of icterus lymphadenopathy or any pedal edema. There is no presence of any external markers of congenital heart disease or syndromic phases.
Tell me the external markers of congenital heart disease.
Sir, hypoplastic thumb in Holt-Oram syndrome, and when we go on to Down syndrome, we have clinodactyly, simian crease, epicanthal folds, hypertelorism, a cleft palate and cleft lip. And in patients with Marfan syndrome, they'll have a high arch palate and presence of arachnodactyly, that is thin webbed fingers, and elfin facies in patients with Williams syndrome.
Williams syndrome?
Sir.
Turner's?
Turner's patients will be short and there'll be a web neck with a shield-like chest on examination, sir.
Okay. Then AST, any external marker of AST? Which will tell you there is AST is there, external marker with the fingers. Some syndrome?
Holt-Oram syndrome.
Holt-Oram syndrome. So this is once again, if you are very, very strong in your external markers, you know all about your syndromes, say that. So that I will have a temptation now to ask you. Now you enumerate Turner syndrome, Holt-Oram syndrome and other things. You consume the maximum time of the examiner where you are strong, right? So that the examiner will have less time to ask some difficult question in the future. So that is the way of trapping the examiner. So it is not the prerogative of an examiner to trap you. You can also trap the examiner, right? So that's why you have to be strong when you say these statements. Each statement, for example, when you routinely write something, you must make sure that each statement, if the question is asked in this statement, I am ready to answer, I am confident to answer. So don't write routinely something in the history. Because it is written lifelong and years long, from first third MBBS you are writing nothing. But we keep on writing that. But in a postgraduate exam, the things will be asked in detail. So that's important. So each line you write, keep asking yourself, in this line, if the question is asked, am I eligible to answer? Am I ready to answer? Then if you are not ready, go back and see. If the question is asked in this line, what SAR said, thin built. SAR cell undernourished. So each line is important. External markers of heart disease, upper lower limb ratio. They will ask you what is upper limb ratio, in which condition it is abnormal, all this. So each line you write, make sure you are confident to answer if a question is asked in that line. So that's very, very important. Right.
Sir, vitals examination, temperature of 98.6 degrees Fahrenheit, pulse of 76 per minute, which is regular, normal volume, no specific character. All the peripheral pulses were well felt. There were no radial or radiofemoral delays and no vessel wall thickening. Blood pressure in the upper limbs, both right upper limb in supine and left upper limb in supine position was 100.
You can go to the findings. You can normal things you tell normal. Go to the cardiovascular.
Okay. So just one question. Go back. You see radiofemoral delay or brachiofemoral delay, which is right?
Sir, it should be brachiofemoral delay, sir.
Why?
Because brachial, compared to the radial artery, femoral artery pulsation occurs earlier, but whereas brachial artery pulsation occurs earlier than femoral artery, so it should be brachiofemoral.
What is the time frame at which the femoral artery, femoral artery pulsation is felt from the aortic opening and the brachial artery?
0.65 to
60 milliseconds is
femoral,
brachial artery
brachial,
and 75 milliseconds is femoral artery. So already you have 15 milliseconds gap between the brachial and femoral. So even a small delay will be better appreciated if you see brachiofemoral delay. Whereas radial is felt after 80 milliseconds after the aortic opening and femoral is 75 milliseconds. They are almost occurring, actually the femoral is actually occurring very close to radiofemoral delay. So even a small delay you may not be able to appreciate if you look at radiofemoral delay. That's why conventionally you must look at brachiofemoral delay because already 15 milliseconds gap is there. So even a slight gap you will be better able to appreciate. So it should be a brachiofemoral delay rather than radiofemoral delay. So that's the only thing I want to just mention. Okay. So how will you say the volume of the pulse? What is normal volume to me may not be normal volume to you. What is high volume to you may not be normal volume to me, maybe normal volume to me. How will you confirm it is volume is normal volume, low volume, high volume, pulse? You say normal volume. So how will you substantiate its normal volume? Very simple thing. You will say just say pulse and say normal volume. But for me it may be high volume. But you must be able to say, no sir, this is normal volume because this finding is there.
Pulse pressure.
Exactly. Pulse pressure. What is normal pulse pressure?
30 to 60.
30 to 50. So you have to look at the pulse pressure. When you mentioned the volume, your subsequent what you write in the blood pressure is very important. You cannot say high volume pulse and give a normal pulse pressure in your BP. Please remember that. So when you are saying normal volume pulse, your pulse pressure between 30 and 50. If it is less than 30, it is low volume pulse. More than 50, it will be a high volume pulse. So what actually happens in the examination is, you do in parts. And when you do one part, you forget the other part. And you will be exactly giving the opposite statement of the previous part. So it should be comprehensive. You must keep on looking. When you write one part, you must look at the previous part and say, this part I am writing is consistent with the previous part I have written. So that's what happens. Because you write in isolation, you would have forgotten it is a normal volume pulse, and you have written the BP of high systolic and low diastolic BP. And that's where you get caught. So keep on, when you are doing the examination, keep on comparing your findings with the previous finding. And each one of them should be correlating together. Because we do inspection as a part, palpation as a part, auscultation as a part. Many of your inspection findings may not be correlating with the palpation. Many of your palpatory findings may not go with the auscultation. Ultimately, we make a diagnosis on auscultation. Right, this time is over, sir? Okay, take that. Okay. Right, start.
Thank you, sir. On examination and inspection wise, the position of trachea appears midline, the shape of chest appears symmetrical, there is a precordial bulge noted in the right side, pulsations are visible 4 centimeters lateral to right mid-clavicular line in 5th and 6th intercostal space. There were pulsations visible in the right parasternal and left supraclavicular region. A scar of 4 into 2 centimeters seen in right second intercostal space, below which a circular bulge is seen. No parasternal heave that is appreciable.
Okay. Parasternal heave seen where?
Is not seen, sir. Usually in the...
Whereas in this patient, when you have apical impulses on the right side, where you will be looking for the parasternal heave.
Sir, on the left side, sir.
For normally, parasternal heave is looking where?
On the left.
For example, normal apical impulse on the left side, where you will be looking at the parasternal heave? In the left.
Left parasternal, 3rd and 4th intercostal.
Similarly, you have to, you want to go to the left to look at the parasternal heave. It should be right parasternal edge. Instead of a left parasternal heave, the right parasternal heave should be the right parasternal edge. Right? Okay.
Sir, on palpation, trachea is confirmed to be in midline. Apical impulse is felt 4 centimeters lateral to mid-clavicular line in the right 6th intercostal space, which is a diffuse character and hyperdynamic in nature. There is a systolic thrill present in the right parasternal area. The scar of 4 into 1 centimeters in right second intercostal space, which has a palpable circular bulge approximately about 6 centimeters metallic in nature. All these features suggestive of dextrocardia.
When you say it's dextrocardia, what is the difference between dextroversion and dextrocardia?
Sir, the apical impulse is shifted down and out to the right side of the...
what is dextroversion? What is dextrocardia?
Sir, dextrocardia, the chambers and the major vessels will also shifted into the counterclockwise.
No, they are
direction.
opposite. Opposite, okay. Chambers are opposite in their orientation. Dextroversion?
No, sir. The chambers and vessels are in the same direction.
So it is only movement.
Movement.
It is only the movement. Okay. Levocardia? What is levocardia?
The normal heart apical impulse, sir.
Normal heart? What is levocardia? Dextroversion. So you must be very. What is dextrocardia? What is dextroversion? Levocardia, mesocardia, all this. You can say it's a normal position, but the normal position of the heart, but levocardia, what happened to the situs?
Sir, there's situs inverse totalis and situs inverse partialis, sir. In totalis, with the abdominal organs, even the heart is rotated to the same side, that is the opposite side, counterclockwise.
Yes.
Whereas in situs inverse partialis, only the heart gets shifted towards the right side.
Isolated dextrocardia.
Isometric dextrocardia.
Okay. Levocardia, you said heart is in normal position. I am saying what happens to situs?
Situs solitus, sir.
Situs?
Solitus.
Okay. Many times you do not know what is normal, you see. You know situs inversus, you know situs ambiguous. But when I ask you what is normal situs is called, we will not know normals. We are all expert in abnormals, but we are very poor in normals. So normal situs is called situs solitus. Right, okay.
Auscultation wise, the right third intercostal space, the S1, S2 is heard of normal intensity, S2 is split, a high-pitched, soft, blowing ejection systolic murmur of grade 4 to 6 in the right third intercostal space with diaphragm of Steth radiating along the right sternal border and increasing with squatting. Mitral area, S1, S2 heard of normal intensity with a split S2 and the radiating murmur of the ejection systolic murmur of right third intercostal space. Tricuspid area.
Okay.
Tricuspid area is also the similar to the above, sir. S1, S2 heard of normal intensity with a split S2 and a radiating murmur of ESM in the right third ICS. In the
you say is the ejection murmur? I will say pan murmur.
Sir, S2 is clearly heard, sir.
What is the definition of ejection systolic murmur?
It starts at the it starts just after the S1, sir, and ends before S2 is heard.
Just start. So there is a gap between the murmur and the first sound, because ejection murmurs can happen only at the semilunar valves. Semilunar valves will open only after isovolemic contraction. So if there is a gap between the murmur and the first sound, it has to be ejection murmur. Whereas when you have a regurgitation, like AV valvular regurgitation, the regurgitation will straight away happen at the beginning of isovolemic contraction. So the murmur will start with the first sound in a regurgitant or a pansystolic murmur. That is the important thing. So you can say that there are two sounds. S2 is split, but you must say what split. S2 split doesn't mean it's like incomplete sentence. It can be normally split, it can be normally widely split, it can be fixed split, it can be paradoxically split. What split it is?
It's a wide variable split, sir.
Wide and variable split. So, okay. So, right. It's a high-pitched, soft.
It is the...
Why soft?
Soft.
High-pitched and soft may not go together. No?
Yes, sir.
Whether it is soft or high-pitched. Why you brought in soft?
High-pitched S2, sir, soft ejection systolic.
So when the examiners see this, the examiners may not be soft. Right? So why you bring in a soft murmur? Soft murmur is hardly heard, no? So this is, you are saying a good murmur. So why are you bring it soft? You can say, just say high-pitched ejection systolic murmur. Even blowing. What do you mean by blowing?
Like how?
So all these terminologies can be easily lead you into trouble. So just say high-pitched ejection systolic murmur of grade 4 physics. That's enough. Okay. Right. Increases with squatting.
Sure.
So what do you think? Why you want to say that?
Sir, in patients who have congenital heart disease, they can have HOCM, HCM, mitral valve prolapse, and also valvular, subvalvular, supravalvular, or valvular aortic stenosis, which can be differentiated clinically on basis of the squatting, sir. Murmurs of HCM and mitral valve prolapse.
This patient had cyanosis at birth. Where is the question of HCM? Where is the question of supravalvular aortic stenosis? Where is the question of asynotic heart disease? So that's the problem, you know. So when you write, these are the conditions which are asynotic. So you are not thinking of those conditions at all from your history. Then why you bring in a physical finding, which is a differential diagnosis for an asynotic heart disease? You tell me which murmurs increases in squatting in cyanotic heart disease and not in asynotic heart disease. Right? You understand my point? Yes, so it's not a differential diagnosis because you are not looking for a cyanotic, you are not looking for a HCM here. Increases squatting, you already said, it will increase the peripheral resistance.
Sure.
And thereby it will reduce your right to left shunting.
Sure.
When you reduce your right to left shunting, what will happen to the pulmonary circulatory murmur? Pulmonary circulatory murmur, so if the right to left shunting is decreased, blood will go where? More blood will go into the right ventricular outflow. So when actually your systolic murmur will increase because you are decreasing your right left shunt and making more blood to go to the RVOT. So the murmur is increasing. So that is the mechanism, isn't it?
Sir.
Right. Okay. Go on. Radiating murmur to ESM, third interval. What happened to the carotids?
It's not radiating to the carotids.
It is not radiating carotids?
Yes.
Okay. Go on.
Sir, in the pulmonary area, S1 heard of normal intensity, a split S2 heard, and
Once again, you are telling me what S2 is. So he said normally wide moving, normally moving, widely split.
Widely split, sir. Widely
Okay, right.
And in the aortic area, the S1, S2 of decreased intensity, the wide split S2 is...
Aortic area here is where?
Sir, it would be on the left second intercostal space, sir.
Okay.
Seeing areas like this.
Yes,
in general cardiology, PG level, tell the space. Left second space, third space. When you have apex, you tell apex. Here again, you don't confuse with the area. We do not know what is there inside. Okay. In general PG level, go for the spaces rather than giving a name to it.
Especially when there is a dextrocardia.
Sir.
Right. Because dextrocardia and a complex congenital heart disease, you do not know below that pulmonary area, pulmonary valve is there. Below the aortic valve is there. You are not sure about it. Then why you to call that area as aortic and pulmonary? Right. So aortic area, okay. Then go to the next slide.
Other systems, sir.
Okay, we'll skip that.
The final diagnosis.
Okay.
So complex congenital cyanotic heart disease, a possibility of tetralogy of fallopathology with situs inversus and dextrocardia, and history suggestive of probable thromboembolic phenomenon and not in atrial fibrillation, no evidence of heart failure infiltrated to endocarditis. Patient is currently in NYHA class 3.
So what is the other important thing you missed here? You said that there is a scar, there is a bulge, something in the right second intercostal space, right intraclavicular area. So you completely missed here in the diagnosis. You said some bulging was there, some scar was there on the right side. What was there?
A permanent pacemaker.
So where is that in the diagnosis? Patient is on?
Permanent pacemaker.
Probably permanent pacemaker. Okay. So now, what are the points against your diagnosis? Who is a good postgraduate, you know? There is a definition of undergraduate and definition of postgraduate. An undergraduate fails to make a diagnosis, fails to make a simple diagnosis. Whereas an postgraduate refuses to make a simple diagnosis. For postgraduate, all mitral stenosis is myxoma. So, a good postgraduate is the one who can argue for and against the same diagnosis. So, he must argue for tetralogy of Fallot here, must also argue it is not tetralogy of Fallot. Then only the postgraduate becomes a good postgraduate. You see, what are the points against tetralogy of Fallot from your history, physical findings? We'll finish at that.
Recurrent respiratory tract infections.
Okay, one. Second, in your physical finding, the most important physical finding, which should not be there in tetralogy of Fallot, you have detailedly mentioned.
The down and out apical impulse, sir.
Okay, that's a very good point, because in tetralogy of Fallot, RVH is not very great, because RV has got, although it facing the RVOT obstruction, it has got one more outlet. Through VST, it is decompressing. So that's why the RVH you may not make out clinically in tetralogy of Fallot. It is not a severe RVH. That's why RV failure is uncommon in tetralogy of Fallot, because RV has got another outlet to go. So to certain extent only it becomes hypertrophy and not a severe hypertrophy. So naturally your heart size cannot be big. So recurrent respiratory tract infection, the heart size is big. Two things. And what is happening to your second sound?
Wide variable split, sir.
So what is the second sound in Fallot?
Single, sir.
Single second sound. Single second sound. That's once again a very important physical finding which is against Fallot. And what is the fourth thing? What is the common, is there tetralogy fellow is a common thing in dextrocardia? What are the congenital heart diseases accompanied by dextrocardia?
Sir, ASD.
Most often transpositions. So in a dextrocardia, most often transpositions are accompanied. Usually tetralogy fellow, usually there may be a abnormal in arch. One of the common accompaniment of arch is right side aortic arch in tetralogy fellow. So this case you have findings. What are the findings for tetralogy fellow? You tell me now. You have already told me the points against tetralogy fellow here. Now tell me what are the points for tetralogy fellow. Because you are diagnosed tetralogy fellow, on which findings you made this diagnosis?
Cyanosis and pan-digital clubbing with the history of and the age of presentation.
Okay, excellent. So one is adult cyanotic heart disease. The most common cyanotic heart disease is tetralogy fellow. So in that you can make. But the cyanotic spells were there. That is for tetralogy fellow. So that is for tetralogy fellow. And patient was cyanosed, clubbing, and he is living. He had some sort of recovery after 7 years, which may tell us there is something opening of some sort of. So these are the findings for tetralogy fellow.
And the presence of ejection systolic murmur also.
Ejection murmur. But ejection murmur, once again, is most often the ejection murmur is due to what? It is due to VST or
pulmonic stenosis.
It is due to pulmonary stenosis. So this patient is a very complex disease. So in this case, we have a dextrocardia, we have an LV, we have a cardiac enlargement, recurrent respiratory infection, and also features such as of decreased pulmonary blood flow plus increased pulmonary blood flow. So what we can offer will be a patient who started with a decreased pulmonary blood flow, subsequently would have developed some amount of collaterals and has increased pulmonary blood flow. Once you increase the pulmonary blood flow, it is a left to right shunt, isn't it? What is collaterals? It is left to right shunt. So when you have a left to right shunt and more blood coming to the LV, so the LV gets dilated. So that sort of explanation we can give. But what is important in this case is physical findings, good history. The diagnosis is very difficult in this case. Even after echocardiography, it is going to be very difficult because there is no definite diagnosis can be made. There are certain points for increased pulmonary blood flow, decreased pulmonary blood flow. There is some points for tetralogy fellow. There are some points for increased pulmonary blood flow like TGV or something. So all these things are there. So even TAPVC, total anomalous pulmonary venous connection. So it can present with the wide splitting of second sound. It can be a cyanosis, but patient will have a RV failure, but this patient did not have a failure at all.
No failures.
So all these things are matter. So to sum up, I will say this is, first you have to make sure what are the conditions you have at cyanosis at birth and cyanotic spells, and what we can see is a complex cyanotic heart disease. So please remember, don't give a straight away tetralogy fellow here. We can say that I'll discuss differential diagnosis. So I will discuss differential diagnosis. I'll say these are the points for Fallot's tetralogy. These are the points against Fallot's tetralogy. So this may be a complex thing or tetralogy of Fallot to start with, and subsequently happen something which has produced the findings today. And rather than straight away telling it is tetralogy of Fallot. Okay. But from your clinical point, especially when you are giving wide split, normally moving second sound, you cannot give a diagnosis of tetralogy fellow. What is the condition which will produce normally split, widely moving second sound? Because you said that, what is the condition which will produce that?
VST.
VST. Okay, AST. Nice. Second?
Wide fixed splitting, AST.
MR. Widely split, normally moving. Right bundle branch block. Widely split, normally moving. Pulmonary stenosis, wide split, normally moving. So these are the conditions in which there may be widely split, normally moving second sound. So that's why you don't give that diagnosis of tetralogy of Fallot straight away, because there are so many points against, especially in your physical finding, when you have two sounds, and this is exactly against the tetralogy of Fallot. Tetralogy of Fallot, the typical second sound is single second sound. So when you are saying it's wide split, and don't give a diagnosis of tetralogy straight away. Right, otherwise your presentation is nice. So just remember my points in presentation. So try to improve your skills and go through the cyanotic heart disease approach. Cyanotic heart disease approach is very, very easy, especially when you go to pedal off. It is increased pulmonary blood flow, decreased pulmonary blood flow. The decreased pulmonary blood flow is divided into RV dominant, LV dominant. Decreased pulmonary blood flow. RV dominant with pulmonary hypertension, without pulmonary hypertension. RV dominant with pulmonary hypertension is Eason-Menger. A reversal of all your shunts where there is going to be tardive diagnosis. Right ventricle dominance, decreased pulmonary blood flow, tetralogy of Fallot, pulmonary atresia with VST. Decreased pulmonary blood flow, left ventricle dominant, only one condition, tricuspid atresia. That's all. Approach cyanotic heart disease, this is. Increased pulmonary blood flow, TGV, transposition, TAPVC. Whereas decreased pulmonary blood flow, RV dominant, LV dominant. RV dominant with pulmonary hypertension, without pulmonary hypertension. LV dominant, tricuspid atresia, rarely pulmonary atresia with intact intraventricular surround, that's rare. Sometimes sepsis anomalies also they suggested. That's all the approach to cyanotic heart diseases. It's not very difficult actually. Right, thank you.
Thank you, sir. Thank you, sir.
Thank you, Dr. Hari and Dr. Prashant. We would like to thank the moderators for chairing this session. It gave us comprehensive overview on congenital heart disease and also many tips for conquering the exams. Thank you, sirs. Next session will be a case presentation by Dr. at Srihar, Chennai. He is an alumnus of Stanley Medical College, Chennai. He completed both his undergraduation and post-graduation from Stanley Medical College, Chennai. And he has more than 25 years of teaching experience. He has published multiple journals in prominent journals like American Journal of Cardiology, Indian Journal of Gastroenterology, and JAPI. He conducts regular workshops on BCLS and ECG workshops for medicos and paramedics. BLS workshops he is conducting for the public also. He has been a co-investigator in multiple clinical trials. We welcome you, sir.
Good afternoon. Myself, Dr. Pratyush, and Dr. Durga Prasad will be presenting the second case on cardiovascular system. Female patient, age 55 years. She's hailing from Thiruvarukadu, Chennai. So she's a daily wage worker in a construction site. Her chief complaints are palpitation 1 month ago and easy fatigability since 1 month. History of present illness. Patient was apparently normal 1 month back, following which she developed an episode of palpitation, which was sudden in onset with the patient being at rest and lasted for around 2 hours. Patient described the episode as an unpleasant awareness of her own heartbeat that was fast and regular. It was not aggravated on exertion. The episode resolved spontaneously within 2 hours. It was associated with left lateral chest pain, which was of pricking type. Again, there was no specific aggravating or relieving factors and no radiation. It also resolved spontaneously. Patient complained of extreme tiredness when she had the episode of palpitation. Coming to negative history, there is no history of dyspnea, paroxysmal nocturnal dyspnea, orthopnea, hemoptysis, repeated respiratory tract infection, dysphagia, dysphonia, dysarthria, oliguria. No history of syncope, pre-syncope, fatigability and angina on exertion. No history of right hypochondriac pain, abdominal distension and lower limb swelling. No history of rheumatic fever in childhood.
So, 1 minute, that you said previous slide you go. I think fatigability was mentioned as the presenting complaint. You go back. First slide. Yeah, easy fatigability 1 month. Next slide. No history of syncope, pre-syncope, fatigability, angina, and exertion. This is what. So that's what you do it as a routine, isn't it? So you forgot what you have mentioned in the first slide. And the second slide, you are exactly mentioning that history is not there. So that's why you have to keep the comprehensive and keep looking what you have done in the previous segment and whether the next segment, your findings and our presentation is consistent with the previous segment, isn't it? So the patient had a palpitation. So you have given extensive history of palpitation, right?
Yes, sir.
So what do you think the cause of palpitation is?
Sir, it could be cardiovascular system. The most common will be cardio. When we
Why
say,
it's a cardiovascular palpitation? Cardiovascular means you think it's an arrhythmia.
Arrhythmia, sir.
So how will you differentiate cardiovascular palpitation from arrhythmia and non-arrhythmic cardiovascular palpitation? Is there a condition which can cause non-arrhythmic cardiovascular palpitation?
Sir, on exertion.
No. Any other cause of palpitation other than arrhythmia in cardiovascular system?
Sir,
cardiac system. We will not say cardiovascular system. In the heart.
So, any structural heart diseases can cause.
What structural heart
valvular
disease?
Heart disease can cause.
What valvular heart disease?
Sir, mitral stenosis.
No. See, please remember, a chronic volume overload, the patient will complain of palpitation. It is due to vigorously pumping of the heart. The patient will feel throughout the day. It may slightly increases on exertion. So the patient will see a vigorous thumping of the heart throughout the day and slightly increasing on the heart. This is due to chronic volume overload like mitral regurgitation or an aortic regurgitation, right?
Yes, sir.
So this is a paroxysm. This is a paroxysmal palpitation.
Yes, sir.
So it could be a paroxysmal palpitation, means it has come from an arrhythmia, right? So what is the arrhythmic palpitation is? It is abrupt in onset and abrupt in offset. You said it is abrupt in onset, but you have not said about offset. That is,
sir,
how did it?
It lasts for 2 hours.
Spontaneously. That is resolved spontaneously. Whether it is resolved gradually or abruptly. That is the most important thing. Because a sinus tachycardia will gradually increase and gradually come down. Gradually increase and gradually come down. Arrhythmia, abrupt. Particular second, the patient feels heart rate very fast and 1 second it will stop. That is an arrhythmia.
Yes.
So this is a very important history is whether it is abrupt in onset and abrupt in offset, or gradual in onset and gradual in offset, or abrupt in onset and gradual in offset.
Yes, sir.
Regular or irregular.
Okay.
So from your history, you think there is a paroxysmal tachycardia.
Tachycardia. Yes, sir.
That is probably regular. That is probably
regular. Sir.
Regular. So if you think it is a paroxysmal palpitation, a regular palpitation the patient had, what are the conditions of? What are the arrhythmias you will think of?
Sir, if it is regular, then we can think of supraventricular tachycardia.
Yes.
We can AVNRT, AVRT.
Okay.
Then atrial tachycardia, like focal atrial tachycardia.
Good.
Then junctional tachycardia could be
AVNRT, AVRT, all are junction tachycardias only.
Okay.
Can you think of ventricular tachycardia? It is also regular. It is also tachycardia. Can you think of ventricular tachycardia in this patient?
But
possible. Please remember, not necessarily all SVTs are hemodynamically stable, and not all VTs are hemodynamically unstable. Even VTs can have in a stable heart. The patient may come with VT, but stable heart. So that is also a possibility is there. Okay, from the palpitation we know it is probably a regular cardiac palpitation, paroxysmal palpitation. It may be any one of the things you have mentioned.
Yes.
She has got easy fatigability. These are the two history you have.
Yes, sir.
Right. Go back.
Coming to the past history, no history of diabetes, systemic hypertension, pulmonary TB, bronchial asthma or any other heart disease. Surgical history, no past surgical history. Again, treatment history, she was not on any medications previously. Personal history, bowel and bladder regular, sleep and appetite normal, no substance abuse. Family history, she's born out of non-consanguineous marriage, no history of any sudden cardiac death in the family. Menstrual history, she attained menopause at the age of 10 years back.
What are the conditions which will produce sudden cardiac death in the family?
Sir, cardiomyopathy, sir.
What cardiomyopathy?
Hypertrophic cardiomyopathy.
Okay, what else? So this is in this case, why you want to mention sudden cardiac death. So you must ask, this is the trap, the examiner's trap. So you have to list the conditions in which sudden cardiac death will happen in the family. WPW syndrome, Brugada syndrome, long QT syndrome, short QT syndrome. So they will go to long QT. What are the types of long QT? What drugs will produce long QT? So these are all the things will go on from this, a sudden cardiac death. Okay, right. Go on. What important history is missing? Anybody? What important history is missing in this case? Yes? Obstetric history. Very, very important history in any cardiovascular examination. Because in a lady, you want to know this particular cardiac condition is aggravated by pregnancy, was not aggravated by pregnancy. So that's a very important history. How many children she has?
She has 2 children, sir.
So any increase in the symptoms at that point in time?
No, sir, no.
What is the age of the last child?
Sir, 34, sir.
Okay, that you have to mention here.
Oh.
So that means, so what are the conditions which will increase in pregnancy? Cardiac condition which will worsen in pregnancy. Yes.
So
yes.
valvular heart disease.
Yes.
AS.
Any obstructive lesions will increase in pregnancy. Please remember. Any obstructive lesion, maybe it is AS, MS, hypertrophic cardiomyopathy, pulmonary stenosis, everything will increase in pregnancy. Then right to left shunt will increase in pregnancy. Pulmonary hypertension will increase in pregnancy. Coarctation of aorta. So all this will increase in pregnancy. So in these conditions, we will not allow the pregnancy to happen. What are the conditions which become less in pregnancy, which we can allow? What are the conditions which will become better in pregnancy? Not as if all conditions will increase in pregnancy or will deteriorate in pregnancy. There are conditions which will become little better in pregnancy. What are they? Yes? Anybody? What are the conditions the patient's cardiac condition will become better?
Simple left to right shunt.
Exactly, good. A simple left to right shunt will become better because of increase in peripheral vasodilatation. The left to right shunt becomes less because more blood will go into the systemic circulation rather than left. Any other condition? Any regurgitant lesion will become less. Please remember. Stenotic lesions will become worse. Regurgitant lesion will become less. Once again, because of the peripheral vasodilatation, instead of leaking back into the ventricle or in the atrium, the blood will go out into the systemic circulation. Any other condition will become better in pregnancy? Okay, go on. So this did not become, so absolutely there was no problem at that time.
At the time of pregnancy.
HCM, sir?
Yes?
HCM.
Epstein's is depends upon HCM. HCM is once again it's very difficult to say because the increase in heart rate will increase obstruction. Increase in preload, peripheral vasodilatation will actually worsen HCM. So it all depends upon whether the patient has got obstruction or no obstruction. So all this. So it is both. It can be both depending upon the obstruction or no obstruction. So there are certain features of pregnancy which will increase, which there are certain things which will decrease. Because of increased preload will decrease the obstruction. Sinus tachycardia will increase obstruction. So both situations are there with HCM. Right.
So history summary. 55-year-old female with no known comorbids. She has now presented with complaints of 1 episode of palpitation. which was sudden in onset, that lasted for 2 hours, which was fast and regular in rhythm, and associated with EC fatigability. So the provisional could be an episode of a transient arrhythmia, possibly a SVT, supraventricular tachycardia, secondary to an valvular heart disease, sir.
But you have written transient atrial fibrillation.
Most common in valvular
You
heart
already
disease.
said, this is what it's saying again. In palpitation, you said it was a regular palpitation. But in the summary, you are giving atrial fibrillation. So this is the thing what happens, no? So you have written history independently of whatever you have mentioned in the previous history findings. That's why I keep on saying, always compare the previous segment before you write the next segments. So you said a regular tachycardia. So it cannot be atrial fibrillation.
Sir, if it is fast rate, then the patient won't be able to identify the rhythm.
Then you do not say regular there. If you think it's still atrial fibrillation, you should not commit there, it is regular. But you specifically said it is regular. And then giving an explanation of rapid AF appearing regular to the patient is so far-fetched, no? So you don't commit regular. Patient is not very definite about, so you can say that here, patient had a palpitation. She is not very definite about whether it is a regular or irregular palpitation. So many of our patients who are not well educated may not be able to tell you whether it is, they may not be able to tap you and give you a regular palpitation or irregular palpitation. Then don't commit there. It is a regular palpitation. Patient says palpitation and she is not very definite about regular or irregular palpitation. Then you can say anything here, rather than committing yourself on a regular palpitation there. Right?
Yes, sir.
Okay. So what do you think the condition is? Because at the any cardiovascular system, apart from congenital heart disease like we saw last time, you must come to a diagnosis at the end of history or the possibilities of the diagnosis at the end of history. You can also.
Sir,
what do you think that disease may be? It is an acquired heart disease.
Heart disease.
That's definite. Okay. It is an acquired heart disease. What do you think the heart disease may be?
It's a valvular heart disease.
Valvular heart disease.
And
abdominal swelling, liver swelling, or leg swelling, we know right heart failure. Right? Both things are not there. So left heart decompensation is not there, right heart decompensation is not there. Whether it could be, so from that we do not know. Palpitation means, if you say a valvular heart disease, palpitation means there may be due to some chamber enlargement or a chamber disease. One chamber, because of the valvular problem which has got enlarged, would have produced a palpitation. That we can explain. EC fatigability?
So our fixed output, cardiac output can cause.
Exactly. So whenever there is a fatigability, tiredness or exertional syncope or exertional angina, you must think of an obstructive lesion. Whereas whenever there is a long-standing continuous palpitation and also the patient having a PND and orthopnea or on the right side edema, you think of a regurgitated lesion. So here, if at all we can think of is, fixed output obstructive lesion which has caused tachyarrhythmia. So what are the possibilities? Fixed outflow obstruction lesion which has caused a transient arrhythmia. That's what from the history. So what are the possibilities?
So aortic stenosis can cause.
Aortic stenosis is a possibility.
Then hypertrophic cardiomyopathy.
You said it's a valvular lesion. Right. Then
MS. Mitral stenosis.
Right. So you already committed it is a part of valvular lesion because it's acquired and is appearing at this age. So we think of valvular lesion, we have to think of only two lesions, mitral stenosis, aortic stenosis. You see, from the history itself. Because of the fatigability, tiredness and arrhythmia. So she should have, fatigability tells you there may be obstructive lesion. Arrhythmia tells you there is some chamber enlargement which is irritable. So with this, we go to the physical findings. Right.
Good afternoon, sir. Coming to general examination, the patient is conscious, oriented to time, place, and person. The patient is thin built and moderately nourished. Height is 155 centimeters, weight is 52 kg, BMI is 21. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. Arcus annulens is present.
What is her age?
55. Sir.
So you think 55 arcus annulus will be present? What is the age at which arcus annulus may be obvious?
60.
So if there is a young age patient who has got arcus annulus, what are the conditions you think of? Young patient having arcus annulus, what are the conditions you think of?
Atherosclerosis.
No, atherosclerosis is there, but what?
Dyslipidemia.
Familial hypercholesterolemia. Usually it is heterozygous because homozygous familial hypercholesterolemia patients may not live to adulthood. So it may be heterogeneous familial hypercholesterolemia is the one which you must think of when the arcus annulus is early. Okay.
Pulse rate is 68 beats per minute, regular rhythm, normal volume pulse with no specific character, and there is no radial delay or no radiofemoral delay. There is no vessel wall thickness, and all peripheral pulses are palpable equal on both sides. And blood pressure is 120/70 in both upper limbs in supine position, with a pulse pressure of 50 mmHg, and bilateral lower limb BP is 130/90 mmHg in prone position. Respiratory rate is 16 breaths per minute, thoracoabdominal, and no usage of accessory muscles. There is no external markers of atherosclerosis or infective endocarditis.
Okay. From this general examination findings, our diagnosis was MS or AS. So these physical findings help you to differentiate whether we have MS or AS.
AS will have a low volume pulse, sir.
What is your pulse pressure?
Pulse pressure is 50 mmHg.
Upper limit of normal.
Yes.
So what pulse pressure you expect in AS and MS?
AS it will be low pulse pressure.
In MS and AS, what pulse pressure you expect?
Low pulse pressure, sir, less than 30.
So this point is little bit against your diagnosis. So you have to recheck your blood pressure. So please remember that when you are, see, ultimately you know last diagnosis. So even when your pressure is like this, you must either explain why it is like this, or you have to make sure you are putting a low pulse pressure because you know your diagnosis. When you are presenting, you know your final diagnosis. But when the pulse pressure is there, that you think this is going to be a problem. So recheck your pulse pressure and you must give an explanation. If the particular diagnosis is there, still pulse pressure is wide, what are the possible explanations? You have to give ultimately at the end. I will remember this. Right. What is the normal pressure difference between upper limb and lower limb?
10 to 20
Sorry,
millimeters.
pulse, not BP. BP difference.
10 to 20 mmHg, sir.
If it is lower limb pressure is less, what are the conditions?
Characterization of aorta.
Yes. Peripheral arterial disease, aortoarteritis. If the lower limb pressure is higher than the upper limb pulse, upper limb BP of more than 20, what is the diagnosis?
Aortic regurgitation can be
exactly. Right, good. So, lower limb pulse can be. Why lower limb pressure is higher than the upper limb?
Because of the disparity between the cuff and the...
No. Then you are not estimating this. Your technique is wrong. Then you cannot rely upon that pressure. Why normally, even if you take your big cuff or thigh cuff and estimate the pressure in the lower limb, it is higher than the upper limb. Why? Up to 20 millimeters, it can be high. Why? Because as you know, the pulse is nothing but transmission of pressure. It is not the transmission of volume. The pressure travels faster than volume. Pressure travels at 5 meters per second. Your volume travels at 50 centimeters per second. So what you see is the pressure. Because as you know, it is in the direct line with the aorta. Femoral artery is in direct line with the aorta. your pressure transmission is much more obvious in the arteries which are directly in line with aorta rather than on the brachial, which is little bit angle or little bit vertical, little bit horizontal to your aorta. That's why the pressure transmission is more obvious in the femoral artery. That's why your femoral pressure is up to 20 millimeters higher than your upper limb blood pressure. So that is the reason.
Okay, sir.
Okay.
Coming to JVP, JVP is elevated. It is seen at 4.5 centimeters from the sternal angle in recumbent position, semi-recumbent position. Two waveform is seen with prominent A waves, and it is better seen than felt, and it is more laterally located pulsation in the neck, and it varies with respiration and diminished on applying pressure on the root of neck. Between the two heads of sternocleidomastoid, and inward type of impulse is seen, and the JVP is elevated with the pressure over the periumbilical area, hepatojugular reflex.
So what is your inference from JVP? So what the JVP means?
It indicates the central venous pressure. It indicates central venous pressure.
P stands for what? Pulse and pressure. It is not the pulse alone. Pressure and pulse. In P stands for pressure and pulse. So it will tell you whether pressure is elevated. So you have to explain two things. Whether the pressure is elevated, that is the height of your JVP. Then the waveform tells you why the pressure is elevated. What is the condition which is causing that pressure elevation is seen by the pulse. So you have to explain the pressure, you have to explain the pulse. Then tell me, this is the condition which has increased the pressure, because this waveform is like this. So what is your inference from JVP?
When there is prominent
it
A
is a
wave,
normal pressure or abnormal pressure from JVP?
Abnormal pressure, sir.
Abnormal pressure where?
In the right atrium.
Right atrium, very good. It's abnormal. Why it is abnormal pressure? 44.5 centimeter is abnormal pressure?
4.5 centimeters, yes, sir. And it can be because of
what is the normal elevation of?
Up to 3 centimeters.
Up to 3?
Below 3 centimeters.
Anybody? In my undergraduate days, I choose number 45 and 4.5. At 45 degrees, I used to think 4.5 is the upper limit. Right? Usually it is above 4.5. Please remember, this is from your sternal angle. And your midpoint of the right atrium is 5 centimeter below this sternal angle. So that means your total venous column is 4.5 plus 5. That is 9 centimeter is your entire venous column from the midpoint of the right atrium. The calculation is 1.2 centimeters equal to 1 millimeters of mercury. 1.2 centimeter is equal to 1 millimeter of mercury. Now 4.5 centimeter from sternal angle and 5 centimeter from the midpoint. So your total venous column is 9.5 centimeter. So 9.5 centimeter divided by 1.2 will give you the mean right atrial pressure. That is the object of seeing JVP. You can indirectly calculate the right atrial pressure. So 9.5 divided by 1.2, what is it?
8 millimeter Hg.
7 to 8. Normal upper limit of right atrial pressure is 7. So it is almost normal. That's why I used to remember 4.5. So if at all it is only mildly elevated. This is how the importance of JVP. It is not the elevation. You ultimately go through 4.5 plus 5 total column plus 1.2 centimeters roughly equal to 1 millimeter of mercury. So the total venous column divided by 1.2 will give you right atrial mean pressure. So right atrial mean pressure here is almost upper limit is 7. Left atrium it is 12. So its upper limit is 7. It is almost 78. So little bit. So now you tell me from your pulse why this is mild elevation. The pulse, then you look for A wave, V wave and tell me why this pressure, why this right atrial pressure is elevated. Tricuspid stenosis or what has elevated this right atrial pressure?
Looking at the waveform, there is prominent A waves, yes, which can be seen in tricuspid stenosis and cannon waves in junctional rhythm.
So this is inviting trouble. So nobody asks you cannon wave now. So I will ask you what is the difference between giant A wave and cannon A wave? Where conditions will produce giant A wave and cannon A wave? So all these problems are there. So A wave means right atrial contraction is increased. That's all. A is right atrial contraction. Then comes X descent, right atrial relaxation. Then comes V wave, right atrial filling. Then comes Y descent, right atrial emptying. That's all the JVP is. Right atrial contraction, right atrial relaxation. So whenever right atrial pressure is increased, you have a positive wave. Whenever the right atrial pressure is dropping, you have the negative wave. Right atrial contraction increases the right atrial pressure. X descent is right atrial relaxation, where the right atrial pressure is dropping. V wave, right atrial filling, right atrial pressure increases. And Y descent, tricuspid valve opens and right atrial emptying produces Y descent. So when you have increased A wave, means there is increase in right atrial contraction. So why the right atrium is contracting and right atrial pressure is high in this patient? When your diagnosis is probably mitral stenosis.
It can be
Yes?
Pulmonary hypertension.
Yes. So this is indirect clue regarding presence of the pulmonary hypertension. Okay. What is invert type of impulse? I'm not sure why it is written there. I'm not aware of that. What do you mean by that? Invert type of impulse. Why it is written and what do you mean? Something you have written, you must explain. That's what I'm telling you. People ask you, what do you mean? Why you want to write that? Invert type of rate.
Compared to carotid, it is more indrawing, so the pulse is.
No, I think don't mention all that because this tells us that your negative waves are prominent. See, please remember, when you look at the JVP, you must see whether your positive waves are prominent or the negative waves are prominent or both positive and negative waves are prominent. So whenever there is a cardiac lesion, heart failure, right ventricular failure, right atrial pressure rise, your positive waves are prominent. A and V waves are prominent. So whenever JVP is elevated, if your positive waves are prominent, it tells you it is an intracardiac pathology. Whereas in the absence of positive wave prominence, it is only negative waves are prominent. If you can see, only X and Y descent are prominent. You will not see the positive wave. You will see just the collapse of JVP. If X and Y descents are prominent, when negative waves are prominent, it is constrictive pericarditis or restrictive cardiomyopathy. So when the JVP is elevated, you have to see whether the positive waves are prominent or the negative waves are prominent. The negative waves are prominent, it is most often constrictive pericarditis. It is also JVP is elevated. They will also edema. They will also come with ascites. But how to say from the JVP elevation it's a cardiac failure or a constrictive pericarditis? Because the treatment is different. If you give diuretic in constrictive pericarditis, patient will go for hypotension. You should not give a diuretic because preload dependent condition. Whereas in heart failure, you have to give a diuretic. So that's the JVP helps you. Just seeing the JVP will tell you whether this edema and heart failure, whether this ascites in heart failure is due to constrictive pericarditis or right heart failure. Looking at the prominent waves and the negative waves. So this confuses me when you say inverted type of, I assumed that the negative waves are prominent. Okay.
Coming to CVS examination, on inspection, chest wall appears symmetric and normal in shape. There is no sternal or the spinal deformities. Trachea appears to be in midline, and position of apex beat was not visualized. And visible pulsations were seen in the suprasternal area. There is no precordial bulge or engorged veins and scars and sinuses.
So what is the cause of suprasternal pulsation?
It can be seen in aortic arch aneurysm, sir.
Okay. So you think aortic aneurysm is there in this patient? So once again, when you write the findings, you see whether it is consistent with your original diagnosis. You know original diagnosis. So your original diagnosis can be aortic stenosis or mitral stenosis. In both, what will be the aortic pressure? It is low or high?
Low, sir.
In a low aortic pressure situation, can you see a suprasternal pulsation? So, once again, this will be, you have to explain. Why in an obstructive lesion where you expect the aortic pressure to be low, you will have a suprasternal pulsation, means there is an increase in aortic pressure, there is an increase in volume overload. So that's why you don't routinely write. Even if you see that, you just see whether you can explain that. If you do not explain that, people are not going to see. Examiner is hardly examining this for 2 minutes. So he will not be seeing the suprasternal pulsation and ask you, why you have not mentioned suprasternal pulsation. If it is relevant, they will ask you, like aortic regurgitation or aortic stenosis. Okay, go on. The time is up.
On palpation, trachea position is confirmed to be in midline. Apical impulse was localized to left fifth intercostal space, 1 centimeter medial to the left midclavicular line, and it is tapping in character. And a palpable thrill was felt over the apex. And in left second intercostal space, palpable P2 was felt, and parasternal heave was visible, palpable, and obliterable in the left parasternal area, which is of grade 2. Epigastric pulsations were felt, and there is no tracheal tug sign.
Okay, what is the thrill? Diastolic thrill or systolic thrill?
That's a diastolic thrill, sir.
Diastolic thrill. Yes, okay. So what is tapping there? What is the character? What is the tapping apical impulse?
Tapping apical impulse is a palpable S1 which can be seen in mitral stenosis, sir.
Okay, right. Okay, so the heart is not. What is the character of the apical impulse? It's tapping. It is not heaving. Okay. You have a parasternal heave like this. So you have finished palpation, isn't it? So now you tell me the diagnosis. You need not auscultate at all. Now you tell me the diagnosis. The auscultation is not necessary.
Mitral stenosis.
Because at the end of your history, it was AS or MS.
Yes, sir.
So now you don't have a heaving apical impulse. You don't have an ejection murmur. You don't have the murmur in the aortic area, and you have a tapping apical impulse. You have a palpable parasternal. Pulmonary hypertension is more common in mitral stenosis when compared to the aortic stenosis, because aortic stenosis take a very long time to have a pulmonary hypertension. That is also shown by your A wave. So all these things. So at the end of your palpation in cardiovascular examination, at the end of palpation, your diagnosis should be out. Auscultation is confirmatory. So now what is your diagnosis?
Mitral stenosis with pulmonary artery hypertension.
That's all. You see, if you go through the history properly and you do your examination properly and correlate each one of them together, you will come to a diagnosis in cardiovascular case at the end of palpation. Auscultation is only confirmatory. So that's what so easy is a cardiovascular case. Provided you go through from the history, because from the history you don't think of something, you just summarize the history and don't think of something. And when you think of something, from your general examination you must accumulate the points for your diagnosis. Okay, come to this thing.
Percussion right heart border corresponds to the right sternal border, and left heart border corresponds to the apex, and right and left second intercostal spaces are resonant.
Okay.
Coming to auscultation, at the apex, that is in left fifth intercostal space, 1 centimeter medial to the midclavicular line, S1 and S2 are heard. S1 is loud and S2 is soft. There is a murmur which was heard in the apex, mid-diastolic murmur, rough and rumbling with low pitch and
why you say it's a loud S1? Whatever is loud for you may not be loud to me. How to say it is a loud S1 clinically?
Loud S1 will be heard with equal intensity in all the areas, sir.
No. How will you say loud S1? And how will you say loud S2 clinically?
If the S1 is louder than aortic sound in aortic area, it's louder.
Exactly, good. So in aortic area, if your first heart sound is louder than the second sound, then the first sound is loud. So to say first sound is loud, you have to auscultate aortic area. Please remember. Similarly, to say the second sound is loud, you have to auscultate mitral area. In mitral area, your second sound is louder than the first sound, then the second sound is loud. So this is the clinically to say whether this particular sound is loud or not. Right. That is the explanation. So don't put your stethoscope in the mitral area and say first sound is loud. Then there is objective means by which you can substantiate this S1 is loud. Good. Okay.
The murmur at apex is mid-diastolic murmur and rough rumbling in character, which is low pitch, and grade is 4/4 because
This chorus we know from the final year, we know left lateral position held in deep inspiration, deep expiration, better heard with the bell of the stethoscope. So all this chorus we know. So tell your that chorus is there, bell of the stethoscope, and why it is better heard with the bell of the stethoscope?
Because it is a low pitch murmur.
So what are the other sounds which are heard better with the bell of the stethoscope?
S3, S4, and mid-diastolic murmur of TS, tricuspid stenosis.
And
pericardial knock.
No, pericardial knock is little bit loud sound. So even the first heart sound is not, it's better heard with the bell of the stethoscope. So how will you recognize a person that he knows cardiology is when the person auscultates with the bell in the mitral area. So he starts the auscultation with the bell in the mitral area, he knows cardiology. Okay? Because of the majority of sounds in the apex are heard better with the bell of the stethoscope. Your mid-diastolic murmur, third heart sound, fourth heart sound, and also your first sound, all are low-pitched sounds. So a person should start auscultation with the bell of the stethoscope in the mitral area, and also come to the tricuspid area with both bell and the diaphragm. Whereas over the base, it should be the diaphragm. Because your ejection murmurs are, the early diastolic murmurs are better heard with the diaphragm. Okay, we'll accept all that. Okay, great. And one thing, grade 4/4, pre-systolic accentuation. Okay, right.
And there is one more murmur heard in the apex, that is systolic, and so character is soft, high pitch. Grade is 2/6 without a thrill, and it is radiating to the left axilla, best heard in expiration and in supine position with the diaphragm of the stheth, and it is increased with hand grip, probably a mitral regurgitation murmur.
So you are not said the timing is systolic. That is not complete.
That was early to mid systolic murmur.
What murmur? What systolic murmur?
Early and mid, it covers the early and mid systolic murmurs.
Early and mid systolic murmur do not go together.
It's more like a pan-systolic murmur.
So you have to
heart disease involving the mitral valve, and the probable lesion is moderate mitral stenosis with mild mitral regurgitation, and the most common etiology is rheumatic in origin. It is associated with pulmonary artery hypertension, and there is no evidence of ongoing atrial fibrillation or cardiac failure or infective endocarditis.
Okay, why you say it is moderate mitral stenosis? I will say it is a severe mitral stenosis. What are the points to say it's a moderate mitral stenosis? And points to say why your mitral stenosis is dominant over your mitral regurgitation.
The mid-diastolic murmur is heard in continuation with the pre-systolic accentuation.
What is clinical pointer to say severe mitral stenosis?
Start with pulse and BP.
Yes. Now you go back to your BP now.
There will be low volume
pulse. Go
pulse.
back to your BP.
There will be low volume
120,
pulse.
70. So in a severe mitral stenosis, it would have been much lower, isn't it? So, but it cannot be a little bit longer, but because of the normal pulse pressure, it cannot be a very severe. So now you go back. So you have forgotten that. When I am asking why moderate mitral stenosis, you have forgotten the pulse volume I mentioned. So you can bring that. My pulse volume is normal. My pulse volume is not a low volume pulse. So I think it's not a regular. But why you think the mitral stenosis is dominant over mitral regurgitation?
There is
when two lesions are there, you must say the dominance.
There is a palpable diastolic thrill in the apex.
So one thing is, what is the location of your apex?
Fifth, left fifth intercostal.
In a mitral regurgitation which is dominant, where will be the apical impulse?
It will be shifted lateral and down.
So it is not a volume overload. The apical impulse is not significantly shifted. I felt there is a classical opening snap. So the opening snap is there. The difference between mitral regurgitation and mitral stenosis is one, the apical impulse will be shifted down and out in mitral regurgitation if it's dominant. And the diastolic sound you hear in mitral regurgitation is third heart sound because of the exaggeration of early rapid filling. Whereas the sound you hear in mitral stenosis, if it is going to be dominant, is opening snap. And also the apex is not shifted. Type of apical impulse is not forcible. You said it is tapping.
Yes, sir.
So these are the situations you think it moderate mitral regurgitation. And if at all there is a mitral regurgitation, mild regurgitation is there because the LV is not enlarged and you hear opening snap rather than third heart sound. MR, because of the early rapid filling, what happens is the mitral regurgitation pushes all its blood in systole into the left atrium. In subsequent systole, because the left atrium has got large amount of blood, the early rapid filling is exaggerated. The third heart sound is caused by early exaggeration of, so that will be for third heart sound. So if the third heart sound is present, one disease which is out is mitral stenosis. Because stenosis, you cannot have an exaggerated early rapid filling. It will not allow. So one sound which will rule out mitral stenosis is third heart sound. Whereas if the opening snap is present, mitral stenosis is dominant.
Okay.
Okay, right. What will be your line of management in this patient? So you not mentioned anything about the tachycardia she had. Atrial fibrillation minus you said. So what is the tachycardia she would have probably had? No.
Paroxysmal atrial fibrillation.
Exactly. Not atrial fibrillation once again.
Yes,
Probably because you said regular, it could be, if you are committed regular, it could be a paroxysmal atrial tachycardia. So whenever the left atrium is dilated, it can go for atrial tachycardia or atrial fibrillation. Because you said regular, it could be one episode of paroxysmal atrial tachycardia because of the dilatation of left atrium, which can produce ultimately go in for atrial fibrillation.
Okay.
So if you said, if you are not committed regular in your history, you could have said probably more common. Atrial fibrillation is more common than atrial tachycardia. So you have said an episode of probably atrial fibrillation. So what is your management?
Since the patient came with history of paroxysmal tachycardia, we'll give beta blockers as the first line medical treatment.
No. Investigations first. You have to confirm your diagnosis.
ECG and 2D echo, sir.
ECG, what will you see?
Right ventricular hypertrophy can be there.
When we say mitral stenosis, you should not start with right ventricular hypertrophy.
Left atrial enlargement.
Exactly. You start with left atrial enlargement. Right. Then probably right ventricular enlargement. So what if the moderate mitral stenosis, what is the area likely to be in echo? What is the normal mitral wall area?
5 centimeters square, sir.
5.1?
4
is
to
normal
6
or abnormal?
centimeters square, sir.
4 to 6 square centimeters. So in the moderate stenosis, what is likely to the mitral wall area?
1.6 to 2.0.
1.5 to 2. 1.5 to 2 is going to be mild. 1 to 1.5 is moderate. Less than 1 is severe. So it is likely to be 1 to 1.5 from if your clinical diagnosis is right. So you want to do the medical line of management here or intervention here?
Medical line of management will
So
be
if mitral stenosis is confirmed and it is going to be moderate, the symptoms decide. Please remember, less than 1, you can do an intervention. Between 1 to 1.5, the symptoms will decide. The patient is dyspneic, patient has got recurrent episodes of atrial fibrillation like this, which will predispose the patient for complications. Still, you can intervene between 1 to 1.5. Patient has got a severe pulmonary hypertension, patient is dyspneic on exertion. So please remember, you are doing assessment on rest. If you do the assessment on exercise, it will be different. So in this type of patients, we will do the assessment on exercise also. So even moderate stenosis, if the symptoms are there, you have to do the intervention. What type of interventions are available for mitral stenosis?
Transeptal balloon mitral valvotomy.
Right.
Open mitral valvotomy.
Right.
And mitral valve replacements.
Exactly. So in this patient, if you want to do balloon mitral valvotomy, what other investigation is needed?
We have to rule out the LA thrombus by
Yes.
doing 2D echo or transesophageal echo.
Only transesophageal, not 2D echo. 2D echo picks up only 30% of thrombus. So only after TEE, you decide whether the patient will go for a balloon mitral valvotomy. Till then, what drug you will give?
Beta blockers.
Yes.
And if the patient is in AF,
Why you
with
want to give a
heart-
beta blocker?
Because there is predisposition for arrhythmias.
Not. So, for example, this patient does not have an episode of palpitation. Will you give beta blocker or not? Patient has pure mitral stenosis, no arrhythmia. Will you give a beta blocker or not? You must. Because beta blocker does lower the heart rate and expands the diastole. Left atrium is finding it difficult to empty into left ventricle. So you should go long time for the left atrium to empty. How you give a long time? You expand your diastole. How will you expand your diastole? By decreasing the heart rate. So that's why when you give long time, left atrium empties, left atrial pressure comes down. Because left atrial comes down, wedge pressure comes down, the patient becomes less symptomatic. So the best drug for isolated mitral stenosis when you are managing medically is a beta blocker to expand your diastole, not for arrhythmia. It is only for expanding the diastole and decreasing your left atrial pressure. And of course, the patient is symptomatic, you must give diuretic. If the patient is proven to have an atrial fibrillation, then you must start the patient on oral anticoagulant. What oral anticoagulant?
Warfarin.
Why not newer, target specific oral anticoagulants?
We can go newer also, sir.
No, in any mitral valve lesion, it is only vitamin K antagonist. No question of the target specific antagonist like rivaroxaban or apixaban is not indicated in any lesion related to the mitral valve. And also the prosthetic valve, still it is vitamin K antagonist. Right, thank you and good presentation. Of course, you must take away your discrepancies I have mentioned and try to explain. If at all the discrepancy is there, you must be able to mention that. I thank the Department of Medicine, Sri Ramchandra Medical College, especially Dr. Head of the department, sir, and Dr. Emmanuel, and also Dr. Srinivasan for this wonderful opportunity. I find it great honor and pleasure to be here with all of you. Thank you.
Thank you, sir.
Thank you, sir. Thank you, Pratyush and Durga Prasad. I would now request Dr. Sudhakar Singh, sir, Professor and Chief of Department of General Medicine, Ramchandra Medical College, to hand over the memento to the guest of honor. Dr. Chennappan, sir, thank you. The session was really engaging. Everyone really valued the session, and people here are most appreciative for the training. Thank you, sir. May I request Dr. Venkat Krishnan, sir, to hand over the memento to Dr. Emmanuel Bhaskar, sir, Professor and Unit Chief, SRMC. May I request, sir, to hand over the memento to Dr. Srinivasan, sir, Associate Professor, Department of General Medicine, SRMC. Thank you, sir. Thank you all. Now we have our lunch session. It will be
A few words about Dr. Ganesh sir. He is the HOD and Professor of Gastroenterology at Srihar, Chennai. He's received his DM from the Department of Gastroenterology, Madras Medical College, Chennai. He has more than 20 years of experience in the field of gastroenterology in public sector and is now currently the head of department at Srihar, Chennai. He has guided several MD and DM postgraduates in gastroenterology. He has numerous publications to his name in various reputed journals. I kindly request sir to proceed with the session. Dr. Soumya ma'am, she has completed her MBBS and MD from Christian Medical College, Vellore. She is currently working as a professor of medicine and unit chief at Srihar. She has more than 16 years of work experience. She has numerous publications in reputed national and international journals, included Journal Association Physician of India, Journal of Clinical Rheumatology. She is interested in the subspecialties of women's health, infectious diseases, medical problems and obstetrics, and low-cost intensive care therapy.
Good afternoon, everyone. I'm presenting case for Dr. Soumya ma'am and Dr. Ganesh sir. A 65-year-old female homemaker residing at Avadi came with complaints of bilateral lower limb swelling for 1 month. Bilateral lower limb swelling since 1 month, breathlessness on exertion since 1 month, easy fatigability since 1 month. History of present illness.
Dr. Monica, I think you can present, but in between we may probably intervene to ask you a few questions. Huh?
Yes, sir.
Okay, right. Go slow.
Yes, sir. History of presenting illness. History of bilateral lower limb swelling since 1 month, insidious in onset, gradually progressive up to middle of the leg, not associated with pain or redness, no diurnal variation, no aggravating or relieving factors. History of facial puffiness was there for the past 1 month, more in the morning after waking up from the sleep, subsides as the day progresses. History of breathlessness on exertion for the past 1 month, NIHA class 2, not associated with chest pain or orthopnea or P&D, no aggravating or relieving factors. History of palpitations since 1 month, on and off, regular and occurs on exertion and relieved with rest. History of generalized tiredness and easy fatigability present. History of loss of appetite present. No history of nausea and no history of vomiting.
What are the things with this kind of presenting symptoms, what are the possibilities that you're considering of?
When patient is having with bilateral lower limb swelling, and because of this, there is a volume overload state, ma'am. Because of this volume overload, there is breathlessness also. And there is no RS symptoms as in the first slide, like there is no cough with expectoration and all. So some underlying volume overload condition was present.
Which are the organ systems that you think could be affected because of the volume overload? Possibilities.
One could be the cardiac cause, and one could be the GIT cause also, in any hypoalbuminemic conditions like that. And any hematological, like any anemia cases.
With the facial puffiness, you know the diagnosis, so you're going along that direction. But with the
renal causes.
Yes,
renal
is something
also.
that you should also consider.
Shall I present? History of significant weight loss present. From 57 kgs to 43.5 kgs in a period of 7 months. History of chronic dry cough present. Seasonal variations present, no diurnal variation. No history of hemoptysis, no history of reduced urine output. No history of abdominal pain or distension, early satiety or bloating sensation. No history of melena, hematochezia, hematemesis and other bleeding manifestations.
So, what is significant weight loss?
Loss of weight more than 5% of the body weight in a period of 6 to 12 months. Unintentional weight loss.
Is there a difference between weight loss and cachexia?
Cachexia is associated with fever, ma'am. Like flu-like symptoms will be there.
Loss of weight could be due to loss of fluid, loss of fat, loss of muscle mass, anything. Okay,
Yes,
so
ma'am.
but when you say cachexia, it's generally a loss of muscle mass with or without fat loss. That's the difference. In general, you have loss of appetite. Here you have a loss of appetite and a loss of weight. So in what diseases would you expect a significant loss of weight but with an increase in appetite?
In diabetes, polyphagia will be there with weight loss. And in psychiatric conditions like bulimia nervosa,
Obviously, she's got some major symptoms, isn't it? That she's got easy fatigability, she's got some swelling, she's got facial puffiness, and a significant weight loss. For postgraduates, significant weight loss would indicate 10% of the body weight loss in about 6 months' time. That is, by definition, significant weight loss. So it looks like she has lost about 14 kgs of weight in around 7 months' time, which is probably quite significant. So in such situations, this appears to be an organic problem, not like a psychiatric problem like anorexia nervosa or bulimia. So if the patient comes to you with facial puffiness, pedal edema, fatigability, shortness of breath, where will you lean? What will be your organs which you think would be most susceptible, and where you could focus your examination and further investigations? Obviously, she's got no GI symptoms except that she's got a lack of appetite, but no vomiting, no nausea. Okay, lack of appetite could be due to any other things. It could be many things. Even this chronic condition she has may also give rise to lack of appetite. Even, for example, in anemia would probably not help patient eat much better than what she was doing before. So where do you think would be the probable pathology?
underlying malignancies, sir.
Anemia.
Malignancies.
You want to
Hematological
look,
malignancies.
so you think it's malignancy. Okay, okay. Malignancy involving? No, we are just thinking aloud, so it's okay, no problem.
And in any infections also, like in case of disseminated tuberculosis or miliary tuberculosis, there will be fatigability with pleural effusion causing breathlessness.
Because from what you have presented, I wouldn't go that far to say that we are considering malignancy in this patient. It could be a simple anemia, which probably will require investigation and correction. So we have no idea that way. What we want to look at is to see whether we can probably help this patient with some correctable causes and then probably treat them appropriately. So malignancy would be, I wouldn't say we'll rule out, but then that should not be the first diagnosis in your mind.
Yes, sir.
You can still consider cardiac. Even though he is not oliguric, you can still consider kidney problem because of facial puffiness and pedal edema. They can be non-oliguric also sometimes. And all the symptoms would probably also fit into basically patient having a low hemoglobin also. All this can also come if the hemoglobin loss has been pretty fast, or it can be even over a chronic, say about 6 to 8 months time. Okay?
Yes.
So we'll have to look at the further history, which past history can throw a light on this.
Past history. Patient had a history of giddiness and fall 6 months back, not associated with loss of consciousness and seizures, along with breathlessness and bilateral lower limb swelling, for which she underwent treatment at a private hospital where she was transferred 3 units of blood. Patient was advised for further evaluation, but patient denied for personal reasons and nature of medications not known. Patient was symptom-free until current presentation. Patient is a known case of bronchial asthma since 30 years, uses inhaler therapy during exacerbations twice a week. No other known comorbidities. No history of exposures to complementary and other medications. Personal history, takes mixed diet, does not consume alcohol or tobacco, regular bowel and bladder habits, no sleep disturbances, no contact with any known tuberculosis patient, attained menopause at the age of 50 years.
Does the past history give you a clue now as to what could be the reason?
I didn't get you, sir.
Does the past history give you a clue now to
Yes,
see, to probably consider other
Anemia.
possibilities also? If so, what are they?
So previously she had similar complaints of this breathlessness, followed by which after taking transfusion that symptoms got resolved. So indicating anemia is a cause for that thing.
She had blood transfusion, and requiring 3 units of blood would probably signify that she had probably a very severe anemia. So that is probably one of the reasons why she's presented to us again with similar complaints like pedal edema, breathlessness and all that, and giddiness. So anemia probably is the driving force here. The reason for that we don't know. Probably we need to have further information or investigate further.
History diagnosis. 65-year-old female, a known asthmatic, presented with bilateral pedal edema, exertional dyspnea, NIHA class 1 to 3, easy fatigability with significant loss of weight and loss of appetite, and history of blood transfusion 6 months back. With this history, I would like to consider as the diagnosis as symptomatic anemia, and differential diagnosis were anemia of chronic disease, and to consider GI pathology, any GI malignancies like that.
The GI malignancy, yes, malignancy in view of the history of significant loss of appetite and weight, but you don't have a specific symptom related to a particular abdominal organ as such. So what are the other things that you would consider? Yes, symptomatic anemia, possibly high output cardiac failure because of the pedal edema and the breathlessness. So with anemia and failure, what are the other possibilities? GI malignancy is one, what are the others?
Any connective tissue disorders, ma'am?
Why specifically did you mention connective tissue disorders?
Just give us a differential for the anemia. That's what madam wants. What are the possible causes of anemia? One, you said
Nutritional
anemia
causes.
of chronic disease. What are the other causes of anemia you would probably consider?
Vitamin B12
You
deficiency.
gave two. One is GI, the other is chronic anemia. Any other possibilities?
Vitamin B12 deficiency, nutritional causes.
This is a postmenopausal person with a significant loss of appetite and weight. Yes, malignancies, but are GI malignancies the only malignancies you will consider?
Genitourinary malignancies also can be considered.
Yes,
Ovarian
ovarian
malignancies.
malignancies are something that you can still think of. Anything else? Anyone here? Any other
Hematological.
possibilities? Okay, now you said bone marrow failure. Now there is history here to say anemia. Is there a history here which tells you that there is also a change as far as platelets and WBCs are concerned? No, you don't have a history of recurrent infections which you would get if there was a change in your white cell count or any history of bleeding that is present. So you only have history suggestive one particular cell line as far as history goes. So yes, bone marrow is something that you need to consider, but history-wise only one cell line that you can actually get a history out of. Any other symptoms? You said infections. What is glaringly missing as far as infections are concerned? No fever at all in the history.
Just think aloud and tell us what are the other causes of anemia, not pertaining to this.
Sir, with the history of anemia as well as with loss of weight, loss of appetite being there, I would consider malabsorption syndromes also.
Possible, good, excellent. You're thinking aloud. Okay, but no diarrhea. But diarrhea may not occur in about 20% of patients, but then the common presentation would be with diarrhea, but it is not there. Fine, we just can't exclude that.
Occur GI blood loss because it's a postmenopausal female. But we have to first characterize the anemia as iron deficiency or what is the anemia before we go on.
Now tell us what are the other causes of iron deficiency anemia.
Parasitic infestations.
Parasitic infections. Possibly in our setup it is quite possible, isn't it? They can have parasitosis and then they can come to you with anemia. Excellent, doing well. Next.
Otherwise, I would also think of hematological malignancies or solid organ malignancies, especially GI, causing blood loss. Otherwise, I would think of maybe a hemolytic anemia still possible. Autoimmune causes causing the hemolytic anemias.
Okay, so hemolytic anemia is one cause. Just name them. Hemolytic anemia we think is possibility in this case. Anemia is there, it could be hemolysis. So what is general, the presentation of a hemolytic anemia?
So jaundice.
Jaundice is there, but it is probably not here, missing. But again, you can't exclude, isn't it? Yes. Patients don't read textbooks and come. So they can present in a varied presentation. Hemolysis, if it is very severe, very rapid, then you may have jaundice. Then you may not have a perceptible jaundice, which could be missed also. But anemia is predominant in this case. Okay, then next, hemolytic anemia, iron deficiency anemia. What about macrocytic anemia?
Possible, sir. Either pernicious anemia or again with the GI symptoms, vitamin B12 absorption may be less.
So if it is macrocytic anemia, what is the possible pathology?
Vitamin B12 deficiency.
B12 deficiency, folic acid deficiency. What are the additional symptoms they should have?
Hyperpigmentation, peripheral neuropathy.
Neuropathy, isn't it? They should be having pain in the legs, non-specific pain and all that. That could probably give you a clue. So we have so many diagnoses now. So we need to think. You can think and probably consider all these possibilities because we still not touched the patient. So we don't know what it is, but these are the possibilities you need to consider. Hemoglobinopathies, macrocytic anemia, any other cause of anemia also you should probably consider.
Anemia of chronic disease because she has.
But she is already put there, chronic disease, but we don't know. No fever, no cough, nothing. So we have no idea. So I'm quite happy that he brought in malabsorption because that is one of the commonest presentation of malabsorption is iron deficiency anemia plus diarrhea. Give one cause for malabsorption.
Crohn's disease, inflammation.
Then they should be symptomatic. In a case like this, without much symptoms. Celiac disease, possible. Celiac disease. We don't see it in South India, but it's quite rampant in North India. The celiac disease is one possibility. What you said is correct. Crohn's disease is another possibility. Small bowel Crohn's can cause anemia because it can affect the intestinal area where it is required for absorption of B12, which is ileum.
General examination. Patient is conscious, oriented, afebrile. extreme pallor present, bilateral pitting type of pedal edema, no icterus, clubbing, cyanosis, lymphadenopathy, vitals, BP 100
Before
by
you go to vitals, now if someone has extreme pallor, what are the additional findings that you would look for which will give you a clue as to what is the etiology of anemia?
tongue we will see, ma'am.
What are you looking for in the tongue?
Any ball tongue or ball tongue we will see in the case of pernicious anemia or severe iron deficiency.
Okay, so a red beefy tongue glossitis is one of the findings for a B12 deficiency. Then
And in case of riboflavin deficiency, we will see magenta red tongue.
etiology for anemia per se. So what are the things you look for if it's an iron deficiency anemia? What additional findings would you look for?
We will see the nail changes, ma'am. Any koilonychia was there or not.
Okay, so you look for koilonychia. Then?
Then crease, palmar crease we will be seeing.
Okay.
Based on the palmar crease, if the crease was like similar to the other surrounding color, then we can assess that hemoglobin will be less than 7 grams per deciliter.
Okay, you look at the creases for something else. The hyperpigmentation.
Pigmentation, B12 deficiency, we will get hyperpigmentation.
Yes. Hemolytic anemias, what else would you look for?
Any splinter hemorrhages in the case of infectoendocarditis, ma'am.
Before that, simple hemolytic anemia, what else would you look for? It's not there, you've written. Icterus. So is there also icterus?
Jaundice.
You have
No
somebody
icterus.
with a severe pallor. Now, lymph nodes are important because you're looking at a hematological pathology as well. What lymph nodes, if present, are always considered significant, irrespective of the size of the node?
In case of left supraclavicular lymph node.
Only left supraclavicular? Others?
Sister.
Oligocrinone nodes.
Epitrochlear nodes are considered significant
Delphian
if they are
nodes.
more than 0.5 centimeters or more than 5 millimeters. But these nodes, if they are present, it's significant. What are those?
Sister Mary Joseph nodules.
It's a nodule. We'll come to that. The nodes. Both supraclavicular, not just only the left supraclavicular. Left, of course, is the what you're looking for in your GA malignancy, which it is your differential. But right supraclavicular is also significant. Why? Lung, mediastinum, esophagus, all of them tend to drain into the right supraclavicular nodes. So any supraclavicular nodes, if they are felt, always significant. Two other group of nodes, which we don't commonly palpate at all, which are?
Blemish nodules.
Popliteal nodes and iliac nodes, if they are palpable, are always considered significant also. Okay? But the commonest group of nodes which, if at all they are felt, are significant is your supraclavicular nodes. Epitrochlear should be more than 5 millimeters. In general, all other group of nodes, how big should they be before you think they are significant?
More than 3
In general, more than 1 centimeter. Okay. Because hematological malignancy is again something part of your differential, you also look for something else in the bones, which is?
Bony tenderness.
Okay, so what are the bones where you commonly expect to find bony tenderness?
Sternum.
Sternum is one.
Ribs.
Ribs is another, yes.
And vertebral prominences.
One more. Long bones of the arms and the legs. Okay, so the humerus and femur, another group of nodes, another group of bones where you do find bony tenderness. Go on.
Blood
Whenever
pressure.
you have a left supraclavicular node, it is usually the GIT, very significant. So we always train our students to look at the left supraclavicular node because that is the first sign of an internal malignancy. This probably indicates a disseminated malignancy. But if you have right supraclavicular lymph node which is significant, when you say significant, more than 1 centimeter in size, then you need to look at other areas of involvement. Like Madam said, the lungs, etc., etc. Okay?
Vitals. Blood pressure 100 by 60 millimeters of mercury in right upper limb in supine position. There is no postural drop. Pulse 106 beats per minute, high volume, regular rhythm, no special character. Respiratory rate 18 per minute, thoracoabdominal type, saturation 99% in room air, temperature efebrile, JVP raised 4 centimeters above the sternal angle, prominent A wave was seen. There is no bony tenderness, spine normal, no external markers of tuberculosis or malignancy, no tattoo marks are seen.
What are the external markers of malignancy?
Malignancy, we can see clubbing, acanthosis nigricans.
Okay. Acanthosis nigricans is most commonly associated with what?
GI malignancies.
Insulin resistance is its common association. The uncommon association is malignancy. Okay.
Then dermatosis we will get, tri-palm we can get, palmar thickening. Then lesser Trillard sign.
Yes.
Don't forget the left supraclavicular node. That is also an external marker for internal malignancy. Okay. So left supraclavicular node, skin changes, presence of non-healing ulcers. Okay. Even a left axillary node is again a soft sign for internal malignancy if you have symptoms. So this is called virtuous node. This is called what node?
Irish nodules.
Irish node. Very good.
Systemic examination, abdominal examination, oral cavity, tongue appears
But
pale.
you said JVP is 4 centimeters.
Yes.
It is normal or abnormal?
Raise, actually, normally from the sternal angle it is 4 centimeters above.
Above the sternal angle. Okay. In the upright position?
In 45 degrees,
45
degrees position, sir.
Okay. So you think it's normal, they got a A wave. So what is your inference with the JVP?
It was elevated, sir.
No, what is your inference? You already said it is elevated.
Patient with the symptoms of this breathlessness, pedal edema and
You
JVP
think patient is in
elevation.
congestive cardiac failure?
Patient is in congestive cardiac failure, suspecting.
Due to
Right, I didn't get it.
causes?
Anemia, because of
You think anemia is causing a cardiac failure in this? So that is one of the manifestations of symptomatic anemia. Okay, fine. Every point you make should add on to your diagnosis. That is why we are asking.
Yes. Parabdomen examination, GIT examination, oral cavity, tongue appears pale and bald. Left lower lateral incisor tooth decay was present. Inspection of the abdomen, all quadrants appears to move equally with respiration. Prominence is seen in left upper and middle quadrants of the abdomen. Umbilicus is in the midline, inverted. No scars, cyanosis, dilated veins or visible pulsations. Divarication of recti was present. Hernial orifices were free.
What is the significance of divarication of recti?
We will see the rectus abdominis muscle, strength of the rectus abdominis muscles, ma'am. If any internal organ, like usually in the case of ascites or any organomegaly, so there will be divarication of the recti possibility, ma'am.
Is anybody else wants to add on to that?
Yes, it's a chronic lesion.
Okay. What's the commonest reason for a divarication?
She would have had an LACS.
Repeated pregnancies are probably the commonest cause for divarication of recti. Are there any particular criteria to say that you need to have this much to say it is a divaricated recti? Many cutoff values depending on whether it's above umbilicus, at level of umbilicus or below. But a practical thing would be at least 2 fingertips that you can actually insert into the area to see if it is divaricated or not.
On palpation, measurements, abdominal girth was 78 centimeters and umbilicus was equally placed. From xiphisternum to umbilicus it was 17 centimeters. From umbilicus to pubic symphysis it was 17 centimeters. and anterior superior iliac spine to umbilicus 18 centimeters on both the sides. A mass felt 4 centimeters below the right costal margin in mid-clavicular line, firm in consistency, smooth surface, sharp border, non-tender, moves with respiration and non-pulsatile. Most probably liver. And mass felt 14 centimeters below the left costal margin along the direction of the splenic axis, firm in consistency, smooth surface, non-tender, splenic notch palpable, moves with respiration and can't get above the swelling. No other palpable masses were seen in the abdomen.
Okay, with this, just go back to that slide. So, you want to just discuss this?
Here,
What? So what is your inference from presentation? You can take that question.
Splenomegaly.
Yes, so hepatosplenomegaly. So based on the presentation she has made earlier, point for anemia, and now you have hepatosplenomegaly. So what would be your thoughts on this now? Either this quite grossly enlarged, almost 14 centimeters, and the liver is also moderately enlarged. So give us your thoughts on this finding along with the presence of anemia, which is quite symptomatic in this patient. There are 100 hematological causes. Mention a few.
CML, yes, okay. What is against a hemolytic anemia? No jaundice, okay. Other possibilities? Yes, CML is one, then.
Yes, you have to say myeloproliferative disorder. An option because you are committing to a CML. Then I would mean patient. Okay, so you must that you're looking at proliferate, which could include so many other. So, next. Myelodysplastic syndrome. Now tell me the difference between myeloproliferative disorder, myelodysplastic syndrome.
The MPD spectrum has 4 diseases, isn't it? Of them, which are the ones that would be differentials here?
CML?
Yes. Myelofibrosis, yes, is a differential here. What are the other two?
Polycythemia and essential thrombocytosis.
Right, so which of them is definitely not going to be a differential here? Polycythemia is not going to be differential here, considering the significant anemia that was there. So yes, CML and myelofibrosis are both differentials.
Myeloproliferation is marrow will be proliferating.
Yes.
Myelodysplastic is marrow probably is already fibrous. So that also causes. So these are the possible. Apart from these two, any other causes?
In hematological malignancy or any other causes?
Hematology, there are more differentials in hematological causes itself.
Like
huge spleen, huge spleen. Anybody?
Lymphocytic histiocytosis.
Which are quite common.
Iris cell leukemia.
Are you considering malaria or not? No. So in malaria, where you will have such a big spleen?
Malaria, you can consider.
Where will you have such a big spleen?
Tropical malaria.
Tropical splenomegaly.
Tropical splenomegaly.
Splenomegaly. Okay.
Then,
what is the other name for that? Hyperreactive malaria syndrome. Okay.
Hyperreactive malaria.
Okay, fine. That is a possibility again.
Kalas are also.
Any liver-related causes? Gross splenomegaly. We'll wait for her to present.
Budd-Chiari syndrome.
Budd-Chiari, no.
splenomegaly will not be this massive.
Massive splenomegaly.
EHPV.
Anybody comes with blood vomiting, but otherwise very stable. So what will be the cause for the huge spleen in such patients?
Extrahepatic
Portal hypertension.
Portal hypertension. Secondary to?
Liver.
What?
Non-steatotic. Hepatic.
Non-cirrhotic portal fibrosis. Okay, this is one possibility. We don't know. We're thinking aloud. Huh? Okay, so before you touch the patient, you need to look at the patient. The look of the patient gives you a lot of clue as to what would be the possible causes. So most of the time I've seen, once you give the case, straight away they go and palpate. That should not be the case. Make the patient comfortable, look at the patient. They might give you telltale signs of a disease. So you will miss that most of the times. Okay. So nice, we had a good discussion on hepatosplenomegaly. These are the possibilities you have in mind. Let's see what the presenter tells.
Percussion. Upper border of the liver found to be in the right fifth intercostal space, and the liver span is 16 centimeters. No free fluid in the abdomen. Top space dull on percussion. Auscultatory findings. Bowel sounds were regular. No hepatic bruit or no venous hum. No splenic rub. External genitalia examination unremarkable. Other system examination. Cardiovascular system, S1, S2 present, ejection systolic murmur better heard in the left second intercostal space and in all other areas, probably a flow murmur. Respiratory system, bilateral normal vesicular bed sounds heard, bilateral basal crackles heard and no wheeze. CNS examination, no focal neurological deficit.
Anything else you tested in CNS because of anemia? There is no focal neurological deficit for any other specific you did?
In case of
about paresthesia, did you look for sensory involvement?
In case of B12 deficiency, we can see ataxia, posterior column degeneration.
And?
Peripheral
neuropathy findings. Anything in the eye?
Bitoid spot, no, that is bad.
Can you have anything in the eye in B12? Sometimes.
No idea. Provisional diagnosis. Anemia and congestive cardiac failure with massive splenomegaly and hepatomegaly. Differential diagnosis. Myeloproliferative disorder. Non-cirrhotic portal fibrosis. Lymphoma. Tropical splenomegaly syndrome.
Right, do you agree with the lymphoma diagnosis? Okay, so if lymph nodes are not enlarged, do we exclude lymphoma as a diagnosis? Are there any lymphomas wherein you can have primarily splenomegaly without too much of lymph node enlargement? If so, which one?
Marginal zone lymphoma and mantle cell lymphoma.
Marginal and mantle cell lymphoma are known to cause primarily splenomegaly, not too much by way of lymph node enlargement.
Next slide.
So in this differentials, discuss what are the things that are for the diagnosis and what are the things which are against the diagnosis.
In the case of tropical splenomegaly syndrome, there is no previous history of exposure to malaria and no fever spikes were there. And in tropical splenomegaly, we will see the atrophy of the liver. Like liver will be either normal, there won't be any hepatomegaly in the case of tropical splenomegaly. And in lymphoma, absence of lymph nodes. And in non-cirrhotic portal fibrosis, there is no any symptoms of portal hypertension, like varices, ascites.
How common is ascites in non-cirrhotic portal fibrosis?
less common. Less
It's
common.
common, but
But
You should-
variceal
you should-
symptoms.
You should not go with the idea that ascites is present. Generally, these patients are well compensated. They have normal liver functions, except that they have portal hypertension secondary to involvement of the portal vein due to various other reasons. So liver is quite okay, but they have extensive collaterals. They present to you usually with bleed. The first bleed will probably point out to the diagnosis of portal hypertension, and they have massive splenomegaly in such situations. Ascites is not common. One should not expect ascites unless he's had a major bleed, and that probably has temporarily decompensated the liver circulation, and then probably, and even if it is there, it is only temporary. Okay, so generally they don't have ascites. Okay. Before we move on, just what are the prerequisites to say that patient has got a tropical splenomegaly syndrome? How do you make a diagnosis of tropical splenomegaly syndrome?
Patient will come with complaints of.
Again, it is not the name now, it is hyperreactive malarial syndrome. That is what they call it now.
And the area from which the patient have come.
One is splenomegaly. What are the other prerequisites? Anybody here? Come on. The doctor in the red has not contributed. Come on.
Patient must be from endemic area where there is malaria. Patient must be from an area where there is endemic area with malaria, and there must be like the.
No, we are looking at the prerequisites to make a diagnosis of tropical splenomegaly. One spleen must be there. In the endemic area, we are in the endemic area. So what are the other?
Chronic hemolysis could be happen. So jaundice.
What are the other serological markers you look for?
Antibodies against the.
Huh?
Antibodies against the malaria.
Pardon?
Antibodies against the malarial.
They look at IgM levels, isn't it? IgMs are quite high. And then you find that these patients improve with anti-malarial treatment. Even the spleen size shrinks. And then the antibodies to Plasmodium is quite high in such patients. So if you want to make a diagnosis of tropical splenomegaly, one, like she said, endemic area, patient should have symptoms, huge spleen, IgM positive, and high antibody titers. This is all required to make a diagnosis of tropical splenomegaly syndrome.
Regarding of the investigations, patient hemoglobin, it was 6.5 with mean corpuscular volume 104 and packet cell volume 21.4. Thrombocytopenia 41,000, total count 1,630, and alkaline phosphate mildly elevated 224. Other labs were normal. Peripheral smear, it shows normocytic normochromic RBCs with few macrocytes, leukopenia present and thrombocytopenia present. Vitamin B12 levels 164 picograms per milliliter. Retic count.
Go back to the previous slide. Don't be in a hurry. And we'll ask them. Comment on this.
Sir, patient has a pancytopenia.
Okay.
If we characterize the anemia, it's going to be a macrocytic anemia.
Okay.
Reticulocyte index is not present.
No, in this slide. In this slide.
There is bilirubins are normal, so it's not hemolytic.
They're not normal, but they're not high either.
They're not high.
So 1.76 is not normal. It's out of range.
Alkaline phosphatase is elevated. Now we have to localize it.
Based on
either
this,
to the
what is your inference? One, you said pancytopenia. So does it fit with the diagnosis? Huge spleen. And then this is the report, hematological report.
Which of the differentials have got knocked off with this kind of report? myelofibrosis is still a possibility.
Ma'am, could we go back to the differential slide?
Go back to the previous slide.
Non-cirrhotic portal fibrosis.
Why?
That's still there.
Because
In the myeloproliferative, which are the ones which got knocked off?
essential
CML has got
thrombus.
knocked off, isn't it? The white cell count is, it's a pancytopenia, so it cannot be chronic myeloid leukemia. That's the one differential which has got knocked off based on this value.
Okay, now, what is the cause for this hypersplenism? What is the mechanism by which these patients with splenomegaly have this value? Cytopenia. Yes. With you.
Splenic sequestration of the blood.
Pardon?
Splenic sequestration of the
Splenic sequestration, excellent. These things get caught in a huge spleen, so they don't come out. So they get sequestrated and there also. So that is also the mechanism in hemolysis. Only that the hemolysis is so rapid that you develop jaundice because the RBCs are not cleared by the liver in a very short period of time. The sequestration is the cause for all these things. They all get sequestrated in a huge liver, spleen, and then it causes pancytopenia. Fine, very good, very good.
Peripheral smear, normocytic normochromic RBCs with few macrocytes, leukopenia and thrombocytopenia present, vitamin B12 164 picograms per milliliter, and retic count elevated 5.7, corrected retic count 5.6, LDH 509, GGT 37, ultrasound abdomen shows gross splenomegaly with 21.4 centimeters, normal echo texture, splenic vein dilated with perisplenic collaterals, liver normal in size, 16.8 centimeters. Portal vein appears prominent, bilateral simple renal cortical cyst. Endoscopy fine.
You want to comment on this?
So B12 levels are low. Retic corrected retics should sorry. So we have to correct it for the hemoglobin. So the
Normal but corrected retic count 5.6, elevated only.
then it is elevated, sir. Our LDH is elevated. Elevated, sir. LDH is high. Hemolysis.
High retic count, high LDH, and
Hemo-
low B12.
Hemolysis.
Hemolysis,
Can be
possible?
Can be secondary to the B12 deficiency also.
Possible, I think you can't exclude, isn't it? Site count. But what is against the hemolysis? The one first line.
The bilirubin.
First line, peripheral smear. She said normocytic, normochromic RBCs, few macrocytes. There is no mention of target cells, there is no mention of sickle cells, there is no mention of abnormal cells. So normally we pick this up in the peripheral smear. So it is not there, but the other indices are quite high. So we have no idea. I think it's not matching. So we need to keep this in mind. Are we also having hemolytic component in this patient? She may have a diagnosis different, but is there a hemolytic component in this? We need to keep it in mind. So B12 is low. Again, it might indicate that there might be some amount of vitamin deficiency also giving rise to hemolysis. Gross splenomegaly is not normal. It is quite big. diagnosis now. So you ruled out yeah. Does it still fit into myeloproliferative disease?
It can be myelofibrosis, sir.
Okay. Myelodysplastic syndrome?
It can be MDS.
You said CML?
No.
No. Why no?
Leukocytes.
No, counts are very, very low, isn't it? Okay. It still could be any hypersplenic syndrome. Even portal hypertension, NCPF can also be a possibility even now. Okay.
Endoscopy done shows gastric mucosal erythema with RUT negative, no varices visualized, 2D echo, no regional wall motion abnormalities, ejection fraction 60%, grade 1 diastolic dysfunction. Final diagnosis, not yet concluded. Bone marrow plan was to do bone marrow biopsy. Reports were still awaited.
You think bone marrow is going to give you the diagnosis?
Final confirmatory diagnosis.
May not. Isn't it? So bone marrow has been done as a part of the sequence of testing in this patient. So based on all these tests, what is your diagnosis now?
Mine is like first diagnosis myeloproliferative disorder, sir.
Okay.
And the second...
you can't put this, no? Final diagnosis, I will wait for biopsy, bone marrow biopsy. You have so much information available. So based on that, give us your diagnosis.
Myeloproliferative disorder, and the second, I'll keep it as lymphoma, sir.
Second?
Second diagnosis, lymphoma.
Lymphoma, okay. Okay, then?
Non-cirrhotic portal fibrosis.
But then there is no varices, no varices. That goes away. Probably they come much lower down in the differentials. The only differentials we have now is huge spleen and moderate liver. And based on that, we need to probably consider hematological causes as one of the most important causes here. Others probably do not seem to fit. And then hemolytic anemia, because there's so much finding for hemolysis here. High retic count, high LDH, low B12. But the peripheral smear doesn't seem to be fitting into the scheme of things. So we still don't know. It could have a component of hemolysis. So myeloproliferative disorder. Only one diagnosis? You completed the examination. You've done fairly good testing in this patient, except for marrow, all the others. But then what is missing is the red cell indices, isn't it? So ferritin level, TIBC level, iron levels. I think even those have to be done in this patient, because it may give a lot of differentials for the various type of iron deficiency, macrocytic, anemia of chronic disease. All can be probably diagnosed when you have this iron indices also available. Even that should be done in this patient.
We've run out of time. If you have a couple of slides, you can just run through them.
These are the different causes of hepatomegaly: infective causes, congestive and degenerative and infiltrative causes, storage disorders, malignancy like hepatocellular carcinoma, cholangiocarcinoma and secondaries, and toxins causing hepatomegaly. Causes of painful hepatomegaly and causes of pulsatile liver. These are the methods of palpations of the spleen. There are four methods of palpation of the spleen. This is dipping method and Middleton.
Dipping is not what you've shown in your picture. Dipping, this is not really dipping. The traditional one is what you've shown.
And hooking method, also called as Middleton's maneuver. And percussion methods of the spleen, two methods were there, Nixon's and Castrol's method. This is the landmarks of Trop space. And the grading of enlargement of the splenomegaly, mild, moderate and massosplenomegaly. 1 to 2 centimeters mild, 3 to 7 centimeters moderate, and more than 7 centimeters it was massosplenomegaly. And this is a Hackett's grading system for the palpable splenomegaly. And these are the different causes of splenomegaly, causing mild splenomegaly, causes of moderate splenomegaly, and causes of masosplenomegaly. These are the causes for hepatosplenomegaly: anemia, hemolytic anemia, malaria, leukemia, and lymphoma. And hepatosplenomegaly with jaundice, we will see in case of hemolytic anemia, enteric fever, leptospirosis, cirrhosis, and congestive cardiac failure. And hepatosplenomegaly with lymph node palpable, chronic lymphocytic leukemia, and lymphoma. And hepatosplenomegaly with bone pain or bone tenderness, we will be seeing in chronic myeloid leukemia, lymphoma, multiple myeloma, and hemolytic anemia.
On your presentation, I have two queries. One, you said congestive cardiac failure, but then echo turned out to be reasonably normal. You still hold on to the diagnosis?
Yes, sir. Patient is in anemia, so anemia causing heart failure, so it will be like high output cardiac failure, so the ejection fraction will be normal.
Yeah, you may not have a
Reduced ejection fraction or
wall
systolic.
dysfunction, but then they can still be having cardiac failure, possible. So that is one. Number two, you didn't have any evidence of hemolytic anemia on your peripheral smear, but the retic count was quite high. Is there a possible way to explain this in this patient?
In a case of any proliferative, like retic count indicates a proliferation, bone marrow proliferation. So in case of any deficiencies, iron deficiencies or any folate deficiencies, anemia, there can be chances of hyperproliferations in the bone marrow.
So extravascular hemolysis could explain that there is not enough bilirubin in the blood.
She's almost there, but not completely explained. Whenever you have a rapid turnover, secondary to rapid loss of hemoglobin, the marrow starts functioning. You should have a cellular marrow for this. So marrow starts functioning over time. So they produce a lot of RBCs which are very immature, and then these RBCs come into circulation. Then you may have a falsely high retic count also, but most of these reticulocytes are usually mildly macrocytic, not the microcytic type. So there was microcytosis there, macrocytosis, plus a high retic count. So we feel that the marrow probably is hyperreactive and probably producing a lot of immature cells which are causing these values to come. You need to explain all these values, isn't it? So all this has to be explained. There is an explanation for this. We still hold to the point that she might be having a myeloproliferative disorder, needs to be confirmed, but in all practical purposes, all the values which are there, which may not be fitting, may also have an answer, alternative answer for that. Okay, so this is all very, you need to explain each finding. Otherwise, it should fit. Otherwise, your diagnosis is not complete. Monica, you did well.
Thank you, sir.
Sir, for the detail. The detailed insight and discussing the various differentials in the extensive interaction with the delegates. Have been received. Thank you, Dr. Monica. Now I request Dr. Preetham Ortho sir, Professor of Medicine, to facilitate Dr. Ganesh sir with a small memento. Head of Department of Gastroenterology at Srihar, Chennai. He has more than 20 years of experience in the field of gastroenterology in public sector. Thank you, sir. Now I request Dr. Devasena Srinivasan, ma'am, Professor of Medicine and Unit Chief, Srihar, to give a small memento to Dr. Soumya, ma'am. Dr. Soumya, ma'am, has has done her MBBS and MD at CMC Vellore. Thank you, ma'am. Now I request the PGs for the next session, Dr. Delvina and Dr. Aisha, to take up stage. This session will be moderated by Dr. S. Balasubramanian, Sir, Professor of Neurology, Institute of Neurology, MMC, Chennai, and by Dr. Devasena Srinivasan, ma'am, Professor of Medicine and Unit Chief at Srihar, Chennai. I request both ma'am and sir to take up the seat. Balasubramaniam sir has completed his MBBS, MD and DM in Neurology from Madras Medical College, Chennai. He is passionate about teaching both undergraduates and postgraduates and currently is a professor in Madras Medical College. He is a recipient of many awards such as the C.V. Chari Memorial Prize in DM Neurology and the Best Doctor Award by the Tamil Nadu government in 2018. He has been invited as a speaker to various conferences all over India and is a member of Indian Academy of Neurology, Indian Epilepsy Association, International Movement Disorder Society, and the American Academy of Neurology. He has numerous publications in well-reputed journals, both national and international, and his areas of interest include stroke, headache, tropical neurology, neuromuscular disorders, and movement disorders. Dr. Devasena Srinivasan, ma'am, has completed her MBBS from Madurai Medical College, Dr. MGR Medical University, Chennai, India, and MD in Internal Medicine from Madras Medical College, Chennai, India. She is currently a Professor of Internal Medicine at Srihar and a Senior Consultant Physician at Sri Ramachandra Medical Center. She has more than 21 years of work experience with 8 months as a lecturer in Internal Medicine in CMC Vellore. She has numerous publications in reputed national and international journals.
Good afternoon, everyone. Today, me and my friend Delvina will be presenting a CNS case. So, our case is about a 52 years old female residing in a village near Nagai district who has completed her primary school education up to 5th standard and is a homemaker who also does occasional cattle rearing. She came to us with chief complaints of weakness of right lower limb since 2 years, weakness of left lower limb since 1 year, weakness of right upper limb since 8 months, and change in voice since past 3 months. History of present illness: patient was apparently asymptomatic until 2 years ago, after which patient developed weakness of the right lower limb, which was insidious in onset. Initially, patient noticed stiffness of her right lower limb with tripping of toes and inability to grip onto the slippers in her right foot. She was not able to run while rearing cattle. However, patient continued to go for cattle rearing and walked with the support of her left lower limb. Patient also gives a history.
What do you think when there is more stiffness and that's a complaint the patient has told you more than the weakness?
Weakness.
What do you think about that?
Mostly it looks like a UMN.
Is it okay to have
weakness
stiffness first and?
Yes, ma'am. It is common in UMN lesion to have stiffness more than weakness. And a patient also gives history of occasional buckling of knee in the right lower limb while walking since past 1 year and needed support of the wall while getting up from squatting position while using Indian closet. Since past 1 year, she started noticing weakness of the left lower limb also, as walking and getting up from sitting posture became more difficult.
In this, as a continuation of what Madam asked, it's the first stiffness of the right lower limb. Does it go on with buckling of knee? Where do you get buckling of knee? Buckling of knee is due to?
LMN usually.
No, it is due to buckling of knee is due to what?
Which muscle? What?
Weakness of? Just imagine why they should buckle.
Quadriceps muscles are.
So the knee gives way. So it is most often weakness of the quadriceps. So usually buckling occurs early in human or LMN?
LMN.
Lower motor neuron weakness only, commonly buckling. But occasionally you can have buckling in human lesions also. Stiffness, sometimes the knee may give way, but it's not so common. Usually buckling means it is lower motor neuron weakness. So these two, it is slightly contradictory. Okay, but anyway, you can get buckling occasionally in human lesions also, but that is not common. Okay, proceed.
Okay. Patient slowly stopped going for cattle rearing and was only doing her household work like cooking and used to leave the house with the help of a wooden stick to walk. The weakness progressed and patient also started mobilizing at home using the support of the wall since the past 6 months. Patient was unable to squat and hence she stopped using the Indian closet since the past 3 months. Patient didn't have any difficulty in using her upper limbs until 8 months, after which she had noticed that she was unable to lift her 1-year-old granddaughter. And patient also noticed that she was able to hold the knife but was unable to give force to cut vegetables since the past 5 months. Hence she stopped cooking. Patient was also unable to lift a mug of water while using her right upper limb but was able to do so without difficulty using her left upper limb. Patient was able to comb her hair, tie her sari, mix food and take it to mouth without dropping or smearing over the face.
Which muscle you have examined so far and what history and what muscle you have checked from the beginning? Start from the squatting history.
Initially, patient right lower limb.
Which are the muscles involved and what history you have got? Tell the history and the muscle.
With the patient had right lower limb weakness with the tripping of toes, so which involves extensor digitorum hallucis and extensor digitorum, and then she had inability to grip the slippers with the right foot, which is flexor digitorum profundus. And that was the initial thing, ma'am. Later, it had progressed, and patient was having buckling of the knee, which was with the quadriceps muscle.
What do you think about this weakness? Is it more distal or more proximal, and how does it help in your diagnosis? And in the upper limb also you can finish. Which muscle you have checked in the upper limb and whether distal is more or proximal is more?
Yeah. In upper limb, she noticed she had proximal weakness more. Then she had proximal weakness as she was unable to lift her granddaughter and was unable to apply force on the knife.
Specifically which muscle? Proximal weakness?
Not
able to lift, now which muscle?
The flexor, the biceps muscle.
Most likely biceps. Why can't it be deltoid?
She could comb her hair.
Exactly. So you should, in the last line you mentioned that she was able to
comb her hair.
So that indicates it has to be lifted above the shoulder level. So that is deltoid. Okay. So most likely the weakness has started in the biceps, flexing. Then what about difficulty in getting up? The first.
Getting up from squatting position.
No, the next slide, first paragraph.
She was unable to squat. It could be because of gluteus maximus muscle involvement.
Unable to squat or getting up from squatting posture?
Unable to get up from squatting position.
Both. She is not able to squat also and difficult in getting up. So what all muscles are involved? Not only gluteus, what are other muscles? When you want to get up from squatting posture, so
also
what you just imagine what you have to do when you are getting up, you have to extend your Knees. So you have to extend your hip.
Yes, we have to flex the thighs also.
So that is extension of the hip is by
Gluteus maximus.
maximus, and extension of knee is by
Quadriceps.
so those are the muscles which are prominently involved in getting up from squatting posture.
Position.
So that is gluteus maximus weakness and quadriceps weakness. What about distal foot? Already I have mentioned. Okay, in the first distal portion.
Yes.
Now in the upper limb, distal is till now distal is not involved. Why? What you have in history?
She was able to hold the knife, but she was not able to apply force. So
No, she is able to hold mixed food.
she was able to mix the
So
food. and
relatively distal is better.
Yes.
There is no weakness till now. Okay, proceed.
Describe pyramidal weakness. Why is this so important, distal or proximal, and to find out which is more weak?
Usually in UMN there is distal more than proximal involvement, ma'am. So
Which
an
are all the
element it
groups
will be
involved? Common groups affected in pyramidal lesion.
the extensors in the upper limbs and the flexors in the lower limbs and abductors in the upper limbs.
Anti-gravity muscles.
Anti-gravity, yes.
Okay, proceed.
Patient gives a history of twitching of muscles in the right lower limb, thigh, since 1 year and right hand since 1 month, which was intermittent, lasting for few seconds, and did not observe any specific aggravating or relieving factors. Patient also had a change in her voice in the form
What
of
do you think is
decrease.
that twitching due to? What is it? What are you thinking now?
The twitching. It could be any fasciculation, like because
You're thinking
buckling
it's a
history
fasciculation.
was there.
Define fasciculation and which conditions you get fasciculations.
Fasciculation is in irregular, non-rhythmic contraction of the muscle spindle, muscle fascicles due to overfiring of the due to rapid firing of the.
What is fibrillation? Fibrillation.
There's a single muscle fiber.
Fibrillation is actually an electrophysiology, investigative finding. Fibrillation you detect by investigation.
Yes.
For the fasciculation, it is an individual twitching of the single fibers.
Fiber.
Whereas groups of fibers are twitching, then it is fasciculation, which can be observed. Whereas fibrillation you have to record with an EMG.
Without any stimulus, an automatic discharge of a single muscle unit.
Patient also had a change in her voice in the form of decreased volume and slurring of speech with a nasal twang since past 3 months, which has worsened and is incomprehensible for the past 2 weeks. However, patient is able to understand the words and respond back to commands. She has history of occasional nasal regurgitation of food, liquids more than solids, since the past 3 months, which has become more frequent in the past 2 weeks. Patient also gives history of difficulty in coughing since past 1 month. She has difficulty in swallowing both solids and liquids, more to liquids since past 2 weeks. She has difficulty in making a bolus and moving tongue side to side and protrusion of tongue since the past 2 weeks.
What are you trying to say? Which are all the cranial nerves affected now?
9, 10, 12 cranial nerves are affected, ma'am, with the symptoms of nasal regurgitation, the change of voice, nasal twang, difficulty in swallow.
When you get this symptom, first identify the muscle weakness and then tell the nerve. So nasal regurgitation of food is due to
palatal muscles.
palatal weakness and 10th nerve.
Yes.
And then coughing, nasal twang, all this palatal, but coughing?
Laryngeal muscles.
Again vagus. Okay, swallowing.
Swallowing again, pharyngeal muscle and
what are the
and also
pharyngeal muscles?
palatal
What are the
muscles.
pharyngeal muscles? Superior, middle and inferior constrictor muscles.
Constrictor muscles and stylopharyngeus muscle.
So these are muscles of deglutition. Again, they are supplied by the
Vagus nerve.
No, 10th. So all are features of 10th nerve involvement. So if you go by that, it will be easy for localization. Okay, next, in difficulty in making a bolus of food and then moving tongue side to side. So all this is due to
12 hypoglossus.
Muscle first and then the nerves.
Weakness of-
Genioglossus, hyoglossus.
what are the muscles of the tongue?
Genioglossus,
No,
hyoglossus.
first initial classification.
Intrinsic and extrinsic.
No. It is an intrinsic and extrinsic muscles. So extrinsic muscles are?
Genioglossus, hyoglossus, myoglossus, and styloglossus.
Yes. Intrinsic muscles?
Longitudinal, vertical, and horizontal, median groups.
Longitudinal, vertical, and transverse.
Transverse.
Okay. And what are the function of the intrinsic muscles? Extrinsic muscles, it is protruding and moving
Protruding
side to side.
movement.
What is the
and
function of the intrinsic muscles?
Maintain the position in the midline.
What the tongue does? Apart from movement, what you can do with the tongue?
Speech,
That is the
articulation.
shape of the tongue can be altered. See, either narrowing or widening. So the shape of the tongue can be altered, like making it more convex or concave. This is done by the intrinsic muscles. So all muscles are supplied by 12th nerve, or is there any exception?
Palatoglossous is supplied by the vagus nerve.
Okay. So when you encounter this history, what else you want next? When the patient has got bulbar symptoms now.
Yes.
Initially you have had weakness of limbs, and now she is proceeding to develop bulbar symptoms. So in this bulbar symptoms, see, as you go by the history, you should have a concept of localization and also the etiology side by side going. Then only you can get the history of certain disorders. Any patient presenting with weakness of limbs and bulbar symptoms. So what all will be going in your mind? Just as if you go by that, you can get more history from the patient.
We'll ask for any emotional lability symptoms or any breathless difficulty in breathing.
Okay.
Any neck pain.
Pertaining to etiology.
Anything in the neck you want to?
Radicular pain, neck pain.
Okay. So there is involvement of 10th nerve, there is involvement of 12th nerve. So any high cervical, so you have to ask for any history of high cervical
injury.
And subsequently, of course, you will ask subsequently. But pertaining to that only, I'm asking nasal regurgitation, difficulty in swallowing, all this when any patient was presented with a short duration or reasonably, it is not only 2 years duration.
Yes.
So if it is more short, say for example 6 months or less than 6 months, the same patient presents with this history, certain treatable conditions you have to think of and ask. So any patient with bulbar symptoms in this age group, ask for
Spondylosis.
Pardon?
Cervical spondylosis.
That is there.
Syringomyelia.
Any other etiology wise? What all among the etiology which can cause pure motor weakness with bulbar symptoms, what all is running in your mind? Pure motor weakness with bulbar symptoms, which is treatable. Suppose if this patient presents with ptosis, diplopia,
diurnal variation.
So there should be a history of diurnal variation. See, always remember, myasthenia gravis most often presents with ocular, most often. But in some situations, in acute, not in this patient, but in acute bulbar symptoms, or even subacute or chronic bulbar symptoms also can present initially. Subsequently, the patient can develop ptosis. So always have a neuromuscular junction problem and ask for fatigability and diurnal variation. Pure bulbar, don't miss the history of fatigability and diurnal variation, because we have seen many, more than every neurologist have seen 2 or 3 cases of patients diagnosed as motor neuron disease turning out to be a neuromuscular junction problem, myasthenia gravis, which is treatable. So always get a history of fatigability whenever there is a bulbar symptom. Okay.
Patient was able to lift the head from pillow without difficulty, but was unable to get up from bed and turn side to side in bed without support since past 1 month. No complaints of breathlessness was present.
Why this is important?
There is truncal involvement also now.
Neck, what are the conditions which can produce neck muscle involvement? Neck flexor weakness. Your patient is able to lift the neck off the pillow.
Yes,
Suppose if the patient is not able to do that, there is neck flexor weakness.
Yes.
So what are the conditions which commonly present, which has neck flexor weakness?
Spinomuscular atrophy.
Okay, but that occurs very late. Common things which present with neck flexor weakness. Common neuromuscular conditions.
Myasthenia gravis.
Pardon?
Myasthenia gravis.
Yes, myasthenia then. Any muscle condition? Inflammatory myopathy, polymyositis, myasthenia gravis, and what you are presenting, motor neuron disease. So these and isolated neck extensor weakness is also there. So neck muscle weakness, these are the three common neuromuscular conditions which have prominent neck weakness initially itself. Okay.
Patient had no history of memory disturbances or emotional lability. She was able to smell her food, able to read signboards without difficulty, had no history of drooping of eyelids or double vision, was able to appreciate hot and cold water while washing her face. Patient had no history suggestive of difficulty in closing eyes while sleeping, drooling of saliva, deviation of angle of mouth or loss of taste sensation. She had no history of history suggestive of tinnitus, rotatory dizziness or difficulty in hearing. She was able to lift her head from the pillow and turn it from side to side. Sensory history, she had no history of tingling, pain or burning sensation over upper or lower limbs. She had no history of numbness or sensory loss over upper and lower limbs. She was able to appreciate cold and warm water when given a shower. She was able to feel clothes over the body and feel the firmness of the ground. She was able to feel vibration of her cell phone and could feel a mosquito bite. She had difficulty walking in the dark since the past 6 months as she needs the support of the wall while walking. Cerebellar history, no history of swaying while sitting was present, no history of tremors in the upper and lower limbs present. Patient gives a history of difficulty walking through narrow passages and swaying towards the right while walking. Autonomic history, she is able to feel bladder fullness, able to control till a socially acceptable situation. She is able to initiate maturation and able to completely void. There is no history of bowel incontinence, no history of palpitation or abnormal sweating, no history of postural giddiness present, no history of neck pain, fever, headache, seizure or photophobia present. There is no history of trauma, loss of weight, recent vaccination, exposure to pesticides, chemicals or heavy metals present.
Heavy metals you'll ask in this patient?
Lead, any lead and aluminium.
Then? Lead, aluminium, good. Then?
Mercury.
Mercury, very good. Have you heard of Guam area? Where is Guam? Guam Islands.
West Pacific.
Yes, exactly. In the West Pacific.
West Pacific.
Guam Islands. It's known for what? The dumping of the arms and ammunitions. Most often they contain selenium. So you have an high incidence of pure motor syndromes, especially motor neuron disease in that island, Guam Island. We have seen 2 cases in our Institute of Neurology, Indian patients who have returned from Guam with presentation of an ALS, and heavy metals found was selenium. So selenium toxicity is another important thing for pure motor syndromes, especially amyotrophic lateral sclerosis. So heavy metals including mercury, very good. Mercury is commonly we experience here. Mercury intoxication produces variable motor syndromes, and it is present in patients taking long-standing Siddha medications. So we have presented a paper in US American Academy of Neurology, mercury-induced neurological disorders. So always remember in mind, mercury, selenium, lead, aluminum. Okay.
Yes.
And what other physical agents which can cause pure motor syndromes? You have said chemicals, you have said
drugs can cause.
Heavy metals.
Drugs
physical
can
agents.
cause.
Physical.
Physically.
Electrocution.
Irradiation.
Irradiation.
And electric shock.
Electric shock. So these are the things
Any
we
endocrine conditions?
Hyperparathyroidism, hyperthyroidism, hypothyroidism, Cushing's syndrome sometimes. Then hypoglycemia, hyperlipidemia, and hyperglycuria can also.
Okay, this patient is from a rural background. So most often exposure to pesticides. Okay.
Past history, patient is a known hypertensive since 1 month, on tablet amlodipine 5 mg OD since 1 month, not a known case of diabetes, bronchial asthma, TB and epilepsy. Personal history, patient takes a mixed diet, bowel and bladder habits are regular, no addictions, no loss of appetite or sleep disturbances present. Family history, patient is born
related to hypertension in this patient, and what are the hypertensive neurological diseases you know?
Hypertension can cause cerebrovascular accidents, ma'am, and also hypertensive encephalopathy. Also, hypertension induced cerebral small vessel disease can be there, which can cause cognitive decline.
Anything fitting in this patient?
No. Family history, she's born out of a non-consanguineous marriage. Development history, no delay in milestones. There's no history of similar illness in family.
The family history important in this patient?
Yes, sir.
How?
Hereditary spastic paralysis can be, paraparesis can be there. And
so
familial ALS can be.
From whatever you have told now, it is pure motor disorder involving all 4 limbs and bulbar region.
3, yes.
So what are the possibilities when you are thinking? One of the possibilities will be?
Degenerative.
Okay. So pure motor system disorder, like motor
yes,
neuron
pure
disease.
Motor.
Is it familial?
No, sir. She doesn't have any family history.
The patient does not have family history. Is motor neuron disease familial also?
Yes, sir.
What percentage?
10%.
10%. So family history is important in this patient also. And one thing you mentioned in the history, passing history mentioned, no history of memory disturbance or higher functional alterations. History, how is it useful in this patient?
Emotional ability can be there for pseudobulbar.
Okay, that indicates pseudobulbar.
And frontotemporal dementia is common in them.
What higher mental function history you will elicit in frontotemporal dementia?
Memory, sir.
Memory, then?
Any
Social disinhibition.
Social disinhibition. Then, what are the functions of frontal lobe?
Frontal eye.
So, executive function defects, whatever she has been doing, there might be defects in execution, executive defects, and some other frontal lobe syndromes like apathy, behavior disturbance, anger outbursts, change in behavior, change in personality. All these are features of frontal lobe. So frontal lobe disturbances, temporal lobe disturbances, because most often motor neuron disease is often associated with familial motor neuron disease is most often associated with frontotemporal dementia. Not only that, among the treatable conditions, anything where the patient can have motor symptoms and higher mental function alterations, treatable conditions. Patient having quadriparesis with bulbar symptoms and higher mental function alterations. Any infections?
HIV. One, yeah.
Don't forget HIV, retroviral disease. You can have both cortical and subcortical involvement, diffuse cortical involvement. So HIV is an important thing. We should ask for the pattern of, any exposure to sexually transmitted diseases. That is one. Next, any nutritional disorders?
Vitamin B12 deficiency.
But
Vitamin
here, what is the points against B12 in considering the differential diagnosis?
There's no sensory
There's
symptoms.
no sensory at all. It is a pure motor, and so B12 is very low in the list. Among the other disorders, what Madam mentioned, endocrine disorders, what all can cause higher mental function abnormalities? You enlisted.
Thyroid.
No, thyroid disorders, hypothyroidism. So these are all the conditions where history of higher mental function disturbances also are important in any neurological patient. We have to just remember, because when you get the history, your differential diagnosis will be narrowing down, or you can go in one particular direction. Okay, so the every history is important in this patient, and more often you said passing loss of weight, loss of appetite.
Yes.
How does it contribute that?
Because of dysphagia complaint.
One thing,
also
patient can have nutritional, feeding difficulties. Next.
There will be ALS, cachexia, which will be there.
Otherwise, this age group coming with dysphagia, loss of appetite, loss of weight, what do you think first?
Paraneoplastic.
Any hidden malignancy with a paraneoplastic neurological manifestation. So these are all the things which has to be considered. Always, when you are approaching a neurological disorder, have in the back of the mind any treatable condition. That should be your first approach for making a diagnosis. Always have, especially if it is of short duration illness. Suppose if it is a long duration illness, chronic, goes on for years with a family history, then it is well known that it is a familial disorder. But sometimes if it is a short duration, occurring in particular scenarios and situations, always think of a treatable condition in the background and elicit the history, rule out a treatable condition before diagnosing any degenerative.
Treatment history: patient had multiple visits to clinics for her complaints and was advised a vitamin B12 injection, analgesics and oral vitamin supplements. In one of her visits to a PHC, patient was advised for a CT brain in suspicion of a cerebrovascular accident, which was normal. History summary: 52 years old female, recently diagnosed hypertensive, on treatment, has presented with asymmetrical progressive weakness of both lower limb, right more than left, right upper limb, and truncal weakness. The lower limb with distal muscle weakness initially, which then progressed proximally, and right upper limb was involving the proximal muscles since past 2 years. The weakness is also associated with twitching of right hand and right lower limb, with history of speech difficulty, nasal regurgitation, dysphagia to liquids more than solid, and difficulty in protrusion of tongue and moving it side to side, with no positive family history. And there is no history of sensory, higher mental function, cerebellar or autonomic involvement. So with this one, I thought came to a diagnosis of UMN and element type of weakness of right lower limb, with element type involvement of left lower limb and right upper limb, with 9th, 10th and 12th cranial nerve involvement. Structures involved: corticospinal tract, anterior horn cell, 9th, 10th and 12th cranial nerves, and it...
No, just wait. After finishing the history, we told the summary, go back to the summary. So history, after finishing the history, our motto will be, where is the lesion or lesions? If it is single lesion, where is it? Or if it is multiple, where is it? So here from this history, where after we have gone almost every paragraph and localized. So now where all is the involvement and what is the evidence for that involvement? When you are discussing, you are telling corticospinal tract involvement, anterior horn cell involvement, 9th, 10th, 12th. Okay, but corticospinal tract involvement as evidenced by what symptoms you have arrived? That you have to tell. Same way, anterior horn cell disease, because of what symptom, where? Okay, like that. Generally you discuss like that only.
Yeah.
So here you said corticospinal tract involvement. So based on what symptomatology and where is the corticospinal tract involvement?
Because of she had complaints of stiffness of her right lower limb with tripping of toes. So with that I thought of UMN, like a corticospinal tract involvement, sir.
Right lower limb stiffness, no? What level corticospinal tract involvement should be there?
The lumbar. lumbar region.
Above what level?
Yeah, above L1.
Above L1. So this is right side.
Yes.
Okay, what about the weakness on the left side?
Left side, she gave a history of difficulty while squatting. So proximal weakness was there, but she didn't complain
So
of
that was
any
all
sti-
bilateral. When
cell.
the patient gets difficulty in getting up from squatting, and most often it has spread to the other side. So she has given stiffness only in the one lower limb or both
to
lower
the
limbs?
right lower limb. Right
limb.
lower limb.
So that has to be asked in the history also, whether there is stiffness in the upper limb also. So stiffness or flailness in all four limbs you have to ask.
Yes.
Okay, then only you can come to a control. Otherwise, you are left with only one corticospinal tract. No. Most likely, the patient should have had stiffness of both lower limbs.
Is she refusing stiffness in the other limbs?
Yes.
It might be there. Okay, the patient may give, may not give. But what about the upper limbs? Is there any history of stiffness?
History wise, no, sir.
No. Okay. So corticospinal tract removal definitely above L1, most often on the right side, you can say. Then what about that next? Then how to explain the weakness in the upper limb? Where is the distribution of weakness in the upper limb?
Proximal is more.
Proximal only. Distal
Proximal
is not
only,
present.
till now.
Okay.
And
So even after the, she has no, after the later stages also, there is no weakness of the lower, hands.
Examination there is.
But the history-wise, she doesn't give.
History wise, she didn't say anything.
Okay. Is there anything else in the history to say the motor where you can get involvement of the other structure? Fasciculation, you told.
Fasciculation
Fasciculation indicates what?
Element type.
It is a symptom of an lower motor neuron involvement. Where all you get fasciculation in this patient?
On her right thigh and her right hand.
So what is the information you get for localization?
Both thoracic, cervicothoracic and lumbar.
Lumbar.
What is involved?
Anterior horn
So
cell.
you said anterior horn cell. So you have to say the anterior horn cells of the lumbosacral region on the right side, because the right thigh is innervated by right thigh. What is the root value? Quadriceps is by?
Quadriceps is by femoral.
What is the root?
L3.
L2, L3, L4.
L2, L3.
Femoral nerve L2, L3, L4. So you should be specific thighs, whether a front or back. If it is back means
Sciatic nerve.
muscle is
Hamstring.
hamstrings. So it is in the sciatic nerve distribution where it comes under L5, S1, S2. Okay,
Yes.
so the hamstrings. So anterior horn cells in the lumbosacral. So if it is front na L2, L3, L4. Back na if it's L5, S1, S2. So lumbosacral region there fasciculation. The upper limb in the hands. You said in the hands. Or is in the limb.
Limb. Flexor.
On the
C5,
So it is in the whole upper limb.
Yes,
So
sir.
it is involving from cervical region.
No.
So there are fasciculations in the cervical and the lumbosacral. So these are indicative of lower motor neuron involvement and anterior horn cell. Where else you can get fasciculation? What structure apart from anterior horn cell?
muscle atrophy.
Primary
Muscle disorder, you won't get fasciculation. Fasciculation is either anterior horn cell or root, motor root. Okay, motor root is not so common. Anterior horn cell is at the MD point of level, anterior horn cell involvement induces fasciculation. But occasionally you can get fasciculation even in root involvement also. Just have in mind. So in the cervical region, you are getting lower motor neuron. So now you are not going to the examination, but you have some symptoms of lower motor neuron in the upper limb. What other symptom you will ask even if the patient doesn't say?
Neck pain.
Pain you have told. Regarding motor, to localize whether it is LMN or UMN.
Atrophy or any
Stiffness.
Stiffness you have told, the patient denies. What about lower motor neuron? Any other thing?
Wasting.
Thinning.
Atrophy,
It is not, we have not mentioned much the history, whether there is any specific thinning or
She didn't when we asked,
history.
she told
Okay,
no.
okay, there is no thinning. So there is a suggestion of lower motor neuron involvement in the upper limb. There is a suggestion of upper motor neuron involvement and lower motor neuron involvement in the lower limb. Okay, so with this information, now tell the motor localization. Whatever information you got from the history. Probably examination will give more, but from whatever you are told, what is the likely sites of involvement? Corticospinal tract involvement above L1.
Corticospinal tract is involved and above L1, and also anterior horn cell is involved. So, and
In the cervical and lumbosacral region. These are the evidences for motor system involvement at present.
Yes.
Okay, so there is a pure lower motor neuron involvement in the upper limb, upper motor neuron involvement, and lower motor neuron involvement in the lower limb. Okay, next, bulbar.
Bulbar involvement, she had the nasal regurgitation, the tone. All 9, 10, 12 cranial nerves were involved.
10 and 12 cranial nerve.
Yes, sir.
Okay, glossopharyngeal is purely sensory. Mostly it is sensory. So 10th and 12th involvement of whether it is in the nucleus or in the, is it LMN or UMN?
LMN, his.
How will you say if it is you? If it is want to say UMN, what will help you?
From the history.
Emotional ability.
Emotional ability. So she doesn't have.
No, sir.
So can we still differentiate UMN and LMN upon with this bulbar symptoms, whether it is UMN or LMN?
The voice, classically hoarse.
Flaccid or spastic dysarthria. Like
How will the spastic dysarthria will be?
Hoarseness of voice will be there.
Hoarseness can occur because of involvement of the larynx.
Slurring.
Strained voice.
Strained voice. If the patient has straining to speak, that indicates spasticity of the pharyngeal and laryngeal muscles. So when there is a straining to speak, that will indicate that it is an upper motor neuron involvement. But if there is no straining, still you cannot rule out unless you do an examination. And if there is emotional ability, then we can say it is an corticobulbar involvement for the 10th and 12th. But it can be now both UMN, LMN or only LMN. But most often, lower motor neuron symptoms will produce more symptomatic. The patient will have severe secretions. The difficulty in swallowing will be very severe. Secretions will be, lot of secretions will be there. So based on the severity we can say, but that cannot be 100%, we cannot differentiate. Okay. So there is bulbar involvement. Then?
You've already localized, but can it be a cord lesion? And involving one limb to the other limb, if at all cord lesion, and what is the cord lesion? It's not, we have already localized, not.
Else, compressive it could be compressive myelopathy if there were sensory symptoms.
At what level? Compressive myelopathy at what level?
High cord lesion.
High.
So it is a high cervical cord lesion, which will explain what all it will explain.
The weakness, progression of the weakness.
What is this progression?
What is that phenomenon?
Ellsberg phenomenon.
Describe it.
Ellsberg, how will it be? How will the progression will be?
U-shaped, from ipsilateral upper limb, then ipsilateral lower limb, contralateral lower limb, and contralateral upper limb.
Is this Ellsberg?
No.
It started in the lower limb, then spread to the other lower limb, then this upper limb.
Upper limb.
Okay, so it is one lower limb first, then next lower limb, then upper limb, then also it is not it is neither a reverse Ellsberg nor Ellsberg. So, but this progression can occur in a cervical cord also. Quadriplegia paralysis, you can get this progression, but usually you will get this Ellsberg. Okay. So, but how will the high cervical, how will it explain the bulbar?
The exiting nerve roots, 12th nerve can be explained, sir.
Okay, 10th you cannot explain. Where 10th exits? What foramen? Along with the vessels, there is a foramen in the base of the skull. Jugular foramen. So 12th is in from the hypoglossal canal. So jugular foramen is anterior to the hypoglossal canal. It's very close. If you take the base of the skull, if you see the hypoglossal canal and the jugular foramen is just few millimeters and less than 1 centimeter anteriorly only. So these are very close. So high cervical lesions, either it can compress externally also, but suppose if it is inside the substance, intraaxial, what you call, what pathology can explain that?
Syringomyelia.
Exactly. So the patient high cervical lesion with syringobulbia, syringomyelia and syringobulbia. What is lacking for high cervical lesion?
Sensory
Sensory.
symptoms.
So there is no sensory at all, no bladder involvement, nothing is there. So it is a pure motor syndrome. So even though there is no sensory, you still have to consider an high cervical cord lesion. So among these etiologies. Now coming to the etiologies, we will discuss what are the possibilities. So the patient has involvement of pyramidal tract. The patient has involvement of anterior horn cells in upper limb and lower limb. The patient has got bulbar cranial nerve involvement. So what are the possibilities? And she is of 2 years duration, gradually progressive, in an, around a 50 years old lady. So what are the possibilities?
Could be a degenerative disease because of the chronic history and progressive thing. Most probably involving the like anterior horn cell, like motor neuron disease.
Okay. So degenerative, you are fixing the patient. You are dooming the patient. Yeah. Okay. So before going to the degenerative, what are all the treatable conditions? One you discussed, high cervical cord lesion, very good. That has to be considered. Is there any, in the history, is there anything to suggest a high cervical cord lesion? There is no sensory. But one thing you mentioned that we have not explained at all. You said something about swaying to one side.
That was due to the weakness of the right.
We cannot be sure. The patient had swaying. So what are swaying is due to?
Cerebral.
That should be cerebral. So what other, but there are no other cerebellar history. So anyway, keep that in mind. Swaying also is important. Generally you get swaying only in cerebellar lesions or sensory ataxia. Okay. Then apart from eyes, okay. Go to the examination.
The patient is conscious oriented. The temperature was 98.2. BMI was 17.6 kilograms per meter squared. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. There were no neurocutaneous markers, no peripheral nerve thickening. She has a tattoo over her right forearm. Pulse rate was 88 per minute, regular in rate, rhythm, normal volume, no specific character, no vessel wall thickening, no radioradial or radiofemoral delay. BP was 120 by 80 mmHg measured in the right upper limb in supine position, and on standing after 3 minutes it was 120 by 74 mmHg. Respiratory rate was 16 per minute, it was regular and thoraco-abdominal type. Single breath count was 24.
The tattooing, is it a significant, anything blood-borne causing all this?
Viral infections, HIV, HCV and hepatitis B transmission we'll look for. And in HIV, manifestations can happen, but most common will be peripheral neuropathy, distal symmetrical it can present. In AIDS, we can see AIDS dementia complex that can be associated with motor involvement. Patient is right-handed, conscious and well-oriented to time, place and person. Memory, immediate, recent and remote intact with an MMSE of 28 by 30. Speech, verbal output was normal, fluency was intact. Articulation, she had a palatal dysarthria. Comprehension was intact, repetition was intact, reading, naming and writing were intact. She has a nasal twang to her speech and there is hypophonia also present. There was no emotional lability. Cranial nerve examination. All cranial nerves were found to be normal except for the 9, 10 and 12 examination. 9 and 10 examination, the uvula was in midline, the gag reflex was absent with palatal movements decreased, and 12th nerve examination, the tongue bulk and tone was normal, fasciculation was present and the power and tongue protrusion was reduced. Motor system examination.
What are you concluding with the tongue? And the uvula.
Fasciculation is present, so mostly LMN involvement, I'll think. And gag reflex is absent, so again 9 and 10 will go for LMN involvement.
So it is bilateral?
Yes.
Palatal movements are diminished bilaterally.
Diminished bilaterally.
Gag reflex is absent.
Absent bilaterally.
Okay. Regarding the tongue, you said bulk and tone was normal. Okay. And the patient is unable to protrude the tongue?
Fully, sir. Okay. Reduced protrusion is there, and she's power testing also it is reduced.
Differentiate a human and element
tongue. Spastic tongue.
12th nerve palsy.
In 12th nerve palsy, the increased tone of the tongue, Small tongue, which is in the difficult to protrude, will be for UMN tongue. And LMN is a flaccid large tongue with wasting and fasciculations which will be seen. And on articulation, spastic tongue will cause more difficulty in articulation than a flaccid tongue.
If it's at right 12th nerve palsy, how will the tongue on protrusion go?
Deviated to right side and wasting on the right side. Motor system examination, the attitude, patient in supine position, bilateral upper limb on the side of the body, supinated arm and adducted, bilateral lower limb extended at the knee joint, left leg ankle was in neutral position, whereas right leg ankle was plantar flexed and externally rotated, bilateral calf and thigh muscle wasting was seen, small muscles of hand wasting was present, right more than left, thenar and dorsal interossei wasting was present. Fasciculations were present over the right arm and thighs or right thigh. Bulk, there was no gross changes in the both the sides. Upper limb and lower limb, there was not much difference, not much asymmetry. Tone, upper limb right was spastic, left was normal. Lower limb right, I'm sorry. Yes sir, lower limb and upper limb right side was spastic. Power examination, upper limb and shoulder, abduction up to 15 degrees, supraspinatus was 4/5 and bilaterally, 15 to 90 degrees by deltoid was 3/5 and above 90 degree again was 3/5. Adduction was 4/5, flexion was 4/5, shoulder extension was 4/5, internal and external rotation was 4/5, elbow flexion and extension was 4/5. In the wrist, however, flexion was 4/5, but the extension of the wrist was reduced in both the sides, 3/5. Hand grip was 80% in the right side and 100% in the left. And small muscles of the hand.
Can we go to the patient and you can demonstrate?
That is yours.
Thenar more wasted than.
So just the small muscles, what all you notice?
As thenar wasting in both the
So
hands.
what are the thenar muscles?
Thenar muscle is abductor pollicis brevis, opponens pollicis, flexor pollicis and adductor pollicis brevis.
Okay. Then hypothenar?
Hypothenar, not comparatively not much wasted.
Okay. So is there any asymmetry of wasting present in the both hands? Compare the left and right.
Left seems to be more than
Yes,
right.
Exactly.
Hollowing here
left,
is more.
Left thenar eminence
Thenar
is more
eminence.
wasted. There is more hollowing of the palmar
Palmar.
aspect, and you have see the visible tendons on the left side more than on the
Right side.
What is the position of the fingers? You just see
The abductor.
on the right and left side. What is the just? This is a resting position for the patient. How the fingers are going?
Yes, flexion in the proximal interphalangeal joint and abduction of the
So
little
there is an ulnar
finger.
deviation of the little finger. And the other three fingers are slightly, when all the fingers except the index finger is PIP joint is flexed, and there is extension of the distal interphalangeal joint. So there is a tendency for clawing. She has not developed full-fledged clawing, but in future she will develop clawing. What is clawing? What is the actual position of clawing?
Medial
Describe in your
ulnar
hand clawing.
proximal interphalangeal joints.
First thing is there will be hyperextension at the metacarpophalangeal joint and flexion at the interphalangeal joints. So this is the position of clawing. Initially they will get flexion of the interphalangeal joints, but later there will be, since there will be overaction of the extensors of the metacarpophalangeal. So there will be hyperextension of the metacarpophalangeal joints and flexion at the interphalangeal joints, mainly due to what? This clawing occurs mainly due to what muscle weakness?
Lumbricals.
So lumbricals and Lumbricals mainly. Where does the lumbricals act?
For proximal.
So where are they actually
It flexes the metacapophalangeal and extends the
It is one of the
interphalangeal
extensors
joints.
of the interphalangeal
joints.
So they are the main, apart from the extensor digitorum, the other extensor, main extensor is the lumbricals. So they extend the interphalangeal joints. So when they are weak, there will be overaction of the long flexors. So the long flexors will overact. So because of the weakened extension of the interphalangeal joint, you will get the flexion. So that indicates that the small muscle lumbricals are weak, which are supplied by
ulnar nerve.
So both ulnar and median, 1 and 2, 3 and 4. So they are supplied by this.
What
so
is this hollowing and the tendon visibility tells you?
Dorsal intraocular wasting.
So what is this muscle?
First dorsal intraocular.
First dorsal intraosseous. Is there any difference between these two?
Yes, wasting more
Severe
in the
wasting
left.
of the first dorsal intraosseous on both sides, more on the right and on the left
side.
And there are prominent tendon and the dorsal intraossea are all wasted. You can see so much grooving of the hands. So there is severe wasting of the small muscles, especially the dorsal intraossea, palmar intraossea, and there is weakness, tendency for weakness of the lumbricals. So how will you test the abductor pollicis brevis? Where is the muscle? Abductor pollicis is the major muscle of the thenar muscle. Okay, so how will you test that? It acts at where? What are the describe the abduction movement of the thumb? What is that? This movement
This is abduction.
Okay.
This is adduction.
Okay.
This is extension. This is flexion.
Okay. Flexion is along the plane of the palm. So when there is a flexion, this is the flexion movement. This is the extension movement. So this is the
abduction.
This is the
adduction.
So when you are testing the abduction, you have to give pressure at this
MC.
proximal in phalanx. So when there is proximal phalanx, ask the patient to lift. இப்படி தூக்குங்கம்மா,
மேலே தூக்குங்க,
கையை தூக்குங்க, இந்த விரலை வந்து இப்படி மேலே தூக்குங்க, நல்லா தூக்குங்க. Or else you can ask, இந்த விரலை தொடுங்கம்மா, இப்படி தொடணும், இப்படி வந்து தொடணும், இப்படி தொடணும், கீழே வச்சுங்க, இப்போ தொடுங்க. This is abduction. So when there is abduction, you can give resistance or against resistance, without resistance or with resistance. So this abduction. Adduction is by
card test. You can face the card here and to hold it tightly, and we can.
No, that is for other fingers.
Here you can apply pressure resistance here and tell.
Ask the patient to adduct. So how will you test the flexor digitorum? Though it is not a small muscle, flexor digitorum profundus.
Profundus we'll place in the middle phalanx.
What is the action of the flexor digitorum profundus?
In the DIP. Flexion of the DIP.
You have to see that. You have to give the. You cannot hold or hide the distal phalanx.
You have to fix the proximal phalanx.
On this side. Yeah.
Ask the patient to flex.
This side.
But you cannot make out the flexion. No, yeah.
Fix the
middle phalanx.
Middle phalanx. இந்த நுனி விரல் அப்படி மடக்குங்கம்மா, இந்த இடத்துல நல்லா மடக்குங்க. So this is the flexor digitorum profundus. Okay. Flexor digitorum superficialis is here. நல்லா மடக்குங்க, நல்லா. Okay. Then
opponents.
This opponents, what is this?
இந்த கடைசி வரைக்கும்.
How do you give resistance?
டைட்டா பிடிச்சுக்கோங்க, நல்லா டைட்டா.
So always this will be easy. You have to make the patient do like this.
Okay.
So the tip of the thumb and the tip of the little finger should be opposite. If you do like this, this will be easy, pressing. But this is slightly difficult. So this is the ideal to test the opponents. Okay. Then abduction and adduction, palmar and dorsal intraossea.
Rest the hand down, and then we can tell her to. Amma.
You have to do like this. So
to see the.
Like this.
So whenever you are examining hand, rest the hand properly and then ask them to do whatever muscle you are testing.
Moving away from the midline is abduction.
Moving towards the middle finger is adduction.
இந்த விரல் இப்படி தள்ளுமா. So this will be easy. When you are testing like this, the patient will not tell, or the different card test you can place. Cardboard should be of sufficient thickness. Okay. So So ask the patient to abduct and adduct.
Adduct.
Abduction is by?
Dorsal introition.
Okay. Adduction is by?
Palmar introition.
Okay. So all these are supplied by? Ulnar nerve. Thenar muscles are all supplied by the?
Median nerve except the adductor which is supplied by the ulnar nerve.
Okay. So the weakness is in the hands, and then where all you told?
said the wrist extensors are more demonstrated.
Amma, right, puchukon kai ippudu. Mala. Keela vaingi first. Mala. Mala.
So two things, when you are testing the power, first place the patient in the neutral position. Either you can ask the patient to force against resistance, or you can break the you have to break their power by applying resistance, or the patient has to move against resistance. So sometimes if they are powerful, now ask them to do the full movement and then ask them to hold it tightly, then you try to break the resistance. That will be 4 power. Okay. First, initially when you are testing the power, test against gravity first. So that will give a baseline. It is below 3 or above 3. So when the patient is able to lift against gravity, then it's above 3. Then you test for 4. Then resistance you give, mild, moderate and severe. So initially for testing the power, whether the patient is able to move against gravity or not. So that will be the first thing. But suppose if the patient has 0 power, it will be very easy. No, patient will not be able to move only figure of interaction. But if you want to do a quick neurological examination, test for 3. So if she is above 3, then you test for 4. Okay, so next is in the lower limb, you said there is wasting. Is there foot wasting? Okay. Demonstrate the reflexes. Tongue. Set fasciculation. What is it? Speech. அவங்க பேர் சொல்லுங்க. சத்தமா சொல்லுங்க. எங்க இருந்து வரீங்க? What is the description of this speech? எங்க இருந்து வரீங்க சொல்லுங்க. What all you infer from the single word she has spoken? Dysarthria is there. Then what type of dysarthria?
This is flaccid dysarthria, palatal dysarthria.
Why alone palate? Can you understand what she has spoken?
Yes, sir.
Very difficult. With difficulty only you can understand. So there is an lingual dysarthria. As evidenced by there is slurring of speech. Simple words can tell you whether it is a labial, lingual or palatal or guttural dysarthria. So that is dysarthric component. So what are the different types of dysarthria?
Spastic dysarthria, flaccid dysarthria, and ataxic dysarthria can be there, sir. In ataxic, we'll have staccato, scanning speech and staccato.
What speech you get in Parkinson?
Hypokinetic dysarthria.
Hypokinetic. So you can get sometimes, apart from increased tone in spastic dysarthria, you can get what is known as dystonic speech also. Extrapyramidal movement disorders, where you get, there also you can get strained speech, which is due to dystonia of the larynx. So that is also there. Okay.
The tongue you can show the.
நாக்கு நீட்டுங்கம்மா, நல்லா நீட்டுங்க. ஸோ சைடில் ஆட்டுங்க, நாக்கு நீட்டுங்க. இந்த பக்கம் நல்லா நீட்டுங்க வெளியில். ஸோ ஷீ இஸ் ஏபிள் டு protrude. வாய் நல்லா
நீட்டுங்க.
வாய் அப்படியே உள்ளே வச்சுக்கோங்க. இந்த நாக்கு இங்கே முன்னாடி லைட்டாக
பல்லுக்கிட்ட வச்சு உள்ளே வச்சுக்கோங்க.
அப்படியே வைங்க. டார்ச் நல்லா வாய் தரங்க. வாயை மூடிட்டு அப்படியே தரங்க. Sometimes very difficult to identify the fasciculation. Even tongue tremor will look like a fasciculation. So always you should be examine the tongue in the position of rest. Best is ask the patient to just open the mouth without protruding the tongue. That will be the rest position. But most often the patient will not cooperate. Once you open, either they retract the tongue or they protrude the tongue. So நல்லா வாய் தரங்க. அப்படியே லைட்டாக அப்படியே பல்லுக்கிட்ட லைட்டாக நீட்டுங்கம்மா. அப்படியே வச்சுங்க. வாய் நல்லா தரங்க. நல்லா தொடங்க. So very difficult to make out, but she is contracting the tongue. There's slight occasional twitching, but it's very difficult to make out because once they start contracting, the fasciculations might disappear. Oh, okay, so that is, very mild finding, but you have to palpate the tongue for the tone. So just reflexes. So it is what, brisk or exaggerated or? Okay. Good. So finish off this one.
And then go to the next reflex.
Oh, so that is very important. Why? Why finger flexion is important in this patient? So you are demonstrating an element sign in the hand in form of wasting. So if you demonstrate a human sign, the same C8T1. Okay, the element is C8T1. So same C8T1, if you demonstrate in human, then there is an element human in the same segment. So that is why certain reflexes are very important in this patient. Okay. Good. So I have to place it here in the middle phalanx and then tap. So this reflex so finished up of Hoffman and Wattenberg. Very good. Yes. So tip of the fingers, not fully, tip of the fingers. Just use only the catch the tip. Pull it. இந்த பக்கம் இந்த நுனி விரல்ல போட்டு எடுங்கம்மா, நுனி விரல்ல எடுங்க.
It's very classical, this segments.
So you have to give full pressure on the tip of the tongue. Okay. So then lower knee jug. Okay, you just have to demonstrate plantar.
Plantar.
So always don't use a pointed thing. Better with the blunt object.
What's your finding? Plantar?
Don't go up to the ball of the big toe, just short of the ball of the big toe. If you touch the ball of the big toe, normally it will extend. So even though this position is described, I find this is very difficult because when you are doing like this, you are not able to see the extension of the other toes. So always I prefer like this, but generally you do what would textbooks say. But easily it will be like this. If you can observe, you see, always the outer aspect of the sole. You should give sufficient, see, depending on the patient's reaction. In some patients, even a slight stimulus will elicit an extensor. In some patients, if with a thick sole, you have to give more sufficient pressure to elicit an extensor. So, depending on the patient's tolerability and her response, you can modify the stimulus. Okay, but always from the outer aspect of the sole up to the inner aspect and then go medially, but not to the ball of the toe. Okay, so it's right, there is a suggestion of extensor, it is not clear, but there is some hyperextension at the toes, whereas left there is extensor.
Plantar equivalence in the lower limb. Anything seen positive like upper limb? Try now. Open hips.
I'm going to take this side. So you're getting, so you're getting that you have to give sufficient pressure. See?
It's extension. Open hips is positive.
And squeezing the Achilles tendon.
That also is present.
If there is amputated toe, other toes also hyperextension can see. Only a great toe I am telling. If all toes are amputated, you can still feel the tensor fasciae contraction. Okay. So sensory is normal. Is there lower motor neuron sign in the lower limb? Thighs. You said fasciculation also. Is there a fasciculation demonstrated anywhere?
Only by stimulation.
How will you bring out latent fasciculation?
Hyperventilation and by smacking the muscle.
No, just hyperventilation will be enough. Okay, because sometimes twitching also will, you can cause, and even on normal individuals also, but hyperventilation definitely will bring out the fasciculation. Okay. Any visible fasciculation here?
Hospital.
Mamu cheerthu vidinga vegam. Nalla vegam. Nalla vegam.
Yeah, okay.
நல்லா இழுத்து விடுங்க, மூச்சு இழுத்து விடுங்க. இந்த மூச்சு இழுத்து விடுங்க நல்லா. Not much visible. So another thing you have to look at is, even though it is not present, you should look for polymony myoclonus. If it is present, it is not present here, but some fasciculations of the small muscles of the hand will cause polymony myoclonus. கை ரெண்டு நீட்டுங்க. Daving. சாதாரணமாக விடுங்க. Okay, finally concluding.
Involvement. The structures involved are the corticospinal tract, the anterior horn cell and the nucleus of the 9, 10, 12th nerve. Corticospinal tract involvement in the cervical, thoracic and lumbosacral region, and the nucleus of 9, 10 and 12th cranial nerve involvement. Etiology most likely to be degenerative because of the chronic progressive course, and most likely diagnosis probably is MND, ALS with bulbar involvement.
Okay, see corticospinal tract involvement, you said reflexes
Exaggerated.
are all exaggerated. What all reflexes?
Her
From
biceps.
highest level of reflex?
Pectoralis is also present for
okay,
us.
above that?
Jaw jerk is normal, sir, not exaggerated.
Okay, any other reflexes you want to test in the cranial? So you divide it into cranial, cervical, thoracic, lumbosacral. So you are having LMN human sign in the lumbosacral in the form of brisk reflexes, wasting in the lumbosacral region. In the thoracic, of course, we cannot make out because truncal muscle, but still abdominal reflexes is it present or absent?
Absent.
Okay, then upper cervical region, there is both wasting and then brisk reflexes. So again, there you are getting an LMN and human sign. Now we need an LMN human sign in the bulbar cranial musculature. You have got evidence for LMN in the form of twitching tongue. So human, you have to look at the reflexes.
Gag reflex is absent.
Absent. So that is not favorable. Next.
Human.
Palmomental, are there any release reflexes?
No.
That is important in this patient because release reflexes will again take an human sign in the cranial, say like palmomental, snout, all these deep facial reflexes will tell there is an human sign in the cranial with LMN sign. So here, so there is human LMN in the cervical and lumbosacral. Definite. Okay, so this will fit into what type of ALS?
3 region is showing UMN plus LMN, so definite ALS with bulbar involvement.
Okay, 3 region is here?
Here the cervical, lumbosacral and bulbar, thoracic, sir.
Thoracic we have not mentioned, found out anything. Only truncal weakness is there. So cervical, if at all you can say probable ALS, but I think it is even bulbar also. So what are the other things you like to, treatable condition you like to rule out?
Syringomyelia again, syringobulbia, we don't have any sensory symptoms, so we're not entertaining that, sir. And cervical spondylosis, but with cranial nerve involvement, again unlikely, sir.
High cervical lesion?
Again, sensory involvement is not there, so only motor involvement with progressive lesion.
So in summary, all the other differential diagnoses will go out when you find an UMN, LMN in the same segment. Without sensory, without cerebellar. Especially sensory is important. If there is no sensory, LMN human sign in the cervical cannot be explained by any other etiology. Okay, both, that is involvement of both the anterior horn cells and the pyramidal tract. Without involvement of the sensory structures, you cannot put any other differential diagnosis in this patient except an ALS. Okay, but still certain treatable conditions, pure motor like, okay. So what is this, is it classical ALS?
Yes. Yes, sir.
What are the variants of ALS?
UMN onset, LMN onset and bulbar onset ALS. Familial ALS and sporadic ALS.
Anything localized forms?
Flail arm, flail leg and Mills hemiplegic variant.
And then is there a monomelic variant?
There is a differential for Hirayama.
Okay. So monomelic variant, Hirayama disease. So all these are other conditions you have to rule out. Okay. Thank you. Very good presentation and discussion. Thank you.
Covering every possibility and explaining how to systematically analyze and localize the findings. We request Dr. Emmanuel Bhaskar sir, Professor Department of General Medicine, to felicitate the moderators, Professor Dr. Bala Subramaniam sir, and Professor Dr. Devas. Thank you. So we welcome the PGs, Dr. Saravana Kumar and Dr. Sharanya onto the stage for the next case presentation. We welcome the moderators for the next session, Dr. Preetham Mathur sir and Dr. Swati Murthy ma'am. Dr. Preetham Mathur sir is Professor of Medicine at Sri Ramachandra Medical College and Research Institute. He completed his MBBS and MD from the prestigious CMC Vellore. He was conferred FRCP in 2009. He has multiple publications in national and international journals, including Lancet Infectious Diseases and American Journal of Cardiology. He has edited a monogram titled Treatment Protocols of Common Medical Outpatient Conditions. He is an examiner for MBBS exams, Depend B exams for medicine and infectious diseases and MRCP. He has handled multiple administrative responsibilities in this institution. Dr. Swati Murthy ma'am is an associate professor at Ramachandra Medical College. Ma'am is an alumni of PSG Institute of Medical Sciences and Research. She completed her MD from our college, Dr. Sri Ramachandra Medical College and Research Institute. Ma'am has multiple publications, up to 42 publications in multiple reputed journals, including BMJ, Journal of Infection in Developing Countries, International Journal of Scientific Research, and is a part of many ongoing research projects. She is a peer reviewer for Journal of Tuberculosis and Other Mycobacterial Infections and Curious Journals. She is a board member of Sri Ramachandra Farm Vigil newsletter. She is a member of various associations, including Association of Physicians of India, and she is the NAC department coordinator in our institution. She has she's an excellent teacher and has keen interest in academic skills of both undergraduate and postgraduate students. We welcome both of them.
Thank you. Okay. Today's case is going to be peripheral neuropathy, so that's a topic we are going to cover. And what we are going to do is, two of them are going to present. How we have planned it is, there are some standard questions which normally we ask in an exam in peripheral neuropathy patients, which will be projected, and the questions will be directed towards you people. You can answer what you know, then we will project the answers. There will be a lot of extempo questions also which will come, which will be directed at RPGs or anybody. Okay, so extempo there will be no answers which will be projected. But the standard questions which are for the exams will be projected. Okay, right.
Very good afternoon. I know it's a very long day. From morning we've been blogging your minds with all case presentations. We are going to end up today with this case discussion. Now, as Sir said, since this is peripheral neuropathy and I have a varied sectors of postgraduates right from the first years till the exam going postgraduates, so the discussion and the questions will be catered at various levels such that we cater to every set of the postgraduates who are here. And at least what we aim to is by the end of this case discussion over the next 1 hour and the discussion, we would like or we would ensure that you at least know the basics of the ways to approach how a patient with peripheral neuropathy, their common symptoms, analyze the symptom and the common etiologies across, understand how you differentiate a weakness in a neurogenic and a myogenic cause, understand what is axonal and what is a demyelinating neuropathy, understand how you differentiate the symptomatology in sensory wise across a small fiber and a large fiber or length dependent. These are the common terminologies used when you come across a case with a peripheral neuropathy. And of course, how you get to see the common causes across treatable, which cannot be treatable, which you have to go for a palliative management or a symptomatic management, and how you approach therapeutically these cases. With this, I think we can ask our postgraduate, Dr. Sharanya and Dr. Saravana Kumar, to go ahead with the presentation.
Good evening. A 34 years old male, studied till 10th standard, right-handed, currently not working for the past 3 years. Previously was
Saravana
working.
Kumar, we need you to be more louder.
Currently not working for past 3 years. Previously working in a Xerox shop, residing in Chennai. Presented with chief complaints of weakness of both the lower limbs for the past 18 years and weakness of both upper limbs for the past 6 years. History of presenting illness. Patient was apparently normal until the age of 16, after which he noticed weakness of both lower limbs in the form of difficulty in gripping slippers while walking, which was insidious in onset and slowly progressive. following which he had difficulty in climbing stairs without support. Patient also noticed difficulty in squatting and required support to get up from squatting position. Patient is able to walk on flat surfaces without support. The weakness was associated with gradual thinning of lower limbs below the knee. There is no history of any involuntary movements over the lower limbs. There is no history of buckling of knees or tripping of toes. 6 years ago, the patient noticed upper limb weakness in the form of difficulty in holding the pen, which was insidious in onset and slowly progressive till date. Patient also had difficulty in buttoning his shirt. Patient can able to hold glass of water, mix and bring the foot to the mouth, comb his hair and hold the handle of the bus while he is traveling.
Before you go into that question, when you see a patient who says there is weakness and there is wasting, what else should have come in your history?
Patient who presents both with weakness and wasting, possibilities might be peripheral neuropathy or an anterior Hansel disease. So, history of
when you see weakness with wasting is what? Low motor.
Low motor.
So what else? What are the other history should have come? You have not got that in.
Fasciculation history.
Yes, fasciculation.
There is no history of any involuntary movements, he says. He never noticed any involuntary movements in his lower limbs in the form of twitching or anything.
Can somebody have physiological fasciculations?
Yes, benign fasciculations are common.
So how do you differentiate a benign fasciculation from a pathological fasciculation?
Pathological fasciculations will always be associated with wasting of muscles, and there will also be weakness of the limbs. And benign fasciculations will more be transient. It is usually aggravated by conditions causing stress, anxieties.
So the fasciculation should have been part of your. If let us say that weakness was due to an upper motor, do you think you would have wasting?
In long-standing upper motor neuron weakness, we can get wasting because of disuse atrophy, sir. But it happens after a quite long period of time.
Okay, so we'll start with the first question. How do you differentiate a myogenic weakness, which is basically what? What condition are we talking about? Myopathies. From neurogenic weakness, which is basically a stroke or whatever. How do you differentiate it? What are the points you look at? I want them to have Solomon.
Pains, cramps and involvement would be more proximal rather than distal.
In?
Myopathies.
Okay, good. Anything else? There are multiple things you look at, no? What about the reflexes? Is there wasting? What?
So myopathies, usually long-standing myopathies, there will be a significant wasting, but initial stages there won't be significant wasting. And reflexes will be preserved in myopathy until there is significant wasting. And cranial nerve, autonomic and sensory will be preserved in myopathy. There will not be any associated cranial nerve, sensory symptoms or autonomic disturbances.
Yep, the answers. Changed, eh?
It is not coming.
Okay, you look at the reflex, you look at, see, typically neurogenic will be distal weakness, whereas myopathic will be proximal weakness. All of us know that myopathies, proximal weakness basically depends on the bulk of the muscle. Neurogenic, usually typically distal muscle. And reflexes will be preserved in myopathic, whereas not preserved in neurogenic. When a crash actually.
by the time we get that set. Now, as for the major history of presenting illness, what we have understood, it is a predominant motor weakness. So it's a progressive motor weakness over a couple of years without sensory symptoms. There were no major lead of sensory symptoms. What do you think would be the common causes which would present that way? Predominant motor with atrophy without any sensory symptoms.
Anterior horn cell involvement will produce predominant motor with atrophy without sensory involvement.
Okay, but we did not have any lead of any fasciculations here. So keeping that in mind, I would expect some more differentials or
GBS.
Over years like this? Lead poisoning, yes.
Porphyrias.
Okay, acquired adult porphyrias, yes, sometimes can.
Multifocal motor neuropathy with
very good. Multifocal motor neuropathy should be kept in mind. Then
pure motor weaknesses like hereditary spastic weaknesses, tropical spastic weaknesses, laterism.
More than laterism here. So will laterism come? No. So we've given you very classical 3 leads here. Predominant motor weakness with atrophy without sensory symptoms. A case which I just discussed previously. Motor neuron disease. Then hereditary motor neuropathies. Any other drug which can also present with this way of weakness? Dapsone. Never forget, even dapsone toxicity can present. Your post-polio state. Post-polio, they'll only have motor weakness and you will have wasting observed. But will they give you history of any sensory symptoms? No. So whenever you have such a combination, you have a motor weakness which has been progressive over years, you have an atrophy without any sensory symptoms, at least these should quickly run through your mind so that you know how further your history can negate these conditions or you favor these conditions. Your history list should go on according to these. Okay?
And the pattern of weakness more in the distal, and in myogenic it will be proximal, and deep tendon reflex will be preserved in myogenic but absent in neurogenic, and muscle wasting will be seen in neurogenic, and myogenic generally it will be absent. And sensory history, patient also gives history of tingling and numbness over the feet during the initial course of illness for the 2 years, after which he never complained of any such symptoms, no other major sensory complaints. Autonomic nervous system.
When you talk about sensory, what are the positive sensory symptoms? What are the negative sensory symptoms?
Positive sensory symptoms: burning, pain, tingling, paresthesias, dysesthesias, allodynias, hyperpathias are all positive. Negative sensory symptoms can be numbness, loss of any sensations, or
Okay. Now, when somebody has sensory symptom, when do they reach to the doctor? Reach out to the doctor?
if they have severe pain during night or something, like pain disturbing their sleep, or if they have numbness.
Usually the positive symptoms is what will make them reach out to the doctor. Negatives usually don't. Okay? So remember that. So when somebody has a positive symptom, invariably they reach out to the doctor. Right.
Autonomic nervous system, patient able to feel bladder fullness, hold urine and void completely. There is no history of any urinary and bowel incontinence, no history of any abnormal sweating, postural giddiness or erectile dysfunction.
Sarunan, in just continuity of your sensory symptoms, when you said paresthesia, for the benefit of the first year postgraduates, what does paresthesia mean to you all? What does paresthesia and what does dysesthesia mean to you? It's so difficult. You just said positive and negative symptoms. What is paresthesia?
Paresthesia, you have an abnormal sensation without absence of stimulus. In dysesthesia, you will have a stimulus which is perceived as an abnormal sensation.
So in an absence of a stimuli, if the patient is perceiving an abnormal stimulus, that is paresthesia. Dysesthesia is an altered perception of a stimuli. So what does paresthesia clinically tell us? Where do you commonly come across paresthesia? Spontaneously a patient comes and tells you I have some burning pain. Very common in diabetics. That is a form of paresthesia. Why do you get that?
Usually.
I want you to explain me the symptom origin. What happens? Is it purely small fiber? Or how is that small fiber symptom coming up? See, how we approach your symptoms, not just as positive and negative, you can also approach the neurological symptoms as irritative or destructive. It can be both irritative and destructive symptoms in sensory, irritative and destructive symptoms in motor. When you have irritation of your small fibers, so they go totally uncontrolled. Throughout the neural axis, it is the long fibers which modulate the transmission across the small fibers. So when you have undue firing of your small fibers, that is an irritative lesion for your small fibers. They go totally uncontrolled by the long fibers. Or there is a problem with the long fibers. Long fibers are predominantly your myelin based. So if you have some long fiber disease, they are not able to control your small fibers. Even then you will have your paresthesias. So it is not purely a small fiber symptom. You can still have paresthesias with your long fiber also. How do you approach a patient who has come with dysesthesia? What is dysesthesia?
For a normal sensory stimuli, patient feels an abnormal sensation.
That means what? You touch a patient is feeling pain. What does it tell you?
There is a decrease in threshold of pain stimuli.
In terms of prognosis or in terms of how in nerve injury time frame, when a patient is giving you a dysesthesia, what does it tell you?
It's an acute.
It tells you recovery has set in. But only thing is, you have a nerve fiber damage. It is not being replaced by the same nerve fiber, but you have some other nerve fiber. Suppose touch fiber is damaged. The regeneration or the recovery is happening because of the pain fiber here. So all the entire central impulse transmission is going through a pain fiber rather than a touch fiber here. So they are perceiving it as pain even when you're touching. So that's the altered perception. It tells us there is recovery. Only that the recovery is not by the same fiber, it is by a different fiber. Right? So it is basically a neuronal crosstalk. How we have crosstalks in our phones, this is a neuronal crosstalk. Right?
One of the classical example of what she was talking about is crocodile tears. Can you explain what that is?
After a Bell's palsy, patient generally recovers. For those patients, abnormal reinnervation of the nerve can cause when they eat, the lacrimation fibers are abnormally stimulated and they will lacrimate.
The cross connection and produces tears when it is not supposed to produce tears. Okay, so yeah.
Can we get tremors in sensory nerve involvement or peripheral nerve involvement?
Pseudoathetosis.
Pseudo?
Athetosis.
You get pseudoathetosis or you will label it differently. Can you get tremulousness? Yes or no? You talk about fasciculations in anterior horn cells, you talk about tremors at different places, involuntary movements. So can we get in peripheral neuropathy involuntary movements? Or rather, I've even given you the question. Do we get tremors in peripheral neuropathy?
Yes, ma'am, we can get tremors.
You can get tremors. When do you get tremors and how do you get?
CIDP patient will have CIDP, chronic.
What's the explanation why you have tremulousness? Again, it's a mark of recovery only. When you have regeneration, both your agonist and the antagonistic muscles are getting innervated by the same nerve fiber. So when you are asking a patient to maintain a posture, both agonist and antagonist are in action at the same time because they are innervated by the same nerve fiber, so they are not able to maintain a position. So you get that tremulousness. Unlike the pathological tremors of your basal ganglia, they are not rhythmic and they are not repetitive. So they are also called as arrhythmic pseudo-tremors. You don't get tremors, but you get something like a tremulousness because they are not able to maintain a posture. Again, it is a sign of recovery and regeneration.
Cranial nerve history. He is able to appreciate smell of coffee and food he eats, able to see bus numbers, no history of blurring of vision of lotus, able to feel hot and cold water over his face, no history of impaired sensation over his face.
Saravanan, is there any cranial nerve history which is positive?
No positive cranial nerve.
Just move on.
Cerebellar history, there is no history of unsteadiness while sitting or standing, able to speak fluently, able to complete a meal without spilling, no history of swaying to one side while walking, no history of any no extrapyramidal symptoms, and past history, no previous medical illness, and family history, no similar history of no similar complaints in his family members. And personal history, consumes mixed diet, he has a good appetite, has normal sleep pattern, does not consume tobacco or alcohol, no other substance abuse or toxin exposure. And history summary, a 34 years old male, no known comorbids or significant family history, presented with insidious onset, slowly progressive, symmetrical, predominant distal lower limb weakness for the past 18 years with thinning of distal muscles of the lower limb. He also complains of symptoms of proximal muscle weakness in the lower limb, and he also gives history of distal weakness of the bilateral upper limb for the past 6 years. There is history of tingling and numbness over both the feet during the initial course of illness. No history suggestive of any higher mental function, cranial nerve, cerebellar or autonomic system involvement.
So what structure is involved? I mean, what do you think has happened? I mean, with all this history, what do you think of?
His presenting complaint started 18 years back, and the first complaint was a distal lower limb weakness, motor predominant. And during the entire course of illness, his symptom was more symmetrical and it was more length dependent. There was a gradual progression from lower limbs and then proximal and then his distal upper limbs. And he gives one history of tingling and numbness in the bilateral lower limb for 2 years, which was not consistent now. With this history and the symptoms started 18 years back, I would like to think structure involved. First, I would like to think of a peripheral nerve or a distal limb. One thing, because of significant weakness and wasting, one more differential can be a distal predominant SMA possibility because of significant wasting and thinning, or can be a distal.
No, when you have a prolonged history, a CNS symptom which is slowly progressive, what is the etiology we are looking at?
Degenerative etiology or inherited.
Those are the two common things which we look at. But how will you differentiate these two, inherited from a degenerative? Is this degenerative?
This is a form of degenerative. But
okay.
Whether it is inherited or acquired, I'm not sure. Because of its age of presentation and
more
pattern,
likely
so more likely an inherited degenerative disease.
Okay. So usually, what are the different ways a CNS disease manifests? I mean, in terms of time duration, what are the different ways?
It can be an acute onset.
So acute means what are the things you will think of?
Vascular etiologies like strokes or any demyelination like GBS, you'll think of.
No, DBS, is it that acute?
It's not that acute. It can happen over a period of weeks,
Yeah,
or
so
it can
that's really not acute.
transverse myelitis can present as an acute onset paraplegia.
Then the next duration is what?
Next is insidious or subacute onset of illness, like GBS or any toxin related can present. It can present both as an acute and subacute course of disease.
Then the chronic group, which is the very slow progressive, which is usually we're looking at degenerative. Okay. So you think this is probably inherited type of a disease?
Etiology wise, it can be an inherited disease. Structure, because of distal to proximal progression and symmetricity was maintained throughout the course of illness with a positive sensory complaint, I would like to think of a peripheral nerve. And my second differential could be a distal onset SMA, or my third differential could be a sort of any demyelinating diseases like CIDP.
What is going against demyelinating in your case?
Against demyelinating. Usually CIDP will present simultaneous distal and proximal muscle weakness. There won't be like both are equally involved. There won't be disproportionate weakness in the lower limb compared to the upper limb. This patient had a disproportionate weakness in the limb.
Significant disproportionate history was there, right? In context to time frame, when you're talking about a neuropathy, what temporal way of classification? You said acute, subacute and chronic. What is the time frame for each of these?
Acute will be less than a month, subacute will be between 1 to 3 months, and more than 3 months you can classify it as a chronic.
It's usually less than 4 weeks, 4 to 8 weeks and more than 8 weeks. If we have to use the term hyperacute presentation, that is when we use it when it is less than 72 hours. Which conditions present as hyperacute phase?
Generally, necrotizing vasculitis can present
predominantly a vasculitic group of all your involvements present in that fashion. Okay. Is there any other way how you can temporarily classify the neurological disorders or neuropathies?
That's coming as a question. A little later it's coming as a question.
Go ahead.
This is a very simple question. This is an undergraduate question.
We expect you people to answer then.
What? What will be the difference between upper motor and lower motor? I mean, you've gone up to the other one. Oh, so you're not giving, you're not wasting your time there, is it? Just put the answers. Just a point I want you to remember is that in upper motor, weakness is more than the wasting, whereas lower motor, wasting is more than the weakness. That is something which you need to remember. Second thing is, of course, the reflexes. I think if these are two major things which we need to look at, right? And on a long term, you may have contractures in upper motor. Now, why is this important? Like when you have a patient coming in with peripheral neuropathy or symptoms of weakness, why should we know whether it's predominantly motor or predominantly sensory? Is it important clinically or not so important? Obviously the etiology, right? But okay, can you just tell a few causes of pure motor, predominantly sensory?
Lead poisoning, aluminum, selenium. Lead poisoning will.
They are all causes for motor or sensory?
Predominant motor. Lead poisoning cause predominant lead, aluminum, selenium exposure cause predominant motor type of weakness, while arsenic and mercury exposure cause predominant sensory involvement of peripheral nerve. And drugs can cause predominant motor pattern of weakness, like platinum-based compounds or vincristine, vinblastin can produce predominant motor weakness.
Okay, you're staying on drugs. What else? What are the other common things?
Nutritional deficiencies, B12 and B6 excess.
You can project the answer.
Predominant motor weakness, acute
I think one of the things is GBS. You should know. If somebody comes with GBS, I mean, when somebody comes with that type of a symptom, you know it is GBS, the way you need to investigate is different, okay? Whereas if it is predominantly sensory, you are looking at typically diabetes. I mean, that's the two common areas I would look at. Of course, there are other causes which you also need to keep in mind, okay? So, I think whenever you see a peripheral neuropathy, yes, diabetes is very important, GBS is very important, paraproteinemia is important, drugs and some deficiencies are important, toxins.
B12 and B6 are predominantly sensory. You can have sensory motor, they are not predominantly motor. And B6 is one vitamin where both deficiency as well as toxicity can present as neuropathy. That's only one vitamin where both can have neurological manifestations, either deficit or excess. When you were presenting, you did use the term length-dependent neuropathy. What do you mean by length-dependent neuropathy?
Length-dependent neuropathy is generally these neuropathies, the longest fibers are involved, and the degeneration is usually dying back neuropathies. From the distal to proximal, there will be degeneration. Non-link dependent, it won't follow the similar pattern. Any type of fibers can be involved, and it is usually asymmetrical weaknesses will be present.
So what do you mean by length dependent neuropathy is nothing but the longest fibers get affected first. So which are the longest fibers in our body are those fibers which coming for the lower limb, the foot. So the sensory loss or the disturbances or sensory symptoms start on there, and once as they progress upwards or proximally from the foot up till the knee, then the second longest fibers get involved, which are your major fibers for your upper limb. So for your hand, from the hand it progress towards your elbow, and then the third longest fibers start getting involved, which will be around the anterior abdominal wall. So where do you classically get this sort of a presentation? Clinically, where do you come across? Diabetes. This is the classical glove and stocking pattern of involvement. Diabetes is a classic example. Non-length dependent, you can get patchy involvement or multiple involvement at different areas simultaneously. All that is possible. Okay.
Okay. Before I go into this question, see, we call it glove and stocking, right? It's supposed to be stocking and glove, because the one to go is the stocking, not the glove. Okay. For some reason, it is put the other way around, but I think you need to remember it is stocking followed by the glove. Okay. Now, I'm going to ask you the question in a different way. Should you do nerve biopsy for every peripheral neuropathy? Yes or no? No. Yeah, that's the right answer. So now tell me, what are the conditions where you would look at doing a nerve biopsy?
Vasculitis.
Vasculitis, you will need to do a nerve biopsy. Okay.
Amyloidosis.
Amyloidosis is one. Anything else?
Hansen's disease we do.
Hansen's disease, you should make a... No, basically you need to understand nerve biopsy is an invasive procedure. You do not do it for all peripheral neuropathy. You need to do it only if it is absolutely indicated, if you can't make the diagnosis otherwise. So that's what you need to understand. Okay? Yeah, vasculitis and amyloidosis are what we are really looking at. But even nowadays, vasculitis, you can easily make your diagnosis with your C-ANCA, P-ANCA, etc.
Do you get any findings in nerve biopsy in a patient with CIDP? Because that's another chronic neuropathy which you keep coming across, still confusing for many postgraduates to give a diagnosis there. And it is chronic, like a long-standing history in our case also. Do you think you should be doing a nerve biopsy there? And if at all you do a biopsy, what finding do you expect there?
Loss of the myelin sheath around the...
What do you mean by loss of myelin sheath? Demyelination. No, less likely. We are calling it as CIDP. Expand CIDP fully, then you will get, it is predominantly mononuclear cell infiltrate around the endoneurium. Okay. AIDP, is there any role for nerve biopsy? Will you get any finding if you do a nerve biopsy in AIDP? Yes? No. You do a sural nerve biopsy in AIDP, it will be normal. That's another differentiating point. Sural nerve biopsy, you have a demyelinating polyneuropathy, inflammatory demyelinating polyneuropathy, acute versus chronic. Sural nerve will be spared in AIDP, sural nerve will be involved. You will have endoneurial mononuclear infiltrates in CIDP. Okay?
Yeah, I think this is just for you to understand. I don't think I'm going to ask you what are the questions. Just project the answers. But I think what we really need to look at here is, this is the academic classification where A alpha, A beta, things like that. But I think clinically when we look at it, we look at A alpha, A beta, A delta, and C. B usually we don't look at. But I think we need to look at, I mean, when somebody comes with peripheral neuropathy, you need to know which fibers are involved. That's what we are really looking at, right? So this is something which you need to understand, I mean, remember when you are looking at a peripheral neuropathy, right?
So your large myelinated fibers are predominantly for your motor and proprioception, and pain are with your either less myelinated or the unmyelinated fibers.
Good afternoon. I'll be discussing general examination. Patient is conscious, oriented, comfortable at rest, cooperative. Height 176 centimeters, weight 50, BMI 16. No pallor, icterus cyanosis clubbing, lymphadenopathy, pedal edema. There's peripheral nerve thickening, bilateral ulnar and left peroneal nerve thickening. Pes planus, inverted champagne bottle appearance, and bilateral wasting of upper limb. And a scar of 6 centimeters is present in the left foot, posterior to the medial malleolus.
So,
why does this patient, when do you come across this inverted champagne bottle appearance?
When there is wasting of our quadriceps, when there's wasting of gastrocnemius muscles, then you'll have inverted champagne bottle appearance.
Which are the conditions where you come across this?
In inherited neuropathy like Charcot-Marie tooth, we can come across
Is there any other terminology which you can use instead of this?
Stalk leg is another term.
what is the scar?
The scar was the biopsy which was done, sir, in 2006 when he was diagnosed with a disorder.
Okay, so that means they've done a nerve biopsy.
Yes, sir.
Was it indicated in this patient?
Long-standing chronic neuropathy over many years with no definitive other underlying causes. Maybe nerve biopsy was indicated when no other reason.
No, I think that is the point I think you need to carry home. Sometimes we tend to overdo things which we should not do, especially when you know for sure what it is. It's a disease which is progressing. Definitely there was no indication here. Okay, I mean, people have done it, but I mean, I don't think it was the right thing to do. Done. Go on.
These were the some of the findings which, as I have mentioned before, the wasting of bilateral hand, and the first image is the inverted champagne bottle appearance or the stalk leg appearance.
Yeah, this is, I think it's a very simple question, but you should be aware. Pes cavus, hamatose, and inverted champagne bottle legs is, thin ankles is a typical features of hereditary this thing. And sometimes they say that when somebody has a hereditary problem, they walk funnily. So somebody has a funny walk, you should understand that it could be that he's developing or she's developing a hereditary thing, is one. Second thing, they may be very clumsy with things. You know, some people can't do things and they are very clumsy. You should always wonder whether there's a problem. Okay? Tell me, what is Charcot joint?
Diabetic, it occurs secondary to diabetic neuropathy, where...
what are the nerves involved? I mean, what groups? Okay, proprioception plus sensory.
Joint.
These are two things which are involved in Charcot joint. Okay. Now, tell me what happens in a Charcot joint.
So there is a deformity.
Now, you're only looking at diabetic. Does Charcot joint occur in other situations?
Syphilis.
Syphilis, okay.
Do you come across any case of syphilis? I'd love to hear that. Thank you. It's gone with the win. So what other condition can you come across Charcot's joint apart from diabetes?
We've already put the...
You put the answers, okay.
Okay, so basically most of the Charcot joints are atrophic. That means there's a joint destruction and the size of the joint becomes smaller and it becomes unstable. Okay, there are some situations it may be slow progression with little hypertrophy. Okay, typically lower limbs is diabetes, amyloidosis, alcoholism. Upper limb is typically syringomyelia and leprosy. Right? Yeah, this you should be able to tell me.
Which are the conditions where you can clinically palpate peripheral nerves? They're thickened.
Hansen's disease.
Hansen's, yes, very good.
Hereditary neuropathies.
Correct.
CIDP we can have palpable. Infiltrative nerve disorders can have palpable peripheral.
Name the infiltrative disorders.
Amyloidosis and sarcoidosis can have.
Great. Based on how the thickening is, also you can further classify. Probably we'll just skip that for the time frame constraints now. Proceed with the answer. So you get it in amyloidosis, Hansen's, CIDP, REF-SIMS, Charcot-Marie tooth. Some cases of neurofibromatosis also we do come across peripherally thickened palpable peripheral nerves. So do you have any clues in general examination in any patient who presents with peripheral neuropathy? When you look at a patient who's come with neuropathy, some general examination clues which will pave way to the etiology of the patient.
Trophic changes.
Where all do you come across?
On the...
No, what conditions?
Which conditions?
Diabetic nephropathy.
Diabetes, then?
Diabetes and? Hansen's.
Hansen's.
Skin and nail changes, dry skin, atrophic nails.
Loss of hair.
Loss of hair. Any other condition which you can have ichthyosis? REF-SIMS, very good. Any other general examination clues you can think of?
Signs of vitamin B12 deficiency, hyperpigmentation of knuckles.
Orange.
Okay, I'll give you a
orange.
Tonsil and tangiers.
Very good. Where do you get orange tonsils?
Tangiers disease.
Adult Tangiers disease. Why is the tonsil orange there? Due to deposition of cholesterol esters. Any other clues? There are 6 structures which you'll need to look for in general examination. Skin, hair and nail. Tongue, teeth and
Macro.
tonsils.
Macroglossia for amyloidosis.
So in the tongue you can have magenta tongue, you can have beefy tongue, small tongue, large tongue, they all will give you clues. Then tonsils, you've told me orange tonsils. Anything on the teeth and gums?
Mercury. Burton line, Meese lines and Burton.
Meese line.
Pink teeth, blue line on gums. And nails also you can have blue lines, Meese lines. You can probably even add on raindrop hyperpigmentation. You get hyperpigmentation in between the knuckles. Along with Meese lines, you get to see in arsenic poisoning, common in one of the zone in Kerala. They take Siddha medication which is loaded with arsenic. So you get to see that in that belt of Kerala. Arsenic toxicity, raindrop hyperpigmentation with Meese lines.
Higher mental functions, conscious oriented to time, place and person, memory intact, speech, fluency intact, articulation intact, comprehension, verbal output normal, reading, able to read, writing, difficulty in holding pen and clumsiness while writing, and repetition is intact.
Can you tell me any toxins which can have manifestation with both neuropathy and higher mental function involvement? Open to all.
What are the toxins?
Alcohol.
Yeah,
Alcohol.
definitely.
I think your hands are into tremulousness. Control your tremors.
What else?
Which other toxins?
Mercury poison.
Arsenic, does it have higher mental function impact? Thallium, you should remember. Higher mental function with neuropathy. Okay? So you get to see them in alcohol, uremia, arsenic, thallium, mercury and lead. Move forward.
Cranial examination, cranial nerves, all cranial nerves are normal. Yes.
All cranial nerves are normal, then just move on.
Yes. Coming to the sensory system.
No, finish the cranial nerves.
Neuropathy is associated with cranial nerves.
So if you have a peripheral neuropathy with cranial nerves, there are very few of them, but you should know it. Okay, let me ask a question more open. If you have person with GBS, what cranial nerve will be involved? Huh? And what is that called? Okay, Miller-Fisher variant. So like that, tell me what are the other variations you may find with peripheral neuropathy?
Fifth nerve involvement in Sjogren's and
Sjogren's, very good. Loud.
Optic atrophy in B12 deficiency.
Optic atrophy.
Okay.
Diabetes causing third and sixth nerve involvement.
Yeah, correct. So at least some things you should know. So when you find peripheral neuropathy, typically, there may be sometimes, most of the times it will not have cranial nerves. But you should also look out in certain situations. Definitely diabetes you should look at, GBS you should look out, all these things you should.
So it is predominantly your 3, 2, 5, 6, 7. Less commonly 9 and 10. These are the cranial nerves which you need to examine with caution when you have a patient with neuropathy.
GBS you can have bilateral facial, Sjogren's you can have trigeminal, Kennedy's is lower cranial nerves. I mean, at least you should know some of them, right? Okay.
Coming to motor system, bulk, inspection, wasting present in both palmar and dorsal aspect of bilateral hands below the knee in bilateral lower limbs. Attitude of the patient in supine position, upper and lower limbs are extended. There is minimum flexion deformity in the proximal interphalangeal joint at the third and fourth metacarpals. Coming to the measurements, upper limb 10 centimeter above and below the olecranon is 21 on both the sides. There is uniform wasting on either bilaterally. Coming to tone, upper limb and lower limb, hypotonia on both right and left side. Power, upper limb, shoulder, flexion 4 out of 4 by 5 on right and left side, extension 4 by 5, abduction, adduction 4 by 5, internal and external rotation 4 by 5, flexion, extension of the elbow 4, wrist, flexion, extension 4 on either side. Coming to the small muscles on the hand, thumb, abductor pollicis brevis, abductor pollicis longus, adductor pollis, flexor pollicis longus, extensor pollicis longus, weak. Small muscles of the hands are weak, hand grip weak. Coming to the lower limb, flexion, extension, abduction, adduction 4 out of 5, internal rotation 4, knee flexion and extension 4 on either side. Motor system, dorsiflexion, plantar flexion, inversion, eversion 1, and external hallucis longus, extensor hallucis longus weak on either side, and flexion of the other toes weak. Trunk muscles, trunk, he is able to get up with support. Superficial reflexes, corneal reflex present, conjunctival present, abdominal reflex present, cremastic, plantar, no response, cremastic present. Deep turn on reflexes, jaw jerk absent, biceps diminished on either side, pectoralis jerk diminished, triceps diminished, supinator absent, finger flexion absent, knee diminished on either side, ankle absent.
Okay, before, this is more for practice or usefulness when you start practicing medicine. Whenever you see a motor weakness with reduced reflexes, it's lower motor. All of us know that. investigations are different for that compared to when you have motor weakness with hyperreflexia, investigations are different. So please don't blanketly write CT scan for brain or whatever when you know it's a lower motor neuron lesion. Very often that's what happens in practice. You'll find people writing everything. Please understand you need to make sure what type of investigation you write for what group, right? So obviously this is typical lower motor, right? Now what we'll do is we'll finish and then come and show you some signs, okay? Okay, now this is one of my favorite questions for postgraduates, okay? Whenever you see a patient with motor weakness, you need to see a pattern. The same way when you see a sensory loss, you need to see a pattern. When you see the pattern, then you know what the disease is. So those are the two questions which will come. So if you see a patient with motor weakness, what are the different patterns you will recognize? I mean, it's not a very difficult question. It's a just common sense question. What pattern will I see? If somebody comes with weakness, what are the different patterns of motor weakness will I see? First is it upper motor or lower motor? That's the first part. Second. Okay.
Whether it's
You're on the right track. Tell it loud.
Whether it's proximal predominant or distal predominant.
Okay.
Proximal versus distal. But right, UMN or LMN, proximal
It's the
or
first
distal?
thing, that's the first decision you need to make.
Where?
When you see a...
Involvement.
So let's say if it is upper motor, what are the different patterns you will see? You've seen it. All along you've seen it. What?
How many limbs are involved?
You can have hemiplegia, you can have monoplegia, you can have paraplegia, you can have quadriplegia. These are different patterns you can look at upper motor. Let's say if it's a lower motor.
Mononeuritis, polyneuritis, mononeuritis multiplex, like depending on how many of the nerves are involved, and then depending on which part of the element in that entire circuit is involved, could be muscle, neuromuscular junction, peripheral nerve, plexus, roots.
So, I mean, basically I want you to recognize it. That makes it easier for you to make your decisions, right? Next one. So basically if it is hemiparesis or monoparesis or paraparesis or quadriparesis, then you look at whether it is a multifocal or generalized. I mean, that's a way you need to look at when you're looking at motor, right? Okay.
Sensory system, pain, temperature, touch, normal, crude touch, fine touch, normal, joint position, sense, normal, vibration, time vibration, great toe 2 seconds, medial malleolus 5 seconds, tibial tuberosity 5 seconds, anterior superior iliac spine 5 seconds, thumb rest 5 seconds, and olecranon 5 seconds. This is the mean value of normal time vibrations that we had got from the NCBI article, and as you can see that the average time vibration is around 8 seconds, and as the age increases of the patient, the time vibration reduces.
Most often if you just check a vibration alone, you might have it present in these patients. So it is always prudent that you look for time vibration. The easiest will be compare it with the examiner themselves. When you are stroking, you know the pressure of your stroke, you will look at the number of seconds you are able to perceive the vibration, then stroke the same way and look it at the patient. Obviously, you will have to compare the same bony prominence when you are comparing between the examiner and the patient and see whether perceiving for the same duration or lesser duration. The earliest which you will be able to pick up is a shortened timed vibration rather than loss of vibration. if there are many papers which have come up where they talk about control group. They have done a control population and then compared the patient's values with control. This is one such comparison. In your clinical setting, it is always easy when you compare it with yourself, assuming that you are normal as an examiner with the patient.
Yeah. I think that's a point you need to remember. So if, let us say the patient does say there is vibration, compare it with yourself, assuming you're normal, and see whether it's the same time. That's the only thing you can do. Sensory syndromes, at least a few. Patterns.
Glove and stocking pattern.
Okay.
Hemisensory loss. Hemisensory loss, ipsilateral or contralateral without facial sensory loss. Then dissociative sensory loss.
Dissociative.
Suspended sensory loss. Saddle sensory loss.
Saddle anesthesia. Sacral sparing. So there are different patterns again you recognize. When you see a patient, you can put the... so even when you look at sensory, you should know that there are different ways, and it's important to understand this, okay? So when it is a brain stem, you get a injury, it is a little different. Face and body are in different ways, whereas the thalamic, it's on the same side, on contralateral side. Where there's something called cape anesthesia, which is the central cord lesion. Then you have the dissociative sensory loss, Brown-Sequard. There are different ways. So when you see a sensory loss, and if you can recognize that pattern, you know what the disease is. So you need to look at it that way. Otherwise, just saying vibration is lost, pain is lost, temperature is lost, it doesn't, it does give you some information, but you need to also recognize the pattern, okay? What is the difference between saddle anesthesia and sacral sparing? What is saddle anesthesia?
Sacral spinal cord is involved, S2, S3, S4 fibers are involved, sir.
Which usually happens in which condition?
Conus medullaris.
Yeah, cauda conus. Okay, so where there is anesthesia around only the buttock region, that is the saddle anesthesia. Okay. Sacral sparing is what?
Sacral sparing and lesion is in the center of the cord. Because of the distribution of the nerve fibers, the sacral
lamination of the nerve fibers, sacrum being the outermost, it gets spared. That's all. So you need to understand all this, right? Okay.
Jogrens and paraneoplastic.
Is pure posterior column. Anything else?
Posterior
more common?
column,
more common?
With B12 deficiency.
B12 deficiency, okay. Anything else? TB dorsalis, okay. Yeah, you can put the... Yeah, some drugs also produce that, okay? Yeah.
Cerebellum, heel knee test alone, clumsy, tandem walking, unable to perform. Autonomic nervous system, no postural hypertension, no resting tachycardia. Spine and cranium, normal, no signs of meningeal irritation.
When the motor power is very weak, distally he's got very low power. When you have such low power, you might not be able to assess your cerebellar signs. You will definitely have clumsiness while you assess that. That doesn't mean that the patient is having a cerebellar involvement. Keep that in mind when you are assessing and interpreting your results.
So what are the nervous and autonomic nervous system you can clinically test? Now if you suspect there's an autonomic problem, what are the things commonly we can test, both by history as well as by examination? History, what are the things we can ask?
Orthostatic hypotension.
Okay.
Erectile dysfunction.
Dysfunction then?
Sweating. Bladder and bowel
problems, okay.
Secretions of your body get disturbed. So your lacrimation, salivation, all that will also be disturbed. They can have dry eye, dry mouth.
So that is clinically and by history. But there are some tests which we can do more objectively. That is subjective. So that's what we are going to project. Yes.
This table is taken from Harrison, and as we can see, clinical ANS symptoms include abnormalities in the pupillary reflex, abnormal sweating, postural hypotension, erectile dysfunction, hypo and hyperpigmentation of skin, GI disturbances such as constipation and diarrhea, and urinary retention. The table shows all the tests that is done. So first is the heart rate variation, second is Valsalva. QSAT is a quantitative pseudomotor axon test, which is for the sweat glands, and the other one is head up and tilt table test, the last one. Gait, high stepping gait present. Other systems normal. So the prominent findings were symmetrical lower motor neuron weakness of both lower limbs and upper limbs, distal more than proximal with wasting, large fiber sensory neuropathy, and peripheral nerve thickening. So this is a case of motor predominant sensory motor neuropathy, probably inherited Charcot-Marie tooth disease.
Okay, before we go into that question, if let us say clinically you diagnose somebody who has got peripheral neuropathy, what will be the first investigation you will do?
EMG and C.
Yeah, please understand you need to do an EMG. Why? Exactly, you want to know whether it is axonal or demyelination. If it is demyelination, the set of investigations are different, the treatment is different. If it is axonal, set of investigations are different and treatment is different. Which is more easily treatable?
Demyelination.
Demyelination. Please understand this very clearly, okay? When you see a patient with the peripheral neuropathy, the first test after your clinical diagnosis is EMG for you to decide what test I need to do further. Not nerve biopsy, not skin biopsy, not anything else. Clear? Right. Yeah. Now tell me what is the difference between these two. Can you speak into the mic?
Axonal is symmetrical, length dependent.
It is length dependent. That's the most important thing. Axonal is length dependent, whereas demyelination is independent. Okay.
In EMG, axonal amplitudes of the nerve impulses will be affected, while in demyelinating, the latency will be affected.
So when you have a demyelination versus an axonal involvement, demyelination is just like an apron. You can remove it and wear it anytime. So that means the prognosis is good. So obviously it is going to be acute because of some infection or inflammation. Most often acute. Sometimes, yes, subacute is also possible. Whereas axonal is a gradual loss. So you have insidious onset. And usually it is length dependent, whereas you can get non-length dependent in demyelination. Wherever you can have patchy demyelination happening, you can have non-length dependent manifestation. Sensory would predominate in an axonal, whereas you will have generalized weakness. Ankle jerk is lost early, whereas reflexes can be lost across simultaneously in a demyelination. Wasting again is common with an axonal involvement. And in CSF analysis, you will have elevated proteins in demyelinating disorder rather than an axonal involvement. Recovery, as I said, it's always good. Prognosis is good in demyelination as compared to axonal. When you look at the nerve conduction, it can be normal or abnormal in axonal, whereas it is abnormal. Can you tell me why the nerve conduction is abnormal in demyelination, whereas it can be normal in axonal? Exactly. The nerve conduction is with your myelin. If you don't have myelin, you will have an abnormality in the nerve conduction. Whereas in an axonal, you have the axon which is lost. So your myelin is not disrupted there. So you can still have a normal nerve conduction study in an axonal neuropathy. When I'm using this axonal neuropathy, can somebody explain to me what is short axonal versus long axonal involvement? Long axonal is nothing but length dependent. Short axonal will go in a reverse fashion. Reverse length dependent, that means non-length dependent. So when I say length dependent, which is the involvement which is first in the body? Lower limbs are involved first. So when I am saying short axonal, the upper limbs will get involved first. So which are the neuropathies where you think you'll have the upper limb involvement first? You can have it in multifocal motor neuropathy with conduction blocks. It's got erratic, no? Blocks are there. So you can have upper limb involvement before the lower limb involvement. Certain drugs. Which toxin? Yes, lead can have it that way sometimes.
Okay, here, I mean, we will not discuss too much here, but I think you need to understand there is no one single classification for peripheral neuropathy. There are different ways in terms time duration, which is hyperacute, acute, chronic, subacute and chronic. In terms of localization, presentation, it can be focal, multifocal or generalized. It can be inherited, acquired, by etiology, metabolic, things like that. So please understand, when we are looking at the peripheral neuropathy, these are different classifications we have. But I think clinically, what is very relevant is whether it's demyelination or axonal, because that sort of gives you the directions how you need to go. Okay?
You can also temporally classify them as either progressive or regressive or remitting relapsing. That will also give you probable clues on etiologies.
Next. Yeah, as a physician, drugs are our bread and butter, right? So tell me some drugs which will produce neuropathy. Huh? Yeah. What are antitubercular drugs? One is isoniazid, then anything else? Any other antitubercular drug? Ethambutol is also supposed to be. Okay, then what are the others? Another common infection where you treat. It was an epidemic in 1983 when I was the first year postgraduate. HIV, okay, then.
Chemotherapy.
Okay, so you have some drugs which produces, so as a clinician you should know at least the common ones which produce neuropathies, okay? See, HCQS, for anti-malaria, though it's anti-malarial, when it's used for rheumatoid and things like that, that's where some things can happen. ART is known, anti-epileptics are known, chemotherapeutics are very well known, which produces a lot of problems, okay? Right. This is again one of the standard question for a postgraduate, because again, diabetes and hypertension are things which we need to be completely, thoroughly good with, right? Otherwise, somebody else will take it away from us. So what are the different manifestations of diabetic neuropathy?
Autonomic neuropathy, cranial neuropathy, third and sixth.
Lumbosacral plexopathy.
Which is called?
Diabetic amyotrophy.
Diabetic amyotrophy.
Autonomic, you said?
Autonomic.
Okay, you can project that.
Which is the commonest?
Distal symmetric polyneuropathy.
Distal symmetric polyneuropathy, yes. In diabetes, can your treatment cause neuropathy?
Insulin.
What?
It's called DAN.
What is it called?
Insulin neuritis.
How do you handle it? That is self-limiting. It will resolve on its own.
Okay. The another statement I think you need to remember that if it is a type 1 diabetes, you expect neuropathy in 5 years. And if it is a type 2 diabetes, you may have it then and there. I mean, the day you diagnose him. Okay? And you also need to understand that if you go and pick up 100 diabetics and do nerve conduction studies, you may find abnormalities in a huge number, but less than 25% of them will be symptomatic. So please remember that if you will pick up more peripheral neuropathies in diabetes if you do an investigation. Clinically, they may not have symptoms. Obviously, that doesn't need treatment, right? Only needs awareness and make sure that they don't get into trouble. So you need to understand that we will overdiagnose if you do the investigation in a diabetic. So 5 years in a first type 1, and at the onset itself for type 2, the chances of that person having a peripheral neuropathy is very high. Okay? And typically autonomic neuropathy, some of the things you should remember is typically a diabetic will come with erectile dysfunction, non-response to hypoglycemia. These are all some of the symptoms they will come in with, in which case you need to look at, does he have an autonomic neuropathy? Orthostatic hypotension, these are some of the things they'll come in with. Is peripheral neuropathy treatable? Yeah, obviously. Some of them are. What? Which are the ones? Some of the deficiencies are treatable.
Nutritional deficiencies causing peripheral neuropathy are always treatable. Toxin and drug related?
Let's continue the exposure.
Exactly.
Go on, I mean, this is just a quick thing.
Can you mention any one painful neuropathy?
Pyridoxine toxicity.
Painful? I didn't say sensory symptom.
Amyloid.
Which drug? Your vasculitic neuropathy as well as your Vincristine related neuropathies are painful.
Next. Okay, we'll just show one. See, I know COVID has not made you see too many clinical patients. Now we do have a patient by our bedside. At least see the findings. It's good for you to observe that. கேமரா கொண்டு வர முடியுமா? At all. Okay, can you show me the power in the ankles? So you said 1/5, right? That's what you had written. So what will you ask him to do to decide is 1/5?
Move his ankle at the joint.
So it's only instruction. It's a flicker of movement is there, it is 1, right? Does he have a flicker of movement or no?
No, sir.
He doesn't have? No, you said 1/5. I want to know whether it's 1/5 or more than 1/5. That's all the question is. காலை லைட்டாக ஆட்டுங்க.
What is he actually doing? Is he dorsiflexing
இதை
his
இப்படி
foot.
ஆட்டுங்க. Which one?
Video cut the files.
Okay, that's really no movement. Can you make him do the? You said 4x5 in knee. Show me whether when you say 4x5, it means against.
Against resistance.
Yeah, sure.
That project.
வரலையா? No, knee. You're doing knee, right? Not hip. Knee.
Whenever you're testing for power in muscles, please ask the patient to do the action themselves first. Until unless they are not able to do the action, never touch for resistance. If the power is less than 3 or less than 2, you will not have a difference when you directly give off your hand resistance on a weak muscle. You will not know where to grade muscle.
So this will tell you what? More than? Straight away it's more than 3. Because he is doing it, okay, then you put the resistance. Okay, that's what Dr. Swati is trying to tell you. First ask them to do it voluntarily. If they are moving straight away, it goes to 3. Then you decide it's 3, 4 or 5. Not moving at all, then you have to go to 2 or 1, right?
1 or 2 you will do it later.
Correct. So that's the easy way to go about doing the muscles and power. Any muscle. How do you remove gravity in this muscle? Let's say I wanted to remove the gravity of knee. In the knee.
What is the meaning when he's asking you to remove gravity? What is the grade of power he's asking you to test for? What is that less than 3? He's asking you to test for a power of
2. So 2. What position will you put the patient in? Whichever. So you will make them, to remove the gravity, you will make them go on the lateral position. So you should know most of the time lateral position will make you remove the gravity, right? Can you show us the plant? I think they were showing, telling you very clearly what you should do in previous thing, but I think okay.
When you are eliciting plantar, the only caution which you all will take is you are not going to cross the ball of the great toe. Why is that caution taken? What will happen if you cross the ball of the great toe? Normally there will be an extension. Why do you get the extension there? Now, for the benefit of the postgraduates, how will I differentiate clinically between an L5 retinopathy and a common peroneal nerve neuropathy? We are doing neuropathy only. An isolated L5 radiculopathy versus a common peroneal nerve neuropathy. How do you think I can differentiate? I want you to tell me in just examination. We are at the bedside in a patient. What will you test to tell me it is an L5 radiculopathy or a common peroneal nerve neuropathy? We are doing muscle power. So what action will you ask the patient to do to differentiate the two? What further test will you do to look at a different drug? I've given you the answer already. Aversion. You will look for aversion. Test in them.
I don't know whether he can do. He's not even moving.
You're not going to elicit in
He's
this
not even
to me.
moving. He's not even.
If I ask you to test one more track apart from this, or rather I'll even directly ask you, sensory assessment to differentiate L5 versus common peroneal nerve. where will you look for sensory? In a common peroneal neuropathy, where will be the sensory loss? It will be predominantly below the knee, whereas in L5, exactly, lateral half of the buttocks, right?
Anything else you want to demonstrate? You can see the, wasting very.
Even in the upper limbs, you can see that there is a gross
That's right,
wasting
yeah.
of the,
The
not just the
cutting,
small
yeah.
muscles, but also the long muscles of the hands and the forearm. Just like how we looked at differentiating T1 was, L5 versus common peroneal nerve neuropathy. Now that you look at his hands like this, can you tell me how will you differentiate a T1 radiculopathy versus ulnar neuropathy? You've seen the hand, you have cross wasting, you have clawing almost. Now, if I just look at the hand, give that as a spot for you to say how will you, if I ask you, is it an ulnar neuropathy or a T1 radiculopathy? How will you differentiate to me? Again, the same way, tell me one muscle which you will test for each, and what will be the sensory symptom, where the distribution will be. Abductor, digitine. Exactly. How is it for, which muscle will you test for the ulnar? Which adductor? You have done it for T1. All the flexors are by the median now. So which flexor will you test for the ulnar now? Exactly. So those two muscles are the ones which you will be testing, and sensory. In a T1, they'll have pain around the shoulder, sometimes extending up to the elbow, whereas in ulnar, it is usually in the little finger, sometimes also involving the part of ring finger. So one muscle and one sensory symptom, you should know the distribution when you are in doubt for a localized neuropathy, local nerve versus that particular radiculopathy.
Just show, look at the gait and tell me how will you. High stepping gait. Now, what are the different high stepping gaits you know of? Or what are the conditions where this high stepping will happen? One is foot drop. Second is? One is foot drop. Second? Second is what? Posterior column. So what is the difference between a foot drop high stepping from a posterior column? One is stamping.
Why do they stamp in posterior column involvement? So they need to hit it hard to perceive that they have landed their foot on the floor, so they need to stamp it hard. So every step they take will come with a loud thud.
Okay, I think we'll stop here. I think I'll just summarize. Whenever you see a peripheral neuropathy, I think two things. When they come with weakness, you need to decide is it upper motor or lower motor. Clear? Don't start your examination or even investigation without knowing what it is. The same way, peripheral neuropathy, what you need to know before you investigate is, you need to do EMG, decide is it demyelination or axon. Without that, please don't go any further, because you will be going the wrong way. Right? The last point. If somebody has peripheral neuropathy, is their lifespan reduced? Most often, no. They live with it, but the lifespan is really not reduced. But they live with the problem. But the lifespan is really not reduced. Okay? Very few things, yes, but most of them, no. Most of them, no. Okay?
And just to add on for the completion part of it, most of these hereditary or inherited neuropathies, patients have more signs rather than symptoms, because these deformities are there from birth or in very early childhood. They are adapted to live with it, so they don't complain. Unlike the other acquired peripheral neuropathies where they have both symptoms, because every side new onset symptoms always immediately complained of. And negative family history does not rule out inherited neuropathies.
Okay, thank you.
Thank you very much. I'm very happy, even though it got prolonged until 6 o'clock, I had the entire crowd holding back.
I kindly request Dr. Emmanuel Bhaskar sir to hand over the memento to Dr. Preetam Wadhwa sir, Professor of Medicine, Srihar. I would also like him to hand over the memento to Swati Murthy ma'am, Associate Professor at Srihar. Thank you all for your patient listening. Hope all of you are immensely benefited from the exhaustive case discussions and interactive sessions, complete with demonstration of the science. Before dispersing with the day, a couple of announcements. One, we request the delegates to make sure to sign the attendance form for the forenoon as well as afternoon sessions. Next, fill up the feedback forms for the workshop as well as for today's session, which have been circulated in the WhatsApp group as Google feedback forms.